Check one. Check hello, hello. एक मिनट 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 ज़्यादा ये लफड़ा चिकन माइक हमने चेंज कर दिया ना। अब आया हेलो हेलो हेलो। हाँ देखो हेलो 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 चेक 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 वन चेक हेलो आ रही है आवाज हेलो मेरी आवाज आ रही आ रही आ रही अच्छा चलिए ठीक है कंट्रोल ही नहीं है क्या
पता नहीं ना आप लोग वाले सबको फोन करके यार दिला क्या है देखो ना नहीं है आप
सब हो गया ना
यूपीएससी कौन लिख सकता है
सब हो गया ना चलिए कुछ खा पी चल रहा हूँ हाँ चालू है गाड़ी ले रहा हूँ
क्या हूँ चालू
इतना तो भाई है आइए भैया चलो
भाई
अंदर भी आ
लगा लेते हैं
अरे यार नहीं चलो खाए वो बहुत ठंडा रहेगा बेटा 11 बजे तक
बढ़िया बढ़िया
चेक हेलो 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 हेलो
यार मैं बदल दिया भाई
आज बदल का भी है यार बहुत कालू इका तो इका वहीं छोड़े जा जाको तो कोई बात तो नहीं है। हाँ बच्चे ही करेंगे या के साथ
आज आवाज ठीक हुई
वहीं लगा
इंटरनेट की वजह से हमको लगा
हेलो 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 ठीक तो है हेलो हेलो चलो माइक्रोफोन टेस्टिंग हेलो 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 नहीं किया यार हेलो 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 हेलो
वही कर रहे हैं
अच्छा नहीं करता कहीं ये सब शैतान चलेंगे हम सब
यार फारूक भाई मेरा
कहाँ है
मैंने दिए हैं
कौन सा हो
मेरे फारूक
नाम तो बताओ
क्या नाम है तो
कहाँ पे है कमरे में
इमरजेंसी
इमरजेंसी को उनको फोन करो
से 2-3 4
हेलो 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 हेलो
बेटा
हेलो
बेटा आ गया वो
माइक देना क्यों कर देना कर देना
फिर 2-3 4
ये माइक होगा तो चेक कर लेना ऐसा लेना वो वाले हेलो 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 काम लगा है अभी नहीं अभी लेके आए चेक वन चेक हेलो हेलो
लैपटॉप लगा तो वो कंप्यूटर से लेके हटा ना वहाँ बैठे लगा
काम करें कुछ करने तो लगा दें
टीचर मेरे रिप्लेस चल रहा है अरे टीचर मैं टीचर अरे टीचर लाइब्रेरी क्या कुछ तो
चेक हेलो 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 चेक वन चेक हेलो हेलो हेलो
ठीक है, मुझे तो सब सेंड में ही नहीं।
सब साल में मिल जाए, सब सबके साल में है, ऐसे तो है साल में। कहाँ जा रहे हैं?
हेलो सुरेंद्र। सुरेंद्र,
टाइम क्या हो गया? आ गया चलो चलो चलो।
देखो बेटा, बदमाशी ना करो, हमको बहुत काम वहां से, नहीं तो भाग के जाना पड़ेगा वहां मुझे।
42 आईडी कार्ड फट नहीं रहता, एडमिट कार्ड है ना यार। एडमिट कार्ड अभी सब पूछता है, आईडी कार्ड कोई नहीं पूछता। मम्मा कहाँ है? बोला था 30 को निकलने को, 45 को निकलने को।
लैपटॉप कनेक्ट कर दिया, करने के बाद टेक्नोलॉजी के कितने हो लास्ट की ये वो कुछ नहीं करना है, आज उसका लेकर नहीं होता है और कंपेयर कर देना। अब बोलो मैं वही आ गया आशीष का।
फोन किए थे, काम बहुत है तुमको। हाँ, क्या मिल जाएगा? कोको अरे कहाँ आ रहे हैं? हाँ, हाँ, पता है वो तो मुझे पता है। ज़्यादा। हाँ, ठीक ठीक ठीक।
और भाग्य में केले केले ले लिया है क्या है
यार खाने में टेक्नीशियन खाएंगे क्या हो गया ये देंगे नहीं तो सर से पता तो बैठते देखा मैं तुमको देखा बहुत मुझे ना अपना कर रहा हूँ नहीं वो ठीक है तू करते रहने दे उससे पता नहीं दस को पॉज कर सेशन नंबर सब लास्ट टॉपिक के लिए भाई कुछ नहीं पूरा नहीं चाहिए एरर भी सर पे चलिए सर चलिए तो इसी भी इधर साइड मिली दोनों अरे सुबह टेक्नीशियन ने बोला थोड़ा ये तो साइड टेक्नीशियन बिल्कुल टेंशन में चल नहीं रहा है टेक्नीशियन में रखने आपके पास चल रहा है क्या हो गया बकवास की बात मत करो काम करना था ये बुला मैंने टेक्नीशियन चेक कर दिया हाँ कैसा हो गया कुछ नहीं लीक कर कनेक्शन से भी प्रॉब्लम हो रही है ये तो आता है दिया आगे उनको उनके तरफ से होते हैं जल्दी ना सर, पता है यहाँ से प्रॉब्लम है तब तो आराम से कंप्यूटर में हो रहा है, वहाँ पे प्रोजेक्टर में हो रहा है। अगर यार वैसे तो प्लीज एक शेयरिंग करते हो ना ये बोलो। इसी को बोलना पूरा होगा, आपका एक आपको कौन देगा शेयरिंग का होगा ना ये वो है शेयरिंग करना है तो मान लीजिए प्रॉब्लम चाहिए तो मैं कुछ भी नहीं किया कुछ नहीं यहाँ पे नहीं यहाँ पे चाहिए ये कनेक्शन है ना हाँ ये सब कल देखते ऐसे ही लगेगा तो इसलिए नहीं है आपके कुछ सब किसी ने नहीं है तब कनेक्शन नहीं हो सकता है कि ये कुछ बस बदल देंगे अंदर बदलेंगे परेशान किसी और जगह पे है तो महाराष्ट्र में सिस्टम कुछ नहीं लैपटॉप बना गया तो अपने लैपटॉप में इशू और इसमें मेरा नहीं बचा कल पूरा इशू भी चल रहा है
इसमें कोई पेनड्राइव कनेक्ट करके देखो कि ये एटलीस्ट ये चल रहा है कि नहीं
आपके पास पेनड्राइव सारे मतलब आई थिंक
पेनड्राइव है फोन कर चल रहा है
निकल लगे तो क्या हो गया यहाँ भी लैपटॉप तो जाना पड़ेगा मैं बताऊंगा कैसे हाँ तब मुझे आपको नहीं पता এটা ছোট নিয়ে নিয়েছি রাখতে হবে এটা ছোট নিয়ে এটা করলে এটা যদি করলে তো প্যাটার্ন নাম শিখতে হচ্ছে
होता नहीं बना हाँ डुप्लीकेट स्क्रीन नहीं डिस्प्ले तक पावर आप नीचे बन गया नहीं ऑन किया होगा हाँ ऑन किए थे आप देखा हाँ वहां से ऑन किया होगा ऑन करके गए स्पीकर हो सकता बस होगा ये भी नहीं करना नहीं की देखो प्लीज कर ये चार्ज कर चलेगा बस आधा काम करी ना, आधा नहीं करना, चालू कर दूँ। सब में रखते हैं, हर जीवन पे करते हैं, ये बस यही लंबे ये कहे सब खड़े हो जाएं तो चला रहे हैं, सारे सब आप ऐसे भारी करें जनरल पर ऐसे करें ये सब खड़े हो जाएंगे। अब आप पहले बताओ उनको क्या करें यार, इसे बोला था कि सबसे खड़े होना है तब चालू कर दो, ये जहाँ घर से था बताऊँ तो देखा हो और जो हाथ पर कौन सा प्यार भारी भी थे, ये कब से चालू कर दिया शुरू ही था। अरे वो नहीं शुरू कहा से किया करना चाहिए, खड़े हो जाते हैं कौन सा साहब वही नेशनल, हाँ वो नहीं चल करो वो आज इसको नहीं देखते ना, क्योंकि उनको ना चक्कर में ना देखो, उनके चक्कर में सब फरवा गया उस समय पड़े हुए हैं। ठीक है जैसे बोला तुरंत चालू करो, बताओ क्या है? अलग को होता है तो समझ सर एक दो सेकंड वेट कर लो, कोई बात नहीं, चलान है सब खड़े हो जाए, वो पूरा खड़ा होना है वही थोड़ा करो, उतना परेशान था उस दिन ना। अब बात धोनी साहब अब इनको कह रहे हैं चूंकि आज ये काला पागल है ऊपर बैठे ये हाल था, साउंड चला रहे थे ये बगल में, हाँ वही माँ साउंड चला रहे थे, लाइट चला मैं ऊपर में बैठा हूँ। ये हाल है क्या करोगे कब एक बताया मुझे बिल्कुल मस्त मैंने कहा तो बैठा उसको नहीं पता कि वो थी कंट्रोल, उसको नहीं पता है कंट्रोल कहाँ से है भाई, उसको पता नहीं इंसान पागल बना। लाइट नहीं बंद तो रही थी कौन सी? पीछे वाली नीचे वाली लाइट नहीं बंद या कुछ नहीं चालू हुआ था। हाँ वो एकदम परेशान हो जा रहा उनकी घर में, वो काम परेशान हो जाते अब एक डॉक्टर अपनी शक्ति की जिम्मेदारी और बंद है किसे किसे बोला वही कुछ कह रहा क्या और वही अच्छा काम के लिए ये लोहानी साहब कहीं हमारे पास काम नहीं है, वो लड़का पढ़ा भी नहीं हो तुम्हें बैठो हम तो देखते हैं नहीं, उनका सर देखो ऐसा है कि वहां जाकर दिखाओ वो सारा चेक ही नहीं करता, अरे कि वो तो सारे पागल हैं, आधे सारे पागल बनाते यहाँ कंप्लेन होती थी मुश्किल नहीं है वो वहां नहीं कर पाते हम पता वही हिसाब से चला दिए हम तो अब कल मैंने चेक किया पूरा बढ़िया, सुबह से फिर चल रहा पर जाओ वो सुबह दोपहर में था कोई मैं चेक नहीं करना जो लेकिन पहले चेक करना और हमारा ये सरस्वती ने मना सकता बाद में
घंटी किससे ले लेना
उनकी कहाँ अभी घंटा वो एक रूम से मिलती रहती है सिंह के बंदे थे मैडम शुरू कर दी और उसके बाद साउंड आधा छूट गो मैडम आगे लेगी अब मैडम आ गया अब बाद में हमसे मैंने कहा क्या करे साउंड यहाँ खुला है ये देखो ऐसे ऐसे दिक्कत हो गई, क्या करें? ये हमारे को लड़का था आकाश, सामने मुख्यमंत्री बैठा, और इससे हमें कहा जाओ वहाँ पे बैटरी करती है, कल बैटरी खत्म होने वाली है। वो कर रहा है, ये कम सो वहां पे बैटरी लेने वाला, चारों तरफ सिक्योरिटी खड़ी हुई, क्या जब सिक्योरिटी नहीं लाऊंगी वो सिक्योरिटी वाले को हमने इशारा करके कि बैटरी लेने आया, बता दिया उसको तो मैंने बैटरी लेने आया, वो मुझे रोकेगा बैटरी, मैं सेट पर धूप जाती इस व्यक्ति को रोकना नहीं, सामान लेने जा रहा क्या कैसे वही काम हम मैंने 4 दिन हाथ पकड़ ले एकदम से और दौड़ चले गया आराम से मैंने कहा जाओ बैटरी निकाल लो जो थोड़े दिन मतलब 4 दिन में पटक दिए ज्यादा ही टिप जमीन बस वो बड़ी वाला ये दौड़ भी कर गया तो मतलब बाद में बहुत बहुत फीलिंग होती है तेरा दिमाग खराब है ये जाओ शुरू का तो बहुत ही मार वीडियो को याद करना बहुत चीज है ना दी जाते हैं दही खिलाता तो ये बन जाते हैं मतलब ये एक बार उड़ी तो मेरे पास बड़ा बैटरी लेके तो बैटरी उसको तुरंत बता दो नहीं दे पाते भी तो होता है वो गए समझने जाते कि हम लोग बोल रहे हैं बात करें नहीं सभी वो क्या बेहतर है इंसान से काम नहीं करने वाला है हाँ? क्या नहीं लगा बहुत कम नहीं होते हैं इससे बहुत बेहतर तो इंसान से काम नहीं करने आलू का वो सवाल देखते हैं हम कॉम्प्लिकेशन काम आपको कम पड़ता है इसको सारे काम डॉक्टर को भी बना देते हैं अरे वही से बैल मान पूरा डिपार्टमेंट अच्छा ना चलो काम नहीं है मुझे लगता है कल सारा दिन इसी पे चला यार नहीं उनमें से रुके रहो सब चाहिए कब मंगा रहे हैं कब मंगा रहे हैं क्या समझ चलना चलना
गैस की ना जो
आवाज सही आ रही है और ये आवाज सही आ रही है अभी कभी गड़बड़ नहीं आती है
my colleagues. Welcome to day 2 of our academic fest. Hope you enjoyed day 1. So now the first case presentation. I'll call up on stage Dr. Jaini, Dr. Siddharth, Dr. Atul, and Dr. Raviraj. Now, Dr. K.D. Yadav sir, Dr. Steven Singh sir, and Dr. Avinash Super sir will lead the session.
हमने कल बाबा
The case will be presented by Dr. Nishi Prasad.
आज बहुत से नींद लग रही। हाँ हेलो क्या रे चलो ठीक ठीक हाँ चलो ठीक ऐसा कैसा चलिए ठीक है दे दिया हाँ मैं कभी बोल रहा हूँ सब बुक दे पोडियम बहन हाँ हाँ पोडियम
68-year female homemaker, resident of Lucknow, came with complaints of pain abdomen for 5 months. Presenting in life of equation was apparently asymptomatic 5 months back when she developed delaying pain in abdomen, which was over right hypochondrium, insidious onset, gradually progressing, non-radiating. It was mild to moderate in intensity, continuous, occasionally required oral analgesia. There is history of appetite and loss of weight present, 8 kgs in 5 months. No history of nausea or vomiting, no history of any fever or jaundice, no history of hematemesis or melena or loose stools, no history of cough, bone pain or headache. Past history, there was no any surgical history, no comorbidities. Family history was not significant. And her personal history, she consumed mixed diet with normal sleep, bowel and bladder habits. There was no any addiction history.
Hello. One of you can summarize what are the key points and what is your differential diagnosis?
68-year female presented with the 3-month history of 5-month history of right upper quadrant pain associated with 5 kgs of weight loss and loss of appetite with no other significant
Oral medications, that's all. Occasional. Nothing more than positive. What comes to your mind? What do you think are the organ involvement and what is the likely pathology? How do you really see this?
right upper quadrant pain in the northern belt here. I will first think of something related to the gallbladder, sir. A gallstone or a carcinoma gallbladder.
Just because this patient is the gallbladder, you already want to jump in that?
Gallstone disease would first come to my mind. Gallstone disease would first come.
Gallstone disease will give rise to what kind of a pain? What is pain typical to the gallstone disease?
Maybe intermittent colicky type of pains.
Related to the food. So is it related to the food? Did he give any history of pain? Why that should come to your first in your? Did history of any cholangitis, fever, cholecystitis? Is it that history is like that?
Could be just biliary colic also, which gets relieved with oral.
Biliary colic. Did he mention the word colic anytime? Then what other organ comes to your mind?
Could be involvement of some lesion in the liver as well, which can cause.
So what liver pathologies in addition to the gallbladder malignancy you said, what comes to your mind?
Hydatid cyst of the liver. Hydatid cyst of the liver.
Hydatid cyst. What made you think hydatid cyst of the liver?
Exhibit.
What made you think hydatid cyst of the liver? Because
The constant pain since last 5 months. No other symptom.
5 kilos weight loss?
Yeah.
How do you explain?
Because of pain, patient might not have adequate oral intake. That is the one possible.
That is explained. That is a very good, significant pain, severe pain.
Yes.
That's why she's affecting her diet. Yes. Anything else?
Liver
Sure.
pathology.
Huh?
Liver pathology can be a malignant or a benign
Malignant
pathology.
or something like that would be keep in mind. So liver is one organ, gallbladder is another organ. Third,
Hepatic fracture of colon. Hepatic fracture of colon.
Hepatic fracture, colonic malignancies.
Yes.
No obstructive symptoms. Is obstruction common on the right side or it is left? I mean, can this remain?
Obstruction is more common on the left side.
Yes, but the pain is not so much usually on this side. Not pain which is required. Most of them are loss of anemia and back pain and all. It's not a very severe pain again. So that is another possibility. What else?
Pancreas, head of pancreas.
Head of
Less likely
pancreas.
because it is right upper quadrant, but head of pancreas.
Back pain, yes,
Weight
without
gain
jaundice.
with
But
loss of appetite.
we have to think, we can keep in mind, but always no jaundice. Because head of pancreas without jaundice, not so common, but can be there incident. So yes, sometimes not so common. So these are few diagnoses you will keep in mind. So one thing is very clear that patient has a 5 months history, loss of 5 kilos of weight, short history, and 64-year coming from this area. So you will keep all this in mind. Anything else?
So once this type of history is given, would you like to ask something more to include in your history and to support your diagnosis or exclude some important points? Something coming to your mind. There is a very short history that only 5 month continuous pain.
Any change in the character of pain? Any change in the
that had not been described. It means it is not there.
Pain in detail. Pain in detail needs to be described. Relation to food, aggravating, relieving factors
Get
need to
more
be
pain in detail,
described.
relating to the back, relation to the food, whether it is aggravating, relieving factors.
So it's important when this type of history is given. It is only very small history, and the history is only a loss of. More important when you said that there is a history of loss of weight, that may be because of the pain, but at the same time you see, is there history of loss of hepatitis? So there is a history of loss of appetite. If I am at your place, I would like to know more about is there preceding pain? Only keep in preceding for many years. Is there some history suggestive of that type of pain which has gone continuous now? Is there any history suggestive? Because if you are thinking about, as you said in the beginning, that I am thinking about gallbladder pathology. So these are the things. When you say liver, what liver pathology? Hydrated cyst should not come to your mind because mostly it is incidentally. Pain is not like this, and there should not be loss of appetite and weight until unless you have hydrated cachexia, sometime in Ajay described. Then there should be recurrent pain or some sort of biliary communication. Otherwise, hydrated cyst should not have. So once you are saying something, you should think what I am going to say should not have a counter question immediately. Hydrated should not be examined. Once you are making a diagnosis of malignancy based on the significant loss of weight and appetite, then you cannot bring one benign disease which can be years together without symptom. So liver pathology, what are other liver things which can be included in the diagnosis?
Liver tumors, what all history you want other
Pruritus, an history of pruritus, which is preceding.
History of blood transfusions, any exposure, risk factors for exposure.
alcohol intake and all that.
Alcohol addiction.
History of jaundice early. There may be there history of jaundice 20 years back. So I am at your place. I would like to see whether he has some history of jaundice. Is there any type of hepatitis which can produce some swell in the liver without preceding cirrhotic liver?
Hepatitis B.
So why should not be asked for? Then counter question would be, is pain a presentation of the liver S? These are the way we exclude and include in the important points in your differential diagnosis. So you cannot pinpoint with this small history that I am talking about gallbladder cancer until unless you try to include these differentials and then exclude one by the history.
Actually, it's a very tricky thing, Many times examiner goes on asking you to ask for differential diagnosis, and you are fixed in your mind about one diagnosis. But just go out and think, because everything you speak, like say when I ask you to see, you just came out with hydrated cyst, but really see it doesn't fit into this kind of an history pattern at all. And then you are exposed to many other questions for no reason. So I think that critical thinking has to come in your mind quickly. What fits into this? And that's the trick of presentation. Let's go ahead and find out.
General examination, patient was conscious, cooperative, oriented. Her BMI was 24 points with ECOG 0. Threshold time was 30 seconds. There was no pallor, icterus lymphadenopathy. Her vitals are stable. On local examination, per abdomen inspection, abdomen was flat with umbilical central position and inverted. All quadrants moved correspondingly with rest. There was no visible scar, peristalsis, signs of recurrence of mass. Vaginal orifice and ventrally appears normal. Abdomen palpation, abdomen was soft, non-tender. There was no mass palpable. Liver and spleen are not palpable. Hernial orifice and extensor normal. Percussion, liver dullness, upper border palpable at 50 intercostal space with a liver span of 13 centimeters. Flanks are tympanic node. On auscultation, normal bowel sounds were heard. On DRE, gloves stained with colic stools, there was no any deposits. Other system respiratory severe illness was known.
So probably it has not contributed anything. So you have stuck with your first diagnosis. Does the word Bihar click anything to your mind?
Gangetic planes.
Gangetic plain. So do you always think patient coming from Bihar with the right type of region, 5 months pain, 5 months of loss of 5 kilos of lost weight, we should think about gallbladder malignancies?
We should keep it in the on
Set the
priority.
wrong- Anyway, so what will you do now?
Sonography.
Your history examination has not contributed anything to you. So your history differential diagnosis remains as it is. So what would you like to do?
I would like to do 2 sets of investigations. One for the general assessment, that is complete blood picture, liver function test, renal function test, and coagulation profile, as well as an ultrasound abdomen.
So you have ultrasound.
Liver was 12 centimeters with normal echo texture. There was no IHBRD. Gallbladder diffuse intramural thickening with ill-defined outline. Echogenic lesion showing vascularity on the Doppler. Multiple calcula was noted. There was a loss of interface between the gallbladder and liver. CBD was 6 mm. Pancreas was absolute. There was no any treatment.
What is your interpretation of these findings?
Do you have that adequate information, or do you want more information on this particular?
Any enlarged nodes are there? I would like to know.
Status of nodes. What else?
Any other liver lesions seen?
Yes. So what about this? Are you happy with only one diffuse intramural thickening? What are the things you expect in a gallbladder when you are first diagnosis gallbladder malignancy on ultrasound?
Mass lesion or irregular thickening of the mucosal line.
So thickening which is intramural. What more you want in the thickening? Diffuse thickening. It's a diffuse thickening.
So the wall thickness and the mucosal hyperechoic pattern.
So these are the only one important point, that there is intramural thickening diffuse, that is the suggestive of the malignancy. What are the important points in terms of when we are talking about thinking about malignancy to differentiate from other chronic?
Whether any layered appearance is there, whether the layers are seen, the distinct interface.
That is very important. And what about the size of the thickening?
at what particular centimeter or something you say that this particular patient is more chances of having
More than 1 centimeter technique.
more than one is too
Then
much.
3 mm.
3 mm, more than 3 mm.
More than 3 mm.
3 mm is
First of all of you are confused about 3 mm, 4 mm.
What is the normal?
3 mm. 3 mm.
3 to 4 mm, maybe. Yeah.
And have you read about GB rates?
Yes.
Where this is picture fitted?
Four.
Loss of
Loss of
interface.
Loss of interface.
Four. Maybe not four.
So one is that focal thickening or diffuse thickening, then size of the thickening, then very important that there is a plane between the gallbladder and liver is ill-defined, and then layering of that is what is in the gallbladder rats, GB rats, which are defined by our colleague in PGI, and size of the thickening also. So symmetrical thickening, is it symmetrical or asymmetrical thickening?
Asymmetrical.
So enhancing or not enhancing, that these are the very, very important points. Then associated stone disease. So you should know all these important points. So you should say that I want to see all these things, though it's not seen in this. Why they have done Doppler?
What is the meaning of echogenic lesion showing vascularity on Doppler? What does it really tell you? Is it very significant? You make a decisional change, or it just confirms that this could be malignancy?
So it just confirms that it is more likely to be malignant, well vascularized.
It's just a supportive thing. It doesn't really, so you need much more differential information which you really need.
So there is a most of the time the peripheral radiologist in the periphery who are not very much used to diagnosing gallbladder, they will rise. There is a sludge in the gallbladder. There is a sludge in the gallbladder with the stone disease and all this history, and then people go and operate. So why this Doppler had been graduated? Can sludge have a increased vascularity? So if there is a lesion which is seen on these things, and one
It's a lesion, it's not a sludge. That's what he wants.
then your vascularity is raised, it means it is pointing more toward the gallbladder cancer. In spite of all these things, still we can have something which may not be malignancy, but we have 2-3 differentials which are very difficult to differentiate only on ultrasound. But these are the supportive features.
So after ultrasound, how you will proceed now? What will be the next investigation?
Like to see the blood investigations which were.
Do you have that investigation?
So one more thing I would like to emphasize. Regularly in Monday clinics, we are requesting all of you not to talk about blood investigation. You say I would like to do this investigation is required, not the blood. Blood has too many things. So you are wasting your time. For one answer, you are giving 2 questions we have to ask. What blood investigation? You can say this one investigation I will. So what investigation?
So hemogram, renal function test, liver function test, and the coagulation.
That's all. Kidney don't.
She said kidney.
Kidney said.
There is a mild anemia, sir, and the coagulation profile appears normal. The rest of the parameters are.
Sure.
Why do you think there should be anemia in a gallbladder? You are thinking about gallbladder malignancy. Is it normal manifestation, or there may be something else according to the mind?
So it's not a normal manifestation. Involvement of duodenum and occult bleed after involvement of duodenum.
So, bleed which is not manifesting. So, occult bleed might be one of duodenal infiltration. One should always keep in mind, especially funded tumors, they sit on the duodenum second part and they can infiltrate by old age. So, very good answer, because this is the patient has nourishment is not that bad. If you see the BMI. It might not be there, but we should think like this only.
So renal function test appears normal.
Okay, next.
alkaline phosphatase is slightly elevated. Rest of the parameters, ALT and AST are also mildly elevated.
Albumin is on the lower side.
How will you interpret this?
There is loss of interface with the liver. We are not exactly sure what involvement is there with the liver, and also the CBD, whether there is any involvement.
Bilirubin seems to be normal.
Bilirubin is not.
And not that low in a country like India. So it is on the lower side, but with 3.1, we cannot say it's very significantly low. Obviously, little bit of higher SGOT and PT. Alkaline phosphatase is not that significant. Unless you do some iso and chains also support with GD3 and 5. What do you think has happened? Why this he's not taking only the loss of
Has lost weight.
We have not taken this thing, but can that affect SGOT and PT?
Not sure, sir.
Would you consider this SGPT significant? That's what he's saying.
Sir, it may not be.
So there are borderline grades, but they are not so significant. So that's what we have to keep in mind. So some process is in progress, but it is not really significant at this stage to say there is an obstruction or there is a cholangitis. We are not able to see. And as he rightly said, 3.1 albumin in India, we see many patients, It is lower, maybe because of loss of weight, loss of appetite, or whatever it is she has. But it is on the lower side, but it is not so low to really say that there is some liver function deficiency. So what will you do next? Last person on this side, what will you do next? Let me rotate you and guide you because you are not really taking turns. So let me give you
Contrast enhanced CT scan.
What are you looking in a CT scan?
Uh,
I think yesterday there were 3 nice talks on liver, pancreas, and rectum. I think there should be one more on gallbladder also. Anyway, what are you looking on a CT scan? Say they also done markers, but you did not say that they wanted markers. Would you do markers before in these patients with blood investigations?
yes, sir. I'd like to do, sir.
So what markers?
CEA and CA19.
So you have just show them. Please show before you.
CA99 is 42.4. It is elevated, and CEA is 3.75.
So again, very borderline.
Very important.
How does they help you?
They are just supportive, sir. They are not. We cannot.
They have any diagnostic, no?
No, sir. Only they are prognostic and supportive role.
So CA has a role in helping in diagnosis, sir, in patients with gallstone disease where we're suspecting gallbladder cancer.
Which study you have this? Where you have
What kind of a diagnostic will vary? You 3 to 3.75 will it be diagnostic?
So when it is very raised at that.
If it was 10, then you would diagnose CFGB.
So supportive to the.
No, it's in exams we don't cannot guess. If you know, if you read some important articles which suggest that CA has a very significant role in supporting the diagnosis, then you can say, first of all, from where CA is secreted. Which mucosa CA is secreted?
Generally columnar epithelium.
Colonic epithelium secretes C.
Colonic.
Colonic intestinal cannot secrete. There is significant group of cells which secrete. Sometimes you are seeing in CA in so many things. So is that cell mucosa present in gallbladder? So if all commoners agree, then even carcinoma, stomach carcinoma, CBD, every commoner will have raised single level. That is not so. So it's very important when it is asked that which study you have read. If you have read, this textbook says this particular study published, which is saying not that one particular somebody, some case. Then you can say half-heartedly, you are also not confident in saying. Half-heartedly it doesn't work in India.
Go to CT scan. Would you like to read, one of you?
This is a non-contrast CT scan phase with axial cuts. There are no calcifications in the liver or pancreas. Can you put on? There is no ascites. Arterial piece.
Can you see some, you said that there is no calcification. When calcification, it is gallbladder links.
In porcelain gallbladder in the pre-malignant condition.
One of the aspects of the associated.
Yes. Yes.
These are the small things that you are reading the CT scan. You can think about that. What is the role of play in scan in the
Yes. This is the portal venous phase of the. I'm showing axial cuts of CT imaging. Left. There is a.
Just wait there.
Yeah.
Would you like to read this?
An asymmetrical wall thickening in the gallbladder, including the fundus and the body of GB. Can you go up? There is some loss of fat planes with the D1, and can you go down? Go up. Go up. Yeah. The CBD appears mildly prominent. CBD. Yes, sir. Duodenum. Yes.
How is the age?
There is some infiltration of liver as well. Yes, sir. Enhancing. Heterogeneously enhancing thickening is there.
Is enhancing.
Yes.
Irregularity, interference, I mean, it is already infiltrating into the part of the liver, the whole thing said, but periphery is enhancing. And then, as you said, duodenum is being really dark and thickening is prominent. Anything else you would like to really say? Are there any lymph nodes?
Lymph nodes. Not very. There is a para-aortic node, interaortic node is seen, but it is not significantly enlarged. Can you go up?
Why it is not significant? Perhaps you have any idea of which lymph nodes are suspicious on CT scan?
Indirectly.
More than.
Doctors are asking what are the characteristics of features of the lymph nodes. involved by the malignant. There are some characteristics, criteria to expect.
Side more than one side.
One side.
More circular in shape, loss of fatty hilum, more circular shape, and
Lots of fatty acids seen this.
not in here.
Cutouts. What have happened in the center of the
Necrosis.
So it's more important, I think, rather than what it's if suppose this city says that duodenum seems to be involved, we'll take it for granted. Which are better, more sensitive and specific to look for by the CT scan, which are important structures, lymph node, thickening, enhancement, gallbladder, vascular structures. But when it comes to adjacent organ involved, it's a sensitivity and specificity good gallbladder and liver
surrounding.
and common bile involvement with in the abdomen. And vascular structures are very. What about vascular? Can vessels be? If you did not ask for the photo, you can ask. When you are not having in your head, then you can ask. I want to see that. These are the important reasons.
Can you go? Deep, right hepatic arteries, please, sir.
Did you see left hepatic?
Left hepatic is right, left, both appear to be free, rising from the common hepatic and further rising from the celiac.
Are you seeing any lymph node close to the ciliary? Or gallbladder cancer? These are the most important things. Are you seeing anything?
It is different lymph nodes. So you are able to see.
Retroportal and suspicious para-aortic.
Significant retroportal.
Yeah.
Retrobank.
So if you see properly, you would be able to see all these structures more accurately than the delivery.
See, when you're describing, make a habit of describing in a particular way and use it, like you say that, okay, so the gallbladder, size, wall, thickening, enhanced wall, surrounding structures, interface between the liver, are there any calcifications, any stones, look at overall it is same. From that, then later on, you come to the surrounding arterial invasions, lymph nodes, surrounding organs. They keep a pattern in your mind, then you don't really serve like this. So make a habit, go into the radiology department, take 10 cities and describe them in 1 minute or 2 minutes. Make that a habit. Once you start reversing like this, then you don't have to like this. Otherwise, what happened? We had to waste almost about 10 minutes to get the findings from you, which you could have said in 1 minute. And that wastes your examination time quite a bit. So see how we can make it. So now we know, if you tell me, what do you think is the stage of this disease already happened?
T4A now. T4A, sir.
T4.
So T3.
T3 and
N plus likely N2.
N plus the notes in the row. portal and all those lymph nodes are set. What about, and then the other major metastasis is at least not seen. We can say, at least on a CT scan, we feel there's an. So with this kind of a lesion, what you have in mind? Anything else you want to have? Any other thing you want to show us on a CT scan? No. So what will you do now next?
I'd like to do an endoscopic ultrasound with and assess the para-aortic node, if possible, do an FNAC.
On the histopathological diagnosis?
Well, since I'm suspecting a para-aortic node involvement, I would like to get an FNAC from the node.
Any other engine also you want to do before?
So we can do a PET CT. That would, if there is significant uptake, it would point towards a malignant involvement.
Given a chance, if you have everything, we go for endoscopic ultrasound first, or you will go for the PET CT. Everything is going back to the patient or to the nation. If you are working in PGI, SGPGI, it is going to cost to the patient. If you are working in private, it is going to cost to the patient. So you cannot put all everything battery together and say I will do everything.
So PET CT.
So CT scan, on CT scan, out of one group of lymph nodes which you saw, how much confident you were that this looks like malignancy? You said it's not, all characters are not seen, but obviously
Suggestion.
Suspicion.
Some suspicion is encouraged. His sign is not that big, but it is sounded.
I agree. I am going to say out of one group of lymph node is involved, then obviously both for other therapy at that particular time. So US would be one of the investigation, but before that, want to do something, I state will go for US and that may be others.
You all others agree with her, or do you have a different opinion?
PET CT. PET CT. I agree with it.
You agree with PET scan or you agree with the US?
I would like to do a PET scan, non-invasive before any invasive.
Any data that supports that is better, which will change the treatment plan.
PET CT upstages the disease by around 30% of the
Listen to the question. That's how I got any data. Look बैठे. No, you should know what is are there some publications supporting PET scan? एक दूसरे को देख के रिले रेस की तरह हाँ ना कर रहे भाई आपने बोला है यू हैव रेड एनी publication PET scan आप स्टेजिंग देखने पर
I don't remember the publication.
Confidence नहीं आएगा.
It up stages by roughly around 30% of patients, especially when this locally advanced, if the dose are positive, to level up stage in at least 30% of patients. If it was no loads, early stage, the check will take 5 to 30%.
What is important for that service saying is very important to the loss of appetite and weight loss. It's very important in gallbladder cancer. Whatever report we have got operated, which has come later to be xantho or chronic cholecystitis after doing extended cooling, where the people who had only radiological, all the radiology we are doing suggestive of CA gallbladder, but patient had no typical presentation of the gallbladder, any cancer. Aggressive cancer, it has, but once there is a significant weight loss of weight and appetite, that should also we should keep in the mind when we are investigating and managing those patients. So immediately, Dr. Shivendra is saying, if publication data, we had one abstract, all these things have supported that 25%, 20% of the study that then avoiding unnecessary clotting, not only abdominal. And in US, we are seeing only abdominal, but I think suppose something comes in the lung, we have found bone metastasis also. So something come in supraclavicular lymph node, which is not present in the classical, not palpable. So all these things have been described in gallbladder cancer. So avoiding unnecessary nephrotic is also a target, rather than only. So with PET scan, that's why PET scan has come in a big way in a CAD.
Can I, the commission of auditors, could auditors came to this discussion, this is the CT scan, why do you think it's a malignancy?
Yes.
But again, PET scan, I know the reports are very, very convincing. But if you consider alternative diagnosis, then PET scan, interpretation, those questions will arise once discussion starts in those lines. So I think it's a good idea to clarify this with your moderator, what you think about it and what they think about it.
So there is loss of. So since there is loss of involvement of the liver, loss of fat planes with the liver, as well as a significant asymmetrical thickening of the gallbladder, that is why we're thinking of malignancies.
So what is it about alternative diagnosis?
There is even
Large lymph node present, irregular thickening, involvement of the wall. That's what we think about malignancy. Otherwise, if it was little different, would have thought about the very chronic prostatic example.
So, and very significant, such a pointed question is asked. I would go to the ultrasound to start with the ultrasound finding. Ultrasound gets suggested, and then come to the CT scan. You only told only irregular thickening, which is enhancing, which is more than about, seems to be more than about 1 centimeter, which is irregular, which is enhancing. Then there is a good huge lymph node involved in the periportal area, which is behind the common hepatic artery, and then you are seeing all these pictures, and then you go back and think about the patient history also. So all these quantities taken together are quantities toward the malignancy. So this would be a more appropriate answer. In fact, our colleague Dr. Pankaj Sinha sometimes is more happy diagnosing CA-GB once there is a difference of opinion on GB rates rather than only CT scan. The CT scan still we are not able to differentiate with the Jantho. Many times we are stuck up Jantho, but Jantho also will not have the same type of loss of appetite. So clinical history taking and examination has always to be kept in. So lymph node is also huge lymph node, which is characteristic of the malignancy.
You have any point in Rajni you want to clarify?
2 minutes down the line, that question will arise when you start asking about section.
Yeah, okay.
Biopsy tool, having an interval biopsy. Those questions of alternative diagnosis start arising then.
Yes.
Initially, we would think that okay, this looks like malignancy, and I totally agree with that. But the issue when you ask them about treatment and suggestion that you cannot operate it upfront, and we think
exactly, then you need a biopsy.
Biopsy, you may not come across that easily in some scenarios where you are inconclusive report. Then the operative diagnosis scenario starts playing in your mind.
See, many times what you said, endosonographic biopsy of a lymph node is technically what you said is done, but it's tricky many times. You create a really lymph node and then go into that biopsy, and many times it may come out that there might have been not. That becomes a problem. So now the next question is, what are you really going to do? Now that you have done, any other more investigations you want to do in this case?
CT first.
PET scan. Do you have PET scan? No. So it is restricted to this. There are few lymph nodes which are showing some uptake. There is no other uptake in the body. So what will you do next?
We are not. Did you try to chest window to see the chest window? No,
if you are not going to do a PET scan, do CT
test. Yes. And even plain X-ray test also. So all these things are important in an component of it. Then at least CT, chest, abdomen, pelvis is must in a gallbladder CA patient.
So what will you do next now? Presume that the CT chest and or the PET scan does not show any lesion in the chest or clavicular or anywhere else, and it is restricted to the abdomen like this. What will you do next?
So there is a suspected duodenal involvement locally advanced. I would still like to do an upper GI endoscopy with an EOS and biopsy, because in such cases we can.
Then you are combining two things. Upper GI endoscopy you are going to do with the further duodenal involvement, or you are going to do a biopsy.
So upper GI endoscopy for the duodenal involvement to look for.
Same endoscopy, not you to see the duodenum and do a biopsy and EOS. So which one you want?
She want in the same setting all these things. Come to endoscopy. If the abdomen is normal, then endoscopy countries.
Ultrasound biopsies.
From what all he wants. No endoscopist will do a US without doing the endoscopy at the same sitting and looking at the track and then putting a US scope in. That's the standard for all US. Actually, I wanted to answer. I'm not just trying to find out what we know, what we don't know. Why you need a buyer? You need to change your plan of management.
So if there is duodenal involvement, significant lymphadenopathy, we can consider for neoadjuvant treatment in this.
I'm not very happy with your statement of duodenal involvement. The duodenum in a negative contrast is the field and just touching the duodenum sometimes is not very significant on this CT scan. So in the report, CT report suggests that duodenum is significantly involved. Have you the report?
TPCT shows a partially distended and elephant asymmetrical heterogeneous enhancing thickening in the body, maximum thickness of 7 mm, with fat planes with the liver maintained, medially abutting D2 with maintained flat planes.
Like that,
this thing is involved. So what would you think? You do upfront surgery in this or you go for neoadjuvant? You want neoadjuvant, you need a biopsy.
No other indication for doing endoscopic ultrasound in this patient.
So para-aortic lymph node.
The suspicious aortic lymph node out there. Do you want to know prove that?
Yes, sir.
Better to do the word interact your paradigm.
Yeah.
I will learn about classification of paradigmatic nodes. How you label those?
So 16A1, A2, B1 and B2.
What is 16A1?
So from the diaphragm to the origin of the celiac artery. Then 16A2 would be from the celiac artery to the. So 16A2 would be celiac artery to the renal artery.
Lower border of the left.
So 16B1 would be lower border of the left, the renal vein to the bifurcation of the aorta.
Aortic level is 16B.
16B1, so.
Above is A1 and A2, both on the left and right side. And B1 is on the right side of the aorta and B2 is on the left side. Does endoscopic ultrasound was done? What else do you, if you are sending for US, you want to do the biopsy from the GP also, or what will be your restriction to the endoscopes? That will all depend on what is your plan.
Okay. I'll give you a scenario. You do endoscopic ultrasound, the lymph nodes come negative, they done also the gallbladder and the retroportal lymph node which has come positive, but auto this is negative. What will you do? It confirms your diagnosis. But there are no autocaval lymph nodes are not involved. Duodenum is not likely to be involved. Would you now do surgery or would you still like to go into the
So in that case, I would like to plan for surgery.
What kind of surgery?
So staging laparoscopy, followed by if there is no spread, but no peritoneal or omental spread, then followed by local assessment for resectability on laparotomy, and then an extended cholecystectomy with lymphadenectomy.
So tell me, once you say that you want to do, you want and what kind of a lymph node clearance you will do? Would you really elaborate more on that? On the shortage of time, I would like to say.
So on staging laparoscopy, I'm looking for any peri hepatic artery piled up, portal vein, the retroportal, the station 8 lymph node, and the retropancreatic lymph nodes are regional.
But in AGC, it's not much of retropancreatic. We usually take retropancreatic as regional, but usually in the AGCC, the retropancreatic is not taken as regional.
So suppose you are going there and the celiac group of lymph node is present. What are they? Is it possible or no?
It is possible, sir.
Then
So it is considered metastatic in carcinoma gallbladder.
is there something like right and left? No, it's sometimes very difficult to differentiate.
On the right
On
side,
the right, we can still
consider regional.
consider regional.
What about systemic margin? Take this.
Yes, sir.
All these
No,
things have to be systemic margin.
has to be sent for frozen section. It will give us an indication for its bile duct excision, extrahepatic bile duct excision. First will be aortocaval node sampling, sent for frozen. If it is positive, it is considered metastatic disease. Then we should not proceed with the surgery.
Any other questions? Anybody else?
Any suggestion? Any?
Our protocol is to do all PET scan in all patients because it changes management to 20%. And we have published our study based on that, even though it is still more than that PET scan as an all staging workup for CETP. Though if there is no locally advanced disease, the change in management plan is only 15%. If it is lymph node positive, it is around 27% change in management plan.
I said in case the incidental gallbladder cancer, the role of PET.
The incidental gallbladder cancer, again, the role is there, but problem is at what time you are going to do. If a patient has come within 1 month, lot of artifacts will be there because of your post-surgery. But still, it is not recommended for immediate post-operative because a lot of artifacts will be there and interpretation will be lost. If a patient has come after 1 month, you can still do a PET scan to rule out a distant mesh.
The other view would be that you do PET sheeting, you can also say that it should be done in cases like all petty, we can afford petty. Whether man we be that if the patient was got age to a patient has got imaging character of advanced with the plate in these patients doing PET sheeting, that can be according to the tissue quality. Similarly, incidental case, PET sheeting sometimes is considered higher because you do not know whether there was any spillage if the findings are not there. In that also the PET sheeting role is slightly different. This is the other view which can be taken.
Well, always may have a chance of creating doubt in your mind that may not have resectability. Even the patient may have a resectability. You all gone through the gastric test, there may be implementing.
So I think what we use is when you are doing a PET scan for incidental CDB, don't see for the port side light ups and all. You should look for areas which are distant, which can you change. If there is a aortocaval lymph node is seen on PET scan, which is better left supraclavicular, then definitely it is useful. But only hypermetabolic activity is there in the port site area or scar area, then those don't take that as positive.
Data for PET-CT incidental is not mature.
Yes.
What is there? For looking advanced only,
I think
it's justified.
I think there is one data put TMS which have shown that incidental also it should be done. But the problem was in their patients, the median time from incidental
More than 1 month. Before 1 month, it is not very useful. After 1 month, you can really use it. Yes.
So our 67 patient incidental patient data, we are been able to operate only 30% of the patient. Rest of the patient either they were metastatic Either they came with the metastatic disease, or when we dissected, they were metastatic. And when we went ahead and saw there are all the reports, there are so many patients who already had significant findings suggestive of carcinoma gallbladder. Still, they were either because of the ignorance or because of some other factors, they were operated by laparoscope or by these things. So it's very, very important for incidental in our country to look into different scenario. It's not the same. So though we tried in this thing, we have published in surgical oncology and this thing group, and this is very, very highlighting the fact that incidental is not the same. What we find incidental, what institutional incidental, hardly we have any incidental in our institute. I had only 2 patients in whom my life. But when you go to the periphery patient coming to us, there is a different scenario. So all these factors should be taken into account in our setup.
So for this patient, only from the USG, can you say that I go for testicle, or would it be right to say please say this that I go for testicle rather than a CT cause?
As CT first or PET CT, that is a very difficult question because mostly people go CT first, but if there is a ultrasound suggestive, but everybody is going CT first and based on the CT finding petition. Yeah.
Yeah. And in fact, you would say CT chest and abdomen.
How to manage patient suspect second that you said aortocable lymph node for sapling, it comes as positive, otherwise the patient is young and it's a resectable need. And third is with regards to port site excision, do you remove all the port sites or only one purely for these students?
So, answering your first question, if you are putting a laparoscope and suspect strongly based on the what factors, sometimes there are some vessels creeping. Okay. So just we are narrowing down. If it is looking like significantly that it is carcinoma gallbladder. So if you are expert in doing carcinoma gallbladder in laparoscope, as people are doing, you can do it or convert and do proper extended polycystectomy. There is no harm in doing that. And second question would be, sir, we are not looking for histopathological diagnosis in that area. When you open the patient and your clinical examination is very important. You palpate the gallbladder, and if you are finding the mass lesion, there is ultrasound which suggests the thickening or all those things. Anticipated can be done, and that is anticipatory, and you send the gallbladder. And second question is about what was? Yeah.
Anticipatory extended polycystectomy.
I think our only issue in this approach is in private sector or medical legal, you have not taken consent for
And
any radical work. Anticipated and patient. If your consent is there, then you can proceed, otherwise. In our scenario, we don't go with the other one. Other scenario is that you suspect CATD on the laparoscopy because you have some nodule somewhere that you're not very sure. Those scenarios, much better to leave the patient, come back with the CT scan later and then decide what to do about it. So yeah, there are two schools of thought. That's why I brought this question up. Is either you take a distant any lymph nodes, or then you take a biopsy and leave the patient, restage it and do it at a later date, or you convert it and do it into anticipated extended polycystectomy. But the question is of consent, especially in the private sector.
So Dr. Chetan, there would be one more important factor when it is too advanced on the laparoscope. There most probably ultrasound will suggest something. It cannot be that ultrasound is absolutely normal and you are finding. Some suggestion would be there, either it is ignored or
Suppose it's they thought that I could remove, and now you will end up in a situation.
So second important thing is that like I had one incident. I cut the section and there was some nodule thickened. I went and disturbed and went and had a meeting with the patient. So you can have this also.
The only problem with that approach is that consent is valid only from the patient.
Yes, that is why for legal purposes this can be raised, but in our country usually if you go to this section, that is signed.
Dr. Rajneesh, another message we should send the students is that one should not take a biopsy from the gallbladder mass per se. It's not a good idea.
That's not a good idea. Extended.
Also, when patient have a GV mass at the neck, when you have the mass at the fundus, hepatic, anhepatic, you can do that with a liver dissection, given cystic margin filtration or 1 centimeter, 2 centimeter, when taking with the laparoscopy also. But when you have a mass, what's the you require?
So most of the time, your this anticipatory comes when you have only thickening. You are not having this doubt when you have a mass lesion.
Yeah, no, there may be the problem, taking way up to reaching up to the.
See, you are operating patient
I think by that, it's all, Rajneesh, you can divide into whether you have a lesion which are going in towards metastatic side, that will be there, you close, come back, you take a biopsy, you complete your workup. If you find a lesion which is resectable, and you on an ultrasound, you did not find anything, it was a CHGP or it was a thick wall gallbladder, on diagnostic laparoscopy, depending upon what the handling of the gallbladder should be minimum in these cases. You should not try to first fiddle with the gallbladder, do perforation and then open and do the thing. So that should be in your mind. And whether it is involving the neck or whether it is involving the body or fundus, it all depends upon the additional factors of your LFT and everything, whether you're going to go in the same sitting or not.
No,
it is one scenario. The other scenario is the consent of the patient. If that is not there in a private center, you come
So
out.
basically, there are two options. Either you do an anticipated extended cholecystectomy, you take a distant either lymph node or whatever this and restage it and do it at a later stage. Second question. Second question is
one more important point I would like to add. If there is so much confusion, you can do intraoperative ultrasound. You call your friend and he will do it. Ultrasound machine is available in the department. So this will solve most of the problem. So this is very important point in these patients. And second question was your report.
That's no. Second question is that so this positive patient is young and the resectable. How will you manage?
So I will close and go and so will not operate.
Another scenario is yes, most of the things we have to follow this. Sometimes what sir is saying that if there is a CHGP, the mass is resectable, on table you find a positive lymph node because the role of chemotherapy is not very established. So telling the patient, if you want to resect with that wedge and do the lymphadenectomy, that is the scenario which might come up as it has collected. That is what is being hinted. However, in exam, obviously, you should be going that beforehand, you give the chemotherapy, see the biology of the lesion and then go.
The exam answer should be, as sir said, you should close and give a neoadjuvant chemotherapy.
So again,
yes. That is what is far larger than the data which you still don't know if you are the standard of the care and this should be.
can you please elaborate a bit on the indications of neoadjuvant? What scenarios will you use neoadjuvant?
I think all patients more than T3, node positive, all and the small IAC lymph node suspicious, all these patients should be taken up for neoadjuvant chemotherapy. But that is all protocol. There is no standard guidelines recommendation because data has not evolved much.
Sir,
More data needs to be published.
Sir, any node positive, sir?
Any node positive, because this all extrapolation is there for mostly coming from intrahepatic cholangio, where all the data is moved to node positive is there, then the prognosis is very worse. So give chemotherapy so that you select good value treatment. Locally aggressive.
There is no protocol available. Institutional practices are different at
different places.
At many places, you will operate upfront because there is no significant or good data to support neoadjuvant treatment in each form. And people feel like we may lose that opportunity of resection.
I think there is data, there is a lot of data, but I think there is no level one also good data.
It is the thing. There is a definition called borderline incidental gallbladder cancer. which has been proposed by the Tata Group, but that also is running into controversies. But for a basic fundamental way of looking at it is what Dr. Shivendra said, that you're looking at T3 plus tumors and you're looking at N1 disease, no matter wherever. And these are the situations where if you have the luxury of diagnosing the lymph node positive disease beforehand, you should go ahead with that and then treat them with the chemotherapy, neoadjuvant protocols, whatever is required, and then reassess.
Suppose in this patient on PET CT we see uptake in the nodes, should we go for neoadjuvant? Should we say in exams and
You don't say it's a neoadjuvant, you say that I'm giving chemotherapy. If the aortocaval node disappears.
So the rationale is that the rationale of neoadjuvant is that you will get the idea about the tumor biology.
No. What question is, when you say neoadjuvant, you are committing for surgery. So you answer it like that, we'll give chemotherapy, see the response, and then we'll decide. In examination, you should answer that. Same.
Most of the festival which means that people are not putting back. So the patient will come in. Now we apply only side 1, 2. And 99% we are talking to the surgeons also, we have done the gallbladder. Most of them they are not putting back and they are not they are using epigastric port only for the removal of the gallbladder. So it's important to remove, though there is that empty understanding, there is one thing that you don't
exercise all the word.
Basically, it is only for prognostication and you exercise only. Move the port, even though it's not coming in your incision. Is that the case? Or it's coming in your incision, therefore you move it?
No, that every time comes in the incision, but only that you have a different approach in sinus.
I removed for the umbilical cord. Would you remove the umbilical cord?
No, remove umbilical cord is very difficult. I have not found a single person. But that port should, let me tell you this. We have 10 patients right now where we have found that even 12 years, after 12 years, one patient had an epigastric port metastasis. So this is very important that the gallbladder from where port is removed, this is good should be removed.
I think your point is well taken, Rajneesh. Many times when we are doing, we take all the ports at the time of incision.
Standards.
But
we have also stopped doing stopped excision for port excision for all patients. Because of data, we have not found for last 7 years any difference till now.
Yeah, sure.
Thank you, sir.
Thank you so much.
Conclude this. क्या करके चले गए हम क्या करते हो तो कोई लड़का मोबाइल नहीं है क्या मतलब now I'll call upon on stage Dr. Uchit Bhaskar, Dr. Anup, Dr. Raviraj and Dr. Sanjan Singh to stage, and I'll request Dr. T.D. Yadav sir, Dr. Ansuman Pandey sir, Dr. Sandeep Saluja sir, and Dr. Avinash sir to moderate the session. And case will be presented by Dr. Palas Savla.
Yes.
Good morning, everyone. We're starting with the post-op case scenario. She's a 27-year-old female with no comorbidity. She came to us from an outside operated lap colostomy done on day 2 of acute cholecystitis. And she was referred to SGPGIMS post-op day 1 with no intraoperative findings available. On post-op day 1, she had complaints of mild right hypochondrial pain and right shoulder pain. On examination, her temperature was 99.2 degree Fahrenheit. Her pulse rate was 110 beats per minute. Her BP was 100 by 60. Respiratory rate was 20 per minute, maintaining saturation at room air. Per abdomen, there was mild tenderness in the right hypochondrium. Bowel sounds were absent, and the drain had 150 ml bile output on post-op day 1.
So what are your concerns at this stage? Just stop a minute. What would you do at this stage? What are the alarming points which you note down?
Sir, the patient is having a pain and tenderness, and she's having tachycardia at the moment. And the most important thing is the drain is having bile, sir, on the day 1 of post-lap cholecystectomy, sir.
And what? Bile salts, but the vowel sounds are absent.
Yes, sir.
What will you do? This is on the day 1, next day morning, talk around. This is the status. Would you like to investigate it further, do anything, or would like to just observe it?
Yes, sir. Definitely, I would like to investigate further with.
It's a post-operative contract, so it's a quick. We have only 15 minutes.
Sir, as a drain is in situ, then first and it is a post-operative, I'll go for a CT scan, sir.
What intent? What do you think?
What are you suspecting?
On day 1, patient coming with this. What is your suspicion? And to go to CT scan.
Are you suspecting what?
You don't know what is the hydration. You don't know about the renal function test. You are not aware how patient is resuscitated.
You want to speak?
So you are immediately you go to CT scan.
So the first answer, as everybody suggested, should be the resuscitation. You have to optimize the patient first. The patient has been referred to you, the most importantly. You have to optimize first. And going straight away for a CT scan, you should have something in your mind what you suspect.
Yeah, absolutely.
So why do you think these things have come on table? It is a common presentation of bile in the drain and the patient running all these signs of sepsis.
Vowel sounds absent.
No, sir. No, sir.
So why do you think it has happened?
Probably there is a billion connection which is formed, which is.
So again, let us be very categorical. You need to know the history of the patient. The patient was operated outside. You need to know what happened to the patient prior to the operation. You need to know where was the person operated upon. You need to know the preoperative details and imaging if possible. And of course, the intraoperative details. So would you be concerned about all these things, or would you go ahead and do a CT scan now?
You don't know he has been operated. A1 only by half a normal gallbladder will not present, usually doesn't present like signs of sepsis. So we have to see in which condition he was operated, what was the acute cholecystitis stage, what was by the, about according to the, which is translating in the post-operative period. Because you understand, these are the things.
Basically, it is clear that you have to first resuscitate, check the investigation, and you are suspecting sepsis. Then, after stabilizing, yes, CT scan is better, or a bedside ultrasound followed by CT scan. Do we have a bedside ultrasound or?
Yes, sir. We have an ultrasound with us, sir. So this was done on post-op day 1. The ultrasound was suggested was suboptimal scan due to excessive bowel gas shadows. The liver was 13 centimeter with normal echo texture. There was no IHBRD. The perihepatic free fluid was seen. Drain was in situ. CBD, pancreas were obscured. Spleen was normal. There was no free fluid in the pelvis.
Anything else?
Sir, in the meantime, I'll also like to send the complete blood counts of the patient. And after starting the patient on the broad spectrum antibiotics, I'd like to wait for 24 to 48 hours and observe the trend, because if the patient stable.
The investigation.
So this is hemogram on post-op day 1, where HB is 14 grams, TLC count is 17,700, platelet count is 3 lakh, INR is 1.21, which is fairly equal to the pre-op values.
What else? Anything other than CBC you want?
KFT and LFT of the patient also, sir.
Renal function test was grossly similar as the pre-operative value. Electrolytes were normal.
Sir, the grossly, sir, the WBC counts have raised, sir, 17,000, and rest of the investigations are within normal limits.
See the NFT now.
Bilirubin is 0.62, direct is 2.25, and SGPGIMS is mildly elevated from 20 to 40. ALP is slightly above the normal limit, and albumin is similar to the pre-op values.
So, the SGOT-PT is slightly elevated. This might be due to the post-op. The patient is having transaminases due to inflammation.
but the WBC is elevated, so the patient is having a source of sepsis. So after resuscitating the patient for 24 to 48 hours, if the patient does not stabilizes, then I like to go for the CCT abdomen to rule out any other. So broad spectrum antibiotic in the form of piperacillin, tazobactam.
Region for selecting. What are the basic principle of selecting antibiotics when you are giving without having culture and sensitivity in any case?
Like to also send the drain culture of the patient.
No, that will be coming later. You will not wait for the culture. When we are starting antibiotic empirical, what are the principles you follow?
The usual suspected microorganism of that organ. Biliary secretion, microorganisms.
Say this biliary, what are you really expecting?
So gram-negative E. coli, Klebsiella proteus, and Enterobacteriaceae group.
So which antibiotics you normally select?
Yeah, cephalosporin is the third generation, most likely initially.
That antibiotic particularly should be secreted as.
Yes, sir, that should be secreted in biliary system.
It should select that it is going to work there.
And along with that, you can also see your microbiological data of your hospital.
Yes, yes.
So then you can start the empirical and give the antibiotic. That is done. Have you done the CT scan?
Yes, we did one
You can
CT
share the
scan.
findings.
So we have a single snap of the CT scan, and we have salient features of the CT findings where there was mild perihepatic free fluid was seen, pneumoperitoneum was present. There was mild dilatation of the right system, 2 to 2 centimeter collection was seen in the GB fossa with surgical clips seen in situ. The right side subhepatic drain was seen in situ, but not close to the collection. There was mild ascites present in the abdomen.
So at this point, I'll again like to know the hemodynamic status of the patient. So then, sir, I'd like to wait and watch and not like to do any other intervention at this point of the time and start the patient on enteral nutrition also. And with drain only when the patient stabilizes, I'll send the drain culture at this point, and based on the sensitivity, send the patient and discharge the patient when she is hemodynamically stable with an oral antibiotic and follow the patient on OPD basis.
Alarming findings which you would like to intervene immediately. Whether signs or CT pictures, if it is there, you should not really wait. You would like to immediately.
Sir,
at the end of 24 hours, what are the alarming kind of signs or this CT picture which you should immediately go in?
Sir, hemodynamically instability in the form of inotropes requirement, patient is having diffuse peritonitis features and abdominal and the really is a diffuse peritonitis, and if the patient is not settling on
So
with
why,
hemodynamic
what additional
instability.
information sir is asking, what additional information would you actually require from a CT scan? Or why was the CT scan done once the patient was clinically, getting better? You had a drain which was draining significant amount of bile. There was no evidence of any significant collection, which was the drain was in situ, it was draining. Why did you do a CT scan? What additional information did you want in the CT scan so that your management would have been altered?
Any other vascular injury?
It's a suspicion of any viscous perforation, sir, which we would like to rule out, sir.
In such a case, anything can happen. If you see in this case, what you can defend is that this patient was operated in acute polycystitis. You went in for CT scan because your ultrasound was suboptimal. And CT scan confirmed that there is no undrained collection. So in this case, you can continue with the conservative management of antibiotics, and the only other thing will come to your mind is, will you at this stage try to classify which type of injury is there?
No, sir.
No, sir.
No, sir.
See, basically you're worried about undrained large collection, viscous perforation, vascular injury. Now, vascular injuries usually are very clear. He has no drop in hemoglobin, 14.1 to 13.7. There is no blood in the drain, anything. Secondly, gross viscous perforation does not look to be here. Basically, there is no massive collection, anything like that. It would have shown gross peritonitis by 1 day or something like that, which is not there. So that you're ruled out. And then the only thing what I think Dr. Saluja said is very important. Is there a missing large collection which is undrained? That's your concern. If that is so, then you would like to really do a re-laparoscopy rather than, and then you would like to really give a wash and put a proper drain and allow it to drain, But here the clips are in situ, patient does not have much collection, so would like to really observe this patient and conserve this patient with antibiotics and rehydration, and rather than do anything drastic at this stage. Our main aim is to drain this patient properly and treat it with
Other scenario could be with this finding, your patient was transferred on day 1 and it was draining bile and there was no evidence of sepsis. So would you have done something different?
So if the patient is stable and no sir, at this point of the time.
Whether there is any early repair, when the patient comes within 24 hours, will you think of it? If you are thinking of it, how will you manage such a patient?
Sir, early repair is indicated if there is no sign of.
That is there in this patient. Have already
Okay, in this patient.
No sepsis. So how will you think, if you are planning an early repair, what else will you order or investigate before you think I'll go for early repair?
MRCP.
MRCP is one thing, and CT would be not just
Angiogram.
But for your exam purpose, there are lots of data available, but against the early repair, long-term outcome, recurrences of the stricture, and mortality also. So at your stage, I think it's better that early repair, intraoperative help is different. Early repair is different. Early repair, the outcome has been continuously, French data, Danish data, continuously, one after another message has come, the data has been published. If you are going for early repair, even in the best scenario, the outcome is not good. So you should in the exam say that any center doing early repair, most of the centers in IAMS, SGPG, everybody is sitting, we are usually deferring early repair. So the same thing everybody would like to listen us. So it's not that you are saying sick. So early repair, if at all somebody is Dr. Suggests, say somebody is helped on doing early repair, obviously vascular injury has to be excluded. And MRCP, when you are doing in a collection, there is perihepatic fluid, lots of fluid is present. You do MRCP, you will find everywhere there is a enhancement, and this collection is seen. Whatever is not fluid is not moving will be seen, and it will not be able to differentiate very nicely about the ductal anatomy. Until unless you are doing some dynamic MR scan, which is very rarely available in our setup. So I think these are the important points at the exam level. So some centers might be doing early repair, but we should be thinking about exam. We should think that.
So returning to this case, first thing, resuscitation, control of or optimization of sepsis by any means, and of course, nutrition.
Second case.
Sorry. So I think you agree with your presentation.
So to summarize, in this patient, we should think about earlier acute cholecystitis leading to this type of features more than that bile. So that is as suggested by one of you. He is our student also. So that you are going controlling sepsis, starting antibiotics based on as Dr. Sandeep said, based on your department and based on that particular organ, what antibiotics is working. All those components has to be taken into account and monitoring. Not that you start and just relax. You have to monitor next day, are my effort working well? Or next day it is same condition or deteriorating. It means your treatment is not adequate. It means your source is not controlled. So at this stage, resuscitation, source control, two important things we have to see. And then
latest GB perforation in the past, for which PCC was inserted. He was post PTBD segment 3. He underwent staging laparoscopy, right hemicolectomy with chordate lobectomy and Roux-en-Y hepatogenostomy of the left side. His post-op day 1 to 3 was gradually recovering, and today is post-op day 4, where patient complains of mild pain in the abdomen that is dull aching. He has nausea and intolerance to oral feeds with abdominal distension. The urine output has decreased on subjective assessment. On examination, patient had a temperature of 99 degree Fahrenheit. His pulse rate is 110 per minute. His BP was 90 by 70 mmHg. His respiratory rate is 22 per minute with saturation of 94% on room air. He has pallor and icterus on examination, and his respiratory examination showed breath sound decreased bilaterally with no added sounds. On abdomen evaluation, his abdomen was soft, mild distension was present, there was no tenderness. Bowel sounds were present. He had past practice but not past stools. His input and output assessment suggested a 3800 ml input, where orally he was given 600 ml, and his urine output was 650 ml. His drain output suggested 500 ml serosanguinous output.
So in this case, the patient is having fall in BP, tachycardia on the POD4 with the zero sanguineous drain output. At this point, I would also like to know the trend of the drain output, whether from POD1 to POD4, the amount of the drain output, the character of the drain output, if it has changed from POD3 to POD4.
And it is 500.
The character of the drain also, sir, because it has zero.
Almost sanguineous components like in.
So, sir, at this point, I like to also suspect for the sentinel bleed and with the hemodynamics of the patient, and I'm suspecting a hypovolemic shock in.
After ectomy with lobectomy, what sentinel bleed are you expecting?
From resection margins, sir, probably needs to be in a liver bed.
Resection bleed is one thing. Sentinel bleed is usually set for.
Sir, because we have done the dissection along the common hepatic artery also, and our
vascular
yes,
aneurysm, you are suspecting second.
Yes, sir. And JJ side, JJ or.
Do you think JJ side would present like
no, not JJ side.
So what will you do now?
So I resuscitate the patient with the IV fluids and send for.
What investigation? You have short time. In 15 minutes, you have.
So complete hemogram.
Hemograms.
CBC
So
will
send a
last match.
Operative value on post-op day 2 it was 8.2, and today on post-op day 4 it is 7. His TLC count from 8,000 in the pre-op increased to 16.8 on post-op day 4. His INR has been 3.4 today, and his platelet count is 17,000.
So there is a significant fall in hemoglobin with raised total leukocyte count and significant drop in platelet, and INR also increased. So there is a decreased synthetic function of the liver most likely, and possibility of. Yes.
So is there science?
So there is a yes,
Liver failure, sir.
liver
failure.
supposed.
So this could have a mixed picture.
Mixed picture.
So in such a scenario, where do you think the bleeding could be from?
And it happens when you are doing this, that there can be binding from the liver here and on the electrolysis. The sepsis is also severe.
Yes. No, it can be from cut
surface of the liver.
Associated with.
So what will you do now?
We will. I will arrange the blood product if not arranged already, and.
What
blood
product?
LFT.
Tell the LFT and the EFT.
LFT on post-op day 4, his total bilirubin is 3.5, direct is 1.9, which is almost equal to post-op day 2. His albumin is 3, and his SGUT, SGPT is 200 and 300. His ALP is 112, that is in the normal range.
So what is happening?
So it can be sepsis with bleed in this case because the LFT.
So start the antibiotic, research the patient with the blood products and CT angio or CCT abdomen dual phase.
These are the things other than
Sir, oxygenation in the form of nasal mask, or if patient may require ventilation, BiPAP or intubation. If patient requires continue, yes, yes, sir. Okay.
Sir, vitamin K, sir, we can start vitamin K. Then load.
Yeah. You said blood products. So basically, the question is leading there. What kind of blood product? Patient is having some kind of a respiratory compromise. The renal functions are deranged. The tachycardia and respiratory things are there, or there's some kind of an inflammatory response, post-operative scenario. So what kind of blood products?
PRBC, FFP, and platelet.
So the volume control should also be there. It has to be directed to the things concerned. Would you like another investigation or any other information?
Yes, sir, I would.
also
Yes.
pending intravascular cough and hence regeneration also. So antibiotic, proper therapeutic care, incoming test and all those things, but then you also add acute so that you are giving not for the disease. So for the regeneration of the liver also you are supporting, and then you are trying to investigate simultaneously from where the blood, because there is a drop in the hemoglobin also.
Yes.
What investigation you were telling?
Thromboelastography.
Yeah.
That is going to. Is it? Okay, fine. Did we do TEG?
So we don't have it currently, sir.
Okay. So that is done, and the alternative is if the fluid, you have to do a resuscitation with restricted amount of fluid, the cryoprecipitate should be kept in mind.
Yes.
And you would look at the INR. So CT was somebody said CT. So was CT done in this case?
CT was done.
Yeah.
There is a snap of CT scan where there was mild proliferation on bilateral, and surgical clips were noted along the middle hepatic vein. There was a well-defined 8 into 6 centimeter collection noted along the cut surface with few hyperdensities noticed within the collection. The arteries were normal, the portal vein was normal, the hepatic vein was normal. There was mild ascites in the pelvis.
So what do you think?
Patient has been also, no? So what is the relation of this collection with the drain?
Sir, this is not written with the collection.
What will you do now?
So do you see any pneumobilia? Just there's only a single film, or?
Yes, sir, we have a single snap of it.
We were talking about leaks and rest of the things. Do we have any other evidence regarding rest of the things? We only have one film, cross-section film.
So it's a post-op case scenario, so we kept one snap. Okay.
So basically, there is no evidence of leak elsewhere. This is the finding. The vessels are okay, so there is no aneurysm. Now, what will you do?
Sir, I'd like to do the IR guided PCD placement into the collection because it looks like a hematoma, which is it would have it get infected and which is now manifesting in the form of.
What is prompting them for doing this?
So the coagulation profile.
The coagulation is 3.4 to under FFP cover. Yes, sir.
Under you will drain it so that the sepsis component is settled down. So probably this patient was having
Bleed from the liver bed surface.
so more likely early liver failure could be their reason for derangement. You will try to control the liver will regenerate as it has been given. And if the jaundice keeps on increasing, what will you do then?
Therefore, everyone was coming lower than the day.
They corrected day 7, the other things are okay and the bilirubin is rising. So any other measure for if the patient is going into post-hepatectomy liver failure other than the supportive treatment?
One important point we do not discuss that if there is a PTBD was done, so what was the culture completed before the surgery? When you do upgrade this patient, you send the culture samples so that you can start the targeted antibiotic in the post-operative period. So obviously PTBD must have been done in this patient. So definitely we are not seeing any result.
So maybe, sir, anything else? Once the patient affects into liver failure, there.
Yeah.
Yes, sir. Yeah, 2 months.
Basically, what is important is probably after this, many things are not in our hand. Supportive management is there. Preoperatively, you could be suspecting with the adequate liver volume was there. So preventive is more important rather than that in this scenario, because either you can consider this patient for transplant or anything. So that is important in this.
So this scenario, the patient is definitely having an ongoing bleed. Why? Because there is a serial drop in the hemoglobin. Number two, there is a collection, which is adjacent to the drain already placed, which is already draining around say 200 to 500 cc per day. Now, would you like to do something else apart from the supportive treatment? Would you want to know that are you missing out on something? What else could you ask your, CT scan only had one film? What else can be the cause? So there is an ongoing bleed. We all agree on that?
Yes.
So how would you investigate this thing apart from the rest of the supportive management which you are going to give to the patient?
Arterial bleed.
Basically, it is that if the bleed is missing and if the color of the bleed is arterial, will you go for a DSA in such a patient?
So sentinel, he said. So I was coming back to it. So how would you like to investigate further? Would you want some additional information in the CT scan?
Yes, sir. The status of the hepatic artery.
How do you ask for that?
CT angiography, CT angio, if it would have been difficult to like.
Yeah, the system as well as the perfusion system both are okay.
Okay.
You could see the vein also see. So these are the you see I will see you see something is there, but liver enhancement is very good. So preoperative future liver eminent we don't know. That is also important to know when you are talking about the patient. What was the liver and since I am not seeing any tube, what that endoscopic is can be done. In the preoperative period.
Basically, hypothetical situation become, it is not a resection margin bleed, if there is a vascular bleed or something, how will you manage that?
That is different too. And that's why it's not like the collection. You see the go to that, there is enhancement.
So this is a very important finding.
It's not that it's a bile collection or something. This is some blood that might be liquefied in that laterally, but close to the liver margin, it is enhancement. Then what?
So if the arterial bleeds are if we are suspected.
So basically, the bleed could occur from a vascular slippage or something which can be embolized. If it's a cut edge bleed, probably if your patient is ongoing bleeding is there, and after your supportive management you are not able to improve, then in this case you might have to go in and pack the area and look at if there is a sputter which you can control, and you taking that the coagulation profile is corrected or the support.
This case of sepsis leading to failure, or as we have seen in the investigation composed of day one, or two, there platelet count was 17,000 only, and there is a high raise in the INR. Is it a case of post-operative liver failure leading to the from the gut surface side, or is it a sepsis leading to the liver failure?
This is the overlap picture. That is why whatever corrective things you can do, that is the correction of the profile, doing the antibiotics and watching the patient, you will come to know the sepsis will be taken care of. If it is a hepatic failure, as I told you that subsequently other things came under control, sepsis was controlled and the patient liver failure, jaundice is going up. So it's always an overlap picture. That is why you have to think as a holistic approach.
On a second day, you're seeing coming from 12.4 to 8.2. So the bleed has occurred first. And then the rest of the thing have added to the whole thing, and the sepsis has come later, liver failure has slightly come later. But drop of, say, 4 gram bilirubin, hemoglobin, the bleed has come first. We should really consider that. Sepsis causing all that would come at a little later date. Secondary sepsis. Yes, sepsis came, but so it has been.
So there is no doubt the patient is on post-operative day 4. The patient would have been good in the time of surgery. That is why he or she was taken for surgery competent. And then subsequently, there's a significant drop in the hemoglobin. First, the patient is having tachycardia with multiple organ involvement in terms of dysfunction. So we'll have to consider that first.
Exactly. And the secondly, this patient is a cholangiocarcinoma, right? So they must have put a PTBD.
Yeah.
PTBD must have caused some degree of a latent infection, and all these factors are already there. So some part of the sepsis is already there. That also could have contributed to the bleeding.
One part is also very important. Question is very valid, and it's very difficult to differentiate and say that no, this is not there. One important point is also when you are taking fecal liver remnant, we are only talking about anatomical value. So at part there was cholestasis. So we don't know the functional status at the time of the surgery. Most of us are not doing ICG and clearance and all. So that is also one of the components which leads to the liver inadequacy, in spite of the fact that in the preoperative period we had a according to the literature, this 40% liver volume left. So that is also very important.
Technical thing that we should note when we have a bleed in the first 48 hours after the surgery from a cut edge, especially after a right hepatectomy, is how the hepatic venous outflow is. Because if there is a torsion of the remnant, or if there is an injury to the vein during the time of the resection, there can be a thrombosis and the outflow can be impacted. That can lead to cut size.
If you really see the cut picture of this liver, it is very close to the middle hepatic. You can see one very margin of middle hepatic.
Thank you, sir.
Thank you, sir. For next session, I will call upon the stage Dr. Ankam, Dr. Arun, Dr. Mohammad Yashir, and Dr. E. Shai Krishna. And I will request Dr. Sandeep Saluja, sir, Dr. Chetan Kandharia, sir, Dr. Shivendra Singh, sir, for moderating the session. Thank you, sir. And case will be presented by Dr. Payal.
Good morning. The patient is 76-year female homemaker, resident of Sitapur, UP, who presented with postprandial fullness for 3 months, recurrent vomiting 2 months, generalized weakness and easy fatigability 2 months. Patient was apparently asymptomatic 3 months back when she started to have dyspeptic symptoms along with postprandial abdominal fullness and early satiety. It was associated with recurrent episodes of vomiting for last 2 months, which was large amount, non-bilious, foul-smelling, contained undigested food particles from previous meal. The frequency initially was 1 to 2 episodes per week, which increased to 1 to 2 episodes per day. There is history of loss of appetite and loss of weight of around 13 kgs in 2 months. History of generalized weakness and easy fatigability is present. There is no history of hematemesis or melena, no history of postural dizziness, syncope, shortness of breath, or need for blood transfusion, no history of abdominal pain, no history of long-term NSAID intake, no history of dysphagia or dinophagia, regurgitation, coughing, no history of altered bowel habits, jaundice, hemoptysis, bony pain, or back pain. Treatment history.
Stop.
Short duration of 3 months with
What are you dealing with when this question is asked? The answer is what is your differential diagnosis, not the supportive findings.
possibility of CA stomach, malignant cause of.
How can you say just what have you heard from the history which makes you tell that it's a CA stomach?
There is a
What we expect you to tell is that this could be a gastric
Gastric
outlet
outlet
obstruction,
obstruction.
either due to
Malignant.
whatever this. So which I would like to know the further history and ask certain question. If you say CA stomach directly, even if you are right, the examiner will say that you know the case. Having said that, everybody knows the case, but you should act as if you don't know the case and you are seeing it for the first time and you are presenting.
Just tell your diagnosis or differential diagnosis.
Possibility of gastric outlet obstruction due to malignant cause.
Not because of any benign cause.
It's a short duration is short with a loss of weight and loss of appetite with a loss of weight of more than 13 kgs in 2 months.
Okay. So if anybody who has got nutritionally depleted, not taking for 1.5 months with a long history, so then we will think benign.
Yes, sir. Long history, if previous long history is there, we'll think about the benign.
You go back to the history. Yeah. 3 months dyspeptic symptoms. So benign you won't, your only one diagnosis would be gastric outlet obstruction caused malignant.
It's most likely to be malignancy. Why?
Most likely malignant,
History
but benign.
from age, elderly patient, short history, and history has ruled out the other common causes, not a known peptic ulcer disease with means newly discovered dyspeptic symptoms. Hence, I am more likely to say that it's more likely to be malignancy. However, it could be. The examiner says that can it be? It could be, but less likely. That is how you should say in exams. Okay, go ahead.
Go with the treatment. Yeah.
Treatment history. For these complaints, the patient was evaluated elsewhere with ultrasound, CT scan, endoscopy, and biopsy. Following this, a nasal tube was inserted for feeding, and as per the patient, she was started on anti-cancer drugs. Patient claims.
Stop. After you have a suspicion on this, you can move on to the examination part.
Currently, patient is conscious, cooperative, oriented to time, place, and person. Her BMI is 21.2 with a weight of 51 kgs. ECOG status 1. Breath hold time of 22 seconds. Pallor is present. There is no lymphadenopathy, edema, cyanosis, ictus, or clubbing. Pulse is 80 beats per minute. BP 120/70. Heart rate of 20 per minute. Respiratory rate of 20 per minute. And she's upright.
Wait. Go back to GP. What on abdominal examination are you suspecting or will you see in such a patient?
Case of gastric outlet obstruction. So I would expect any distension of the stomach in the epigastric area, succussion splash, and auscultation.
The flow per abdomen finding, which she is going to say what positive you are thinking, and then she will tell you the findings.
On inspection, I would like to see any fullness in the epigastric area, any obvious nodules at the umbilicus, mainly on inspection. And on palpation, I would like to confirm the inspectory findings. And nodules, if are there, I would like to palpate those. And on percussion, I would like to see the distension of the stomach with the auscultative percussion, and I would like to mark the stomach. And
what is he listing?
Visible gastric peristalsis, sir, on inspection.
That is probably telling about the epigastric area. What else?
Correctly.
Before that,
would you want to see something below the stomach?
Umbilical.
Why are you missing about the free fluid and the liver part? He is just focusing on his. So basically, one is you are going at the stomach area, And you will also look at the hepatomegaly and ascites, correct? So now you can tell the per abdomen findings.
On inspection, abdomen is flat with umbilicus central in position and inverted. All quadrants are correspondingly moving with respiration. No visible scar peristalsis, no sinus engrossed veins. Hernial orifice appear normal and the bilateral renal angles appear normal. Palpation, abdomen is soft, non-tender, no organomegaly or lump. There is hernial orifices are normal on palpation. Then in percussion, liver dullness is heard at the upper border of fifth intercostal space. In the fifth intercostal space in the right mid-clavicular line, liver span about 13 centimeter in right mid-clavicular line. Flanks are tympanic. On auscultation, normal bowel sounds are heard and there is no succussion splash.
So basically it is the normal findings. Anything else in the examination in next slide?
No, sir.
Okay. So now what will you do? What is your diagnosis?
Gastric outlet obstruction, probably due to malignant etiology, carcinoma stomach.
And any findings, per abdomen findings are not supporting them. Correct. So how will you go further?
How will you confirm your diagnosis? Now that you feel that clinically you feel this, how will you confirm your diagnosis? There is no question of differential diagnosis here because the patient himself said that she was started on some anti-cancer drugs and this. So now how will you confirm your diagnosis?
Sir, I'll review the previous investigations, sir, which were done.
If they were not done, what?
She is come to you, Dean, with this. She says I have no investigation.
Why it is a gastric outlet obstruction? There is no finding.
Yeah.
From the history, sir.
So why there is no finding now?
Can be a last episode of feeding tube. She is on feeding tube.
Okay. So how will you confirm your diagnosis?
I would like to do two set of investigations. As patient is in gastric outlet obstruction, I would like to do complete blood picture, renal parameters, LFTs and coagulation profile. And to confirm the diagnosis, I would do the upper GI endoscopy. And ultras.
Ask how will you go ahead and say the answer that I have to do things. Now the question to you was, what are you going to do to confirm your diagnosis for next day? Then answer accordingly.
Upper GI endoscopy and ultras.
And upper GI endoscopy with biopsy.
Yes, upper GI endoscopy with biopsy at the suspected lesion.
What is the method of doing biopsy? Is there any guideline how you should do a biopsy? Let him answer. Second person. Yeah.
Sir, we need to take minimum 5 to 8 samples, sir.
And you send it for?
Sir,
for what investigation?
Histopathological examination.
Histopathological and nowadays what? What else?
Sir, IASG
molecular
biopsy for LS2 and PDL1 and
Can
MSI.
you tell me what is the molecular classification of CS stomach?
4 class. There is chromosomal instability, MSI high, and PDL1
no. You said chromosomal
Epstein-Barr virus.
Epstein-Barr virus is genomic classification. This is the loose classification.
Whose?
What classification? What molecular classification? The gastric genome atlas classification that gives you this 4 classification. How do you characterize the lesion? Any method, any classification?
Borman's classification.
Which is
on endoscopy.
Which is one? What is followed?
Japanese classification.
So Borman is how many types?
4 types. One is polypyral growth. 2 is ulcer-proliferative, infiltrative, and lineages plastic or diffuse.
Okay. So in endoscopy, what do you want her to tell you?
Size and extent, sir. Distensibility I look for, and
in this case, distensibility, size.
Distal extent of the tumor, whether I can negotiate the scope through the mass or not. Relationship with G junction.
What is
involvement of lesser coverage. Proximal extent of the tumor also I would like to know.
And what do you want to know? What is the location? Where is it? Second,
extent. Location, extent of the this one, and negotiability of the scope. And any distensibility also.
Distensibility.
Okay, so tell us the UGI finding. Along with that, food residue is there.
Upper GI suggested esophagus, multiple large linear ulcers starting at 25 centimeter, extending up to GE junction. Stomach food residue was present. Thickened friable folds seen starting at mid body and luminal narrowing extending up to D1. D2 was normal with the impression of thickened gastric fold with gastric outlet obstruction. Biopsy was done, which suggested signet ring cell adenocarcinoma.
Where you are going to take the biopsy, there is no gastric outlet is patent. And from where you are going to take the biopsy?
Because it's thickening in the body.
And how specific for this type of lesion, how you are going to take the biopsy?
Strip and bite biopsy we follow in these cases. Because these are signet cell where the lesion will be.
Let's see who are going to go later on it is signet cell. If we have this endoscopic finding, where I'm going to take the biopsy from? Which area?
From the narrowing ulcer.
See, there is one linear ulcer in the esophagus, starting at 25 centimeters. Then there is thickened fold at the mid body, which is extending up to D1. So from there will you take?
From the thickened folds at the lateral part of the ulcer.
It's part upper
body.
Will you take only one biopsy from area or will you
We take multiple biopsies of sound weight at the edges.
because it means the addition superposition thing will be just there. So you have to focus on begin
bite biopsy.
Yeah, biopsy. And what else you can for all these scope, new things have come up.
Yeah.
How you can use those technology to take the biopsy?
On either chromoendoscopy, a narrowband imaging we can do NBA imaging.
Signetic, sir?
Not much, because this is submucosal mainly. Mainly the mucosal lesions has a better role narrowband imaging.
So now this is the biopsy. How will you proceed? Next.
Next we ultrasound abdomen. Staging to rule out metastasis.
Common is to have a peritoneal disease or meningitis. Liver mets could be seen, but it is very rare, likely to have a presentation.
So USC, let us see the USC.
Ultrasound liver size was 130 mm. Uniform parenchymal texture in gallbladder and CBT were normal.
And also RFT, blood investigation.
Impra.
Okay, hemoglobin is normal. Transfer blood.
The counts are
Normal in platelets.
RFT.
Readings. Essentially normal.
What?
Alkalosis with paradoxical aciduria. Metabolic alkalosis with paradoxical aciduria. Electis. Albumin is normal, sir. LP is mildly elevated.
EG ratio is okay.
Yes, sir. Wait.
Next. Now what?
So then we'll proceed with the staging investigation. Sir, we'll do contrast enhanced CT of the abdominal pelvis along the CT chest, sir.
Chest X-ray you want to?
Chest CT as well.
Is there a role for tumor markers?
In CS stomach, it doesn't change our management as such, sir. Even though it helps in the further after, if you are planning for NACRT, you can assess the response.
Which tumor marker?
CA99 can be used in
CA 72.4, CA, CA9.
Sir, grossly distended stomach with thickening in antropyloric region.
So you are going to comment this then?
Oral contrast results.
Yeah. Contrast. Here, you need contrast CT.
The film which is going on is what?
In a non-contrast CT.
What do you see?
Calcifications, epidural, no SRTs. Oral contrast is seen. No, sir, we can't comment on the lesion in the non-contrast phase.
Don't have to comment. If you see anything, you can tell always. Is there?
Cystic lesion in
It can be as well, or it can be any other thing. So, but
You have to tell there is a hypotenuse lesion seen.
You saw, I saw. Everybody saw. What is there?
You can comment now.
there is grossly distended stomachs with thickened pylorus and extending into body, which is extending into duodenum, D1 also.
Please even ask her to stop there.
Which is the lower, which is coming posterior.
Are you able to make out my number?
What grossly extended, so you cannot actually say that most likely it is, but it will be. Now what next?
Next, lymph nodes. In liver, there are two S-foils appear like simple cysts without any enhancing tissues, but
In the last discussion also, it was told that you make a system, start either from local side and then distant.
lymph nodes.
Then you will not miss anything.
Tumor, then nodes, insect cells, then different methods.
Thickening starting from the mid body of the stomach, extending up to the D1. Locally, it is just abutting the pancreas, but no obvious infiltration is there. Appears in this place.
Based on this CD finding, and what
There were only cystic lesion
appears more more
What else you wanted to see?
lymph nodes. I would like to look for the lymph node. No ascites.
Lymph nodes, ascites.
In peritoneum, mental peritoneal nose.
And sure, what you saw in endoscopy, will you not look at that? Have you commented about the junction of the-
Also for the. There is no thickening as such in the lower part of the esophagus and even at the GE junction. So most probably it can be due to the recurrent vomiting might the patient have developed the ulcers.
So now, based on the CT
I would like to do the staging labs to.
I think there was some peritoneal deposits on both the scans.
Lymph node is there, sir. Large lymph node is there, sir. Yes.
Come down to these are all these inflates are just these are those department just fracture to liver and just yes.
No, sir, they have not committed them at
Finally, what would you want to do next?
Diagnostic laparoscopy.
Would you want to do EUS?
Straight away diagnostic laparoscopy, right? Straight away with this finding diagnostic laparoscopy, are you planning section?
No, sir. Just to stage the disease also before planning for NACRT, diagnostic lab is the. This is the momental lesion. Through US, I have to take the sample. It will be difficult even to get the FNS. PETs. The signaturing cell won't be very evident. More
The PET scan it's available for signet. Signet, I think
Even if it is signet cell, with this CT scan finding, will you do a PET or no PET?
We can get.
What can be correct? Your intent should explain why.
But after that also we need the histopathological diagnosis. Usually signaturing cell or not to confirm the lesion.
You have got a biopsy malignancy there.
Oh.
Why do you want to do the PET? If you want to do the PET to support your neoadjuvant treatment or direct surgery, that should be in your mind. Even if you don't hit that area, if that area is lighted up in the PET, it is more likely to support your philosophy of neoadjuvant treatment. Before that, it is important to deal the gastric obstruction. So that should be telling which next investigation. Just finding and hitting at that. This is a luminal structure. You already have a biopsy of a malignancy. So this distant finding, is it necessary to be hit in all time?
No, sir.
So PET scan can be done. Was the PET done in this case?
No, sir.
Okay.
So ideally, what we would all do is a PET-CT scan, and diagnostic laparoscopy is also not wrong. The next step will be doing a diagnostic laparoscopy. So this important thing to be done actually before we start the patient on. You could say that I am planning to complete this patient to NCRT. So prior to that, I would want to do a PET-CT to see what is that and whether there are any distinct other small bits which may have been missed. And after doing that, I would do a diagnostic laparoscopy to confirm that and start the patient.
Diagnostic is more important, always. So.
If we are planning for diagnostic lab, still PET CT is like,
First, you want to assess the response post chemotherapy.
okay.
Even if for all guidelines said, is it mandatory for all these CS2, even NCCN mentioned, PET scan is a part of the staging workup for CS2. Institutional protocol can help, but if you want guidelines, it is CS2 exactly should be done. And we rule out category. So diagnostic will be why because category is
Petrol levels.
but we want to know any of the what we can the
Yes, sir.
No.
Petrol levels.
Or if on better scan point, it is a disseminated disease.
That is still not needed.
Then no.
Only chemotherapy will be given. So basically, staging laparoscopy will come if the PET is not, it is a localized disease, only a locally advanced T3 or node positive there, and you want to do NSCT, then the role of staging laparoscopy. When do you do a laparoscopy? Staging laparoscopy, do you do a peritoneal lavage and collect the fluid?
We do the peritoneal cytology also in the diagnostic labs. We do, sir. Peritoneal cytology has to be sent for the HP.
How you take peritoneal lavage?
Come
How you will do?
we infiltrate around 100 to 200 of NS and we collect the fluid and centrifuge it and send for the.
Will you open a lesser sac?
No, sir.
I think all it should be lesser sac is to be opened and everything it should be spilled and then it has to be weighted and then taken out samples. And roughly around 200 ml fluid should be.
Please, we come back to a stage that, like, the important thing is, as Dr. Shilendra said, that in the guidelines it is mentioned that you do PET in all cases, however it is either not feasible and at times it is not possible. So the other scenario should always be, rather than an institutional policy also has a basis. So if you are finding a patient with a disease which has got a locally advanced finding, adding the PET will be useful. And for that case, if your PET shows lighting up, then probably saying that I will go for diagnostic laparoscopy may not be useful. Now, if you are planning a neoadjuvant treatment, there again comes a thought that you do a diagnostic laparoscopy for a purpose of thinking that whether this patient will be given complete chemotherapy, metastatic disease. That is the scenario. So we have to say that now all these investigations are available. If you utter these things, then you should know the basis of that and how you're going to contemplate. Similarly, fluid, if you know, you have to say that it is inside into the cavity. In this case, probably they gave neoadjuvant treatment. So now you can come to the treatment.
So now you tell us that it is normal. It shows that that node is there. And cytology is also negative for this. How will you manage? First one. What will you want to do? You want to do upfront surgery that node is lighted up on the PET CT and you have taken a biopsy in small. Or you want to do upfront surgery, you want to give neoadjuvant, what do you want to do?
Neoadjuvant.
What is the recommendation? For all patients, more than stage
T2N. More than stage T2 and N plus disease.
N plus disease.
Should subjected to NSC.
Subject T.
So you would want to do a new. What new regimen would you want to do?
What regimen will you follow?
What regimen will you follow?
If a patient is in gastric outlet obstruction, so initially I would like to place the NJ tube and start the feeding. After assessing that,
what?
Next one.
Sir, we'll give clot regimen, sir.
Why not regimen? Why not matching? Are there any studies to show that clot is superior to matching? Flot is a toxic regimen, no? So why you want to give flot? You have to substantiate. You are right, but why? Does it improve the overall survival?
It improves the survival.
The studies have shown that there is a significant survival from 36 months to 50 months.
Plot for important is there. However, whatever trials which are very much relevant to your vetting, some of the information about the number is good in exams. Telling that plot and the study support the reason. So what regimen was given in this patient?
Sir, actually, magic was given, sir. Patient claims to have received intravenous medications once 3 weekly and oral medications for 3 weeks. She received 3 such cycles and last dose received was in November 2024.
Okay.
The 5-fluorouracil, leucorin oxaliplatin, and the paclitaxel.
Many times you do pre-surgery. How many cycles?
4 cycle.
4 cycles. And then you wait for how long before?
4 to 6.
4 to 6 weeks.
4 to 6. What surgery are you contemplating? You assess the response on PET CT and if find that the responses. How many surgery do you want to do?
D2 total gastrectomy, sir.
You want to go? Yes.
Total gastrectomy.
Why?
Because even body is also involved.
So that will do something else.
Response evaluation. PET CT. PET CT, sir.
Only PET CT.
Initially CT scan.
CT scan.
And staging lab.
And staging lab. And where you diagnose the lesion, where the access is there, that you won't do it.
And
no endoscopy will do not repeat. Was the endoscopy repeated?
No, sir, we don't have the
Findings. So the endoscopy finding should be done first, right? See how much the lesion is vessel, although we know that you are doing CT scan and PET for what? Endoscopy is normal. Then will you do CT scan or PET scan?
Yes, sir.
Why?
Because
Everything normal.
there can still be disease, sir, even though it's in uptake in the lesions, sir. The stomach.
Uda is normal.
Submucosally, they will still get the lesion.
All you want to assess the image. Right.
So you said that you want to do a total gastrectomy with D2 gastrectomy.
D2 lymph.
Now you tell us.
If the response is stable, then most of the time you will get is stable, then no response.
Then
you have to see it or want to?
Yes, sir. We'll repeat the imaging. If patient is still operable, we'll proceed for the surgery.
There could not be progression of the disease population. If there is a stable, then also you have to take out. You have to rule out progression of the disease.
What do you mean by D2 gastrectomy and D1 gastrectomy? So are the terminologies given now? What are the terminologies given?
D1 remain perigastric, D1 plus D2. D1 plus D2.
So D1 is D1.
1 to 7 lymph nodes perigastric.
What will be D1 plus and what will be D2?
D1 is 1 to 7 groups of lymph nodes, sir. D2 is along with 8 and 9. 8
and D1 plus?
Sorry, sir. D1 plus is 8 and 9. And D2 is 1 to 12A groups, sir.
Is there
specifically
D2 plus?
8A, 9 and 11P in the D1 plus. And in D2, we include 12A, 11D also.
Is there anything called as D2 plus?
That group 13 and
or distal
we
in D1, do you remove 1 to 7 or
No, sir. For distal, we don't remove 2 and 4 SCA.
Yes. In this patient, you station 10 or no?
No, no, sir. It is indicated in cases of
Only
where
direct splenic involvement.
the curvature
Splenic
of the upper stomach or posterior stomach is involved, and if it has significant lymph nodes there at the station.
So it is
Yes.
only what happens is 30 or TB.
Station 13 has to be removed if diurnal is involvement is there. So in this case, I would like to remove 13 also. Sir. And if 10, 14 also it should be.
What is the minimum number of lymph nodes that you should do?
16. 16.
What is recommended not to depend when they are 16 is minimum.
13. 30.
Post neoadjuvant, especially post neoadjuvant. So now you have done a total gastrectomy with D2 gastrectomy. You have a histopathology report of the specimen?
No, sir.
Okay, so it comes as poorly differentiated mucinous adenocarcinoma signet variant. What else would you want to do with this histopathology? What else do you want to do? You have not done. I am giving you a statement. You have not done IASG previously.
Two statement.
Which markers will you loudly, clearly?
Two.
Two PDL1 and MSI. 3.
But all patients will do a PDL1, MSI, and HER2 in all patients. All CS stomach will do. All the treatment changes.
If HER2
MSI is no restrictions in HER2 or PDL1. Only recommendation is for doing MSI status because all solid tumors for all MSI is severe because you can use chemotherapy. Or PDL1 it for metastatic setting. Once it is metastatic, then you have to do all this. HER2 you can do selectively because it can change. You can add in neoadjuvant protocol also. You can add. MSI and HER2 are basically IASG. Some expensive, but PDL1 beyond expect and also.
Yes, so only patient who is going to afford taking leave later on. That patient you will do that. Otherwise, there is no point in doing it.
So now. And that will be final specimen, not because not how much we should actually. Although you people would selectively, but I'm not sure individual protocols are still not standard up. Now it's stated. Even in the initial biopsy, you have to do MSI because you can use for enrichment. And HER2 also some recommendation is that you can as a part of TOGA trial, which was there, if you use HER2, you can use that. But all these things are recommendation is only for MSI. These are all guidelines say MSI, not for HER2.
Basically, they say if you're thinking of neoadjuvant treatment in the biopsy, you can tell your pathologist they can put up these ILC marker, not as a.
Yeah, but guidelines mention that IASG should be done now.
MSI should be done.
MSI should be done.
Biopsy so far has not had any impact, direct impact on the neoadjuvant protocol. It may change. But as of today, it has not had direct impact.
But for CS stomach, the guidelines say that CS stomach and colon also impact.
For neurowhy, the adjuvant setting, in the neoadjuvant setting. In neoadjuvant also, there is, but there is no. As of now, no recommendation where immunotherapy has been given in CS stomach, whatever else. And or CS stomach, colorectal, MSI is definitely has come. And even you can start with immunotherapy upfront. But even if you don't say there is no harm, I mean, still but NCCN and all guidelines say MSI. Well,
I think last week
it is the Folfox also, if the MSI positive on right side is there, then Folfox they will not give, it's not just the
I
immunotherapy.
think for colorectal and stomach MSI, this should be done because it can change your treatment plan by adding immunotherapy. All for rectum, you can say all guidelines have included immunotherapy based on MSI. If it is high, though it is only up to 10% patient only, but it will change your plan.
If MSI is high and patient is not affordable for immunotherapy, does it change our regime of neoadjuvant chemotherapy?
Because if he can't afford immunotherapy, then it will not going to change.
So now we'll come to that. So this patient, you do immunohistochemistry, MSI is high.
Immunotherapy, chemotherapy changes only in the role of oxaliplatin. Because
They have
oxaliplatin will
low-
be very effective. But that is only for stage 2 setting. If it is stage 4, then oxaliplatin has to be added. For stage 2, where it is only selected group of patients in which we are going to use in adjuvant, then oxaliplatin is not useful. Only 5-FU is sufficient enough, or capecitabine is good enough.
So MSI is high, okay? And the patient is affordable. How will you manage? You have given 4 cycles of clot drenching prior. Yes, you second. Third person. You have done surgery, immunohistochemistry, MSI high, submucinous adenocarcinoma, poorly differentiated, 22 lymph nodes retrieved, 3 are positive. How will you do? What adjuvant therapy will you do? You want to answer? Tirupati. Sure.
I will continue the next 4 cycles of lot and add immunotherapy to that regime.
If the patient is affordable.
Yes.
And if he is not affordable,
Continue with the 4 cycles of lot.
I think continent lot is good enough if this patient has responded. And immunotherapy can give or later on in the metastatic disease.
so let me ask you one question is, because the lymph nodes are positive, are you tempted to give radiotherapy? Is there any role of giving?
No, sir. If the only D1 lymphadenectomy was then there is low, or less than 16 lymph nodes, or margin positivity is there, then only there is low. The otherwise, even top care up trial, not sorry, not top care, attraction, artist trial. Sorry. Artist.
And critics study. They all stay there. Basically, the chemotherapy should be indicated only in patients who have not been given adequate surgical, ideal surgical treatment. Otherwise, the outcome is the same.
What are the complications of immunotherapy? You have your patient comes back, what are the complications, common problems with immunotherapy?
We need neutropenia, leukopenia happens and some prone for
These are biochemical symptoms that you should be aware of it.
What else you could have done in this patient based on the present guidelines? This bulky disease T3, T4, you have done a complete. Is there any other thing you could have added in the research?
like prophylactic high.
Adjuvant hyper, not prophylactic. It is a T3, T4, posted disease. All these patients, definitely this is not standard condition guideline for these patients. One should plan for hyper.
That is very, very controversial.
I think it's not label evidence. It is LCC. It is LCC interpretation also. They have a label evidence. Adjuvant hyper, there is much more data for adjuvant hyper PSTMR. It has compared to doing for peritoneal mets. Peritoneal mets also the lifted peritoneal disease, a lot of growth. Our adjuvant hyper is not included in last year only, 2024 only. It included in NCCN recommendation also.
Prophylactic.
Then these are patients which are going to benefit.
Then post-op also you continue the Neoadjuvant.
The post-op lot, give CRS hyper and control slot.
My question was that evaluation after the 4 cycle. See the progress. What do you do in that?
When the disease is not stable, but it has progressed, what will you?
Palliative. It's a bad biology tumor. I would like to explain to the patient that it's gonna recur even if I would like to repeat the imaging and see the operability of the patient first. If it is still operable, I would like to explain the patient and chances of recurrence after surgery and other option of palliative therapy, and then I will be.
Good answer. It is good biology, not a good biology patient. But if it is still resectable, once offer, but patient should be prognosticated because the patient is going to.
So together is inoperable then.
Palliative care with palliative.
What medication?
What restoration regimes are in stenting, and the SEMS can be played, but I would like to.
I think in this patient that you are this flow could go beyond. It is the functional symptom was because of diffuse environment.
Feeding jejunostomy can be planned. Stent.
This is the possibility.
But SEMS may not hold on because it's negotiable. So what else can you do?
Since we not work, because of diffuse environment, contractility is gain prognosticate even a SEMS might not mention.
So other than FG, can you do something else?
Yeah, but that.
And for feeding purpose, what will you do?
Feeding jejunostomy. As this patient has extension up to the body of the stomach, likely it has progressed also. So no other palliative GJ can't be done in this patient.
Good. Now, just to complete this, in which scenario or what is the indication for doing endoscopic surgery, endoscopic training for CA stomach?
Early gastric. T1A lesion, mucosal lesion.
And
Extended criteria with well differentiated tumor, minimally involving less than
1.5 centimeter. T1B.
And
without ulcer.
Without lymph nodes and 0.
Most important.
Mucosa and upper 1/3 of
the most
submucous.
important thing.
Differentiation of the tumor, it has to be well differentiated.
Well differentiated, even more than 2
It
centimeters.
should be elevated, not excavated.
No answer.
Thank you very much.
Thank you, sir.
Of the gastric, it is that most of the gastric tumors are non-ablative. Still, then in exam would say that most of the times we get stuck in this scenario that we say we want to do a PET CT, but then the counter argument is.
But if you ask somebody, the guidelines sells recommendation and PET ability is not there in around 30-40%, which are mostly significant or poorly differentiated.
Problem
They say that PET CT, at least for CA stomach, is important.
Also, another question: if patient had GO and it is not a significant cell, should we offer surgery without chemo?
Again, all these answers, what is important is in PET also you get stuck because when the question is asked in the light of that case, you will be able to give findings supporting in the PET or against that. When you make a generalized statement which is unrelated, there you get stuck with it. Similar with your gastric outer obstruction, it is said that if you have got a patient with a gastric outer obstruction, if the feeding can be done in these patients and there are no nodes across and you do not have the patient doesn't have an early chemotherapy or the scenario is not there, then you can obviously go ahead, do the surgery. It is not that always it is mandatory to give neoadjuvant to these patients. Sir, but tell me one thing. If you have a 4-month waiting list for your chemotherapy, will you give a neoadjuvant to everybody?
But bleeding, and then operate, and then give it to we don't know. But that is an individualized case, but generally you have to give neoadjuvant in this to the population. That will be or the bile was caused and caused.
Just wanted to ask one. So it is generally said that signatures of adenocarcinoma are not usually patient. So in that case, should we also be going a copy pack in all cases?
Not all cases. Yeah, exactly.
Already we answered this question that the PET you can, it's not mandatory in all cases.
Data for copy pad is still evolving. It is only all in trial setting at present. What everybody has no evidence at present in favor of copy. This is all studies are going on. No way of known, but PET is there.
If a patient is often resectable, we give the neoadjuvant chemotherapy. After that, during staging during the surgery, we found only 1 to 2 deposits. Sir, the option can be the option only palliative therapy or CRS and hyper.
Give second line chemotherapy. If there's no response, only flow lymph studies, then you can operate later. But at that time, one should not proceed because that shows that the patient is not good burning. Once one should not operate at.
Yes.
So in this patient, if the obstruction is complete and you are not able to put a FG also, then how will we do the management for this patient? Sorry, not the FGs, the NGS. If you want to give neoadjuvant, then
Removable blood cells, you can take it out, put it on, put it there. You don't want the injection. The patient level, you can put the removable stuff. And that can start.
If there is a complete obstruction, that is what I'm asking, sir. Actually, that is not problem.
Operating upfront,
Thank you, sir. Now we look at resident Dr. Saurav, Dr. Darsnik, Dr. Santosh, Dr. Sunil Bharat come up on the stage. And I will request Dr. Mohammad Ibrahimullah sir, Dr. Ansuman Pandey sir, Professor Piyush Sani sir to come up to moderate the session, sir. And the case will be presented by Dr. Payat. Good.
I'm presenting 55-year female with no comorbidities who underwent post-gastrectomy, distal gastrectomy with Ru and Y gastrojejunostomy indicated for adenocarcinoma of distal stomach, clinically T3N plus disease. Her post-op day 1 to 5 post-operative course was uneventful and patient was started on oral soft diet. Rice tube and intraoperatively placed central line were removed after securing peripheral line. On postoperative day 6, patient complained of multiple episodes of high-grade fever with chills, maximum of 101 degree Fahrenheit, along with single episode of non-bilious small amount vomiting. Her pulse was 114 beats per minute, blood pressure of 108/68, and respiratory rate of 24 per minute. Chest showed reduced by.
Let's stop here and think of what are the possibilities. We are day 5 of a distal gastrectomy for an adenocarcinoma. So what are the possibilities? We've got 4 people, give us 4. Mr. Modi. Okay.
SSI with the deep space, SSI. Organ space,
Okay.
You're not
Common thing is first
No, you don't want to think of common things. Okay. What else?
So the right drain shows bile. So first would be a duodenal stump blowout. Second can be a GJ leak, or third can be a JJ leak. No JJ.
JJ.
Sorry, either a duodenal stump blowout or a gastrojejunostom.
Okay. All right. So how would we proceed in any of these scenarios? What would you like to do? So you have some information there. You can look at that information.
It's fever, tachycardia. I want to resuscitate the patient. I will give IV fluids and antibiotics.
Okay. All right. What else do you want to do?
To look for RFT. Like to do a CT scan with an oral contrast.
You want to do a CT scan at this point in time. Why do you want to do a CT scan at this point in time? What do we expect to find which is going to help us change management at this point in time? So day 5, fine. Day 6, high-grade fever, chills, single episode of non-bilious, small amount of vomiting. Bowel sounds are still present, passing feces and flatus. All that you've got is some persistent soak of the dressing.
CT scan would show if this is a controlled fistula or if there are undrained collections in the abdomen as well.
Clinical examination.
Like to see the tenderness and signs of peritonitis. Here they have just mentioned distension.
The standard, you want to know whether there's any tenderness or is there any evidence of peritonitis? There's no evidence of peritonitis.
And secondly, the wound also. So they're revealing loosening of sheath. I would just like to examine the sheath as well. If there's more gaping, then I would like to remove the sutures and put a Bogota here at this point. If the bowel is visible between the sutures.
So can I do a bedside ultrasound?
Yeah, bedside ultrasound.
But we can.
Huh?
If facility is available, we can do bedside also to look for collections.
Facility is available. You don't have facility for bedside ultrasound. I'm sure you have facility for endoscopic ultrasound. You don't have facility for bedside ultrasound. Come along here.
First would be a bedside ultrasound to see any other undrained collections. And if
I'm quite happy to watch this patient for the next 4 to 6 hours rather than do an immediate ultrasound also. What is the rush? Blood pressure is stable, mild tachycardia, 1 episode of high-grade fever. What is the rush?
multiple. So and you can at least rule out any other undrained collection.
So you want to rule out an undrained collection which you would like to drain as early as possible. That is one possibility that you might find. Okay, what else?
I would also like to see the blood parameters.
You said what is the urgency in intervening or being proactive about managing? What is the urgency?
Have tachycardia.
So it's post-op day 6 now. First 5 days patient was stable. Now patient has deteriorated. That seems some event has happened that has led to complication now.
So duodenal blowout is a serious complication. You cannot sit over it or you cannot procrastinate. So that is why you have to be proactive about excluding or confirming if there is duodenal blowout or not. Any other leak you can sit over that, but duodenal leak is something which you cannot sit over.
Okay, so we do a bedside ultrasound and we see some fluid, periduodenal fluid. What do we do now?
We have to get a cross-sectional imaging, sir, at this point.
We'll do a cross-sectional imaging at this point.
So would you be bothered about the content, the nature and the amount of leak?
Yes, so there is 50 ml bilious content. However, there is some amount of
You
collection.
said something about that you should not procrastinate and you just need to intervene. Would you be having some other information from the history component and evaluation, the bedside evaluation ultrasound? What additional information would you want to know in this then? If you do a bedside ultrasound, if you're doing it for say 24 hours, what would you want to know about all this?
No, I would.
The amount of collection, cross, whether it is a contained thing or whether it is generalized. Now you would like to do a CT scan now.
There's only some fluid in the
And
parotid.
what would you want to know in the CT scan?
So
What are you looking for on CT scan? So, how will you confirm a duodenal stump blowout on a CT
Amount
scan?
of collection.
So you'll see fluid. What else will you see? You'll see a suture line break. You'll see the duodenal stump blowout.
F.
Air foci around the stump. May not see. If I see air foci on day 5 or day 6, what does it tell me? Tells me duodenal blowout, nothing else. So confirming, you see, the word you used was confirm it's duodenal blowout. How do I confirm it's a duodenal blowout?
Contrast.
Repeat which duodenal? The contrast that
You've done a distal gastrectomy, you've closed the duodenal stump, and you've done a Roux-en-Y gastroscopy. Your likelihood of your contrast reaching up to the duodenal stump and leaking out in a patient who's had a Roux-en-Y. So if I have distal obstruction, yes. If I don't have distal obstruction, may not happen. So if you rule out a GJ and a JJ leak, then the only possibility left is a duodenal stump leak. Is that what you're trying to say? In this clinical setting, so one possibility is you give oral contrast, you don't find a leak anywhere else, therefore you presume this is a duodenal blowout. Okay. All right, what else do you want to look for? So one was confirmed duodenal blowout.
If there is a large volume of collection despite the drain being, I would want to look if the tip of the drain is in the collection, or if it is not, then we would consider.
So you want to look at the size of the collection, you want to look at the location of the collection, you want to look at whether this collection is limited to a certain area of the abdomen or whether there's free fluid around it. You want to look at all these things? Okay. Then you want to look at where the drain is. First you want to look at how much fluid you've got, where you've got that fluid. And then you want to look at where the drain is placed. Okay. Suppose there's no drain now. The wound is leaking some 50-60 ml of purulent fluid and you have a collection on the ultrasound.
Okay.
So you'll do a percutaneous drain in everybody, or you'll choose a certain set of patients.
Stable patients, we can consider percutaneous drains.
In unstable patients, what would you like to do? You'd like to explore them?
Sir,
So you said, I didn't ask you whether the patient is stable or not. This is the patient in front of you. Said unstable patients. Stable patients you would put in a percutaneous drain. Unstable patients, what would you do? Stabilize them first. Good idea.
Patient post registration, patient who are stable means the leak varies. If it's significantly, obviously the percutaneous drain won't help, and if patient needs emergency laparotomy and lavage, because the leak is gross leak is there, that won't help to through the percutaneous drainage.
So, in this particular patient, there is an additional information that there is a wound dehiscence as well.
Yes.
Okay, so it's a basically uncontrolled fistula or uncontrolled leak. So here, I think the approach would be very straightforward rather than juggling between ultrasound and all this, isn't it? So how do you manage an uncontrolled leak of this nature? Do we have a CT scan of this patient? Was it done?
Yes, sir. We have one single cut. Sir.
Sure.
It is a snapshot, sir. We can see the collection in the subhepatic region.
Let them see. You don't see. Let them see. And then
Subhepatic collection with the drain in situ in the collection, sir.
The drain has seem to be in the marks.
yeah.
Not in the margins.
Well, is it coming out from the left side or right side? Not seen.
Connected. There's no.
Yeah, more cuts on.
No, we don't have mucus. It was from the left side.
Can we comment on the air adjacent to the head of the pancreas?
That is in the duodenal region, and there is some hyperdense
lesion just above the ear. Maybe that is the suture.
Staple suture. And do we see something adjacent to the left lobe of liver? The wound dehiscence component is there is some air there.
There it is tracker.
So is it
tracking
communicating, non-communicating?
Seems to be communicating.
The same content is tracking.
Dragging out, yeah. Any other information?
I think we're doing a lot of guesswork here, but with a single cut. I was you, I won't sort of venture into trying to guess, second guess, third guess what is happening here.
But definitely we do not see any contrast, which is seen in the or the remnant stomach.
So with this, what do you want to do? What are the possible things you could do? Wait and watch, do a conservative management, put in another drain, do a laparotomy. Are there other options other than these? Are there any other options other than these? So you want to do a laparotomy and do a lavage and place a drain more accurately? I don't know.
So just in addition, would you like to do something about the diurnal stump?
No, not that at this point of.
Anything more? Any supportive measure?
If we can see a prime obvious weak, then we can just put a tube inside the duodenum.
Tube ear dust. Anything more supportive in patients'
And feeding
management?
it
Yeah, if possible, if it is accessible easily.
clarity, maybe tension.
If it is initial technical failure, ischemia,
or the pre-existing ulcer disease on the duodenum, which might be the duodenum.
Okay, not in this context. Okay.
Improper blood loss more than 300 ml.
What's most important? Why does it happen?
Any distal stump,
Distal
distal obstruction.
Thinking of the anastomos, distal anastomos.
Long afferent limb, kinked, twisted. So the idea is to have a controlled fistula. That is what you want to say. So what are the options? Control it. You'll just do a lavage and put in a drain, or you would like to have a control on it?
So definitely control the. We'll control the fistula and monitor the drain output.
So give us the option.
I would want to follow an algorithmic approach. So initially I would want to treat the species of family for antivirals and do a cognitive history. If even after putting a cognitive history, this patient does not improve directly, or there is a deterioration of his vital parameters or a raise in leukocytic counts, or there is still evidence of peritonitis, that is when I would consider doing an exploratory checkup with lavage and fine.
Postoperative day 6. When do you expect this thing to come down or heal on its own, or would you like to do something about it?
It will take 2 to 4 weeks to settle.
Provided you take care of the sepsis control, the source control, or control fistula and nutrition. Yeah.
Next, please. Thirty-eight-year female with no comorbidities underwent total gastrectomy with Roux by esophagogynostomy with NJ placement indicated for adenocarcinoma, body of stomach, clinical T3 and plus disease. Post-op day 1 to 6 were uneven full except for persistent tachycardia with range between 100 to 110 beats per minute. She was started on NJ feeding at 1.5 to 2 liters per day from day 3 and oral clear liquids which she tolerated. Duodenal stump side drain was uh, uh, draining around 100 ml serous fluid output initially, which gradually reduced to 50 ml serous and was removed by post-op day 5. And EJ side drain was draining 150 ml serous fluid per day. Central line was removed after securing the peripheral line. This is the scenario on day 7 when she has complaints of difficulty in breathing, multiple episodes of low-grade fever, a maximum of 100.5 degree Fahrenheit.
Yeah, what do you think is the possibility?
With the fluid coming from EJ side drain, sir. Because it is not anastomotically.
How can you confirm that? How will you confirm that?
The second.
Take the mic.
To get a chest X-ray done and see how much amount of collection is there in the left side of the chest, because that can also be a cause of that is likely a cause of difficulty in breathing and multiple episodes of fever. Then secondly, I would like to consider a EJ side.
Consider?
The drain. Then secondly, I would like to go for think of a EJ anastomotic could be. Firstly, I would like to consider the chest.
That's fine. So how do you confirm the lead?
So we can give a oral contrast and see.
Use mic. Others can.
We can just at the bedside give methylene blue to this patient and see if there's staining of the drain.
So serous discharge, what are the other possibilities? It's not a confirmed leak as now because the patient was tolerating only. There were no significant signs. Can there be something else, lymphatic or some origin of serous discharge?
The nature of the fluid mentioned is turbid, not milky white. Except that it could still be lymphatic fluid.
Yeah. As nature of it is turbid, it can be chylate also.
So one thing she said was chest. The other thing we call as EJ leak, and then there can be a lymphatic source also. So is there a bedside test or something like that which you can confirm?
We can add ether to the fluid.
Ether.
For ruling out a chyle as the drain out. And if there's dissolution of the turbidity, and if it becomes clear.
Is
and
there available? Find it hard to
we still do this. And we can also send the fluid for triglyceride levels.
As in 110 mg per day. Confirms.
Okay. Anything else to do to confirm the leak?
A gastrocapin study.
Gastro.
Contrast study.
Contrast study. Contrast planes now X-ray or CT scan. What would you prefer?
Sir, fluoroscopy.
I'd like to do a CT with an contrast. CT with an oral contrast.
What is desirable? What information would you expect? CT scan? Collection elsewhere or confirming whether it's a controlled leak or uncontrolled leak.
Sir, I have a query. Like patient is already on NJ. So we can just continue the NJ feeds and get a chest X-ray done, drain the left-sided pleural effusion, watch the.
I should ask you the manager.
I mean, I'm just.
At the stage of. So how do you know what next would you do for this patient? Come on, like what you're saying.
Like to get a chest X-ray done, quantify the pleural effusion, drain the pleural effusion, and continue the NJ feeds. If the patient doesn't improve in next 24 to 48 hours, then I would like to go for a contrast, oral CECT abdomen and chest with oral contrast.
So do you have a chest X-ray?
Yes. Blunting of the postoperative angle
So that's the chest X-ray in front of you. Now what do you want to do?
Is CT scan important here after looking at this chest X-ray?
No, we just
Will you be happy with this or you do a CT scan to have more information? So if it is a left-sided diffusion, there's a possibility of subdiaphragmatic collection on the left side as well. So that you would at least exclude by doing a CT scan. So if none is there, then obviously you treat this diffusion. So what would you do with this?
So put a tube into this diffusion, and what you start getting is a bit of what seems like a little bit of bile there. Possible? Possible. You've done a total gastrectomy, you've done a gastrectomy, you may have opened the pleura, the lower end, and now you've got a leak there. The CT shows you no collection there, but shows you some slight yellowish, light yellowish tinge on the drain that you put into the pleural cavity. What do we do next?
see the amount of collection and the patient's general conditions.
Okay. So patient's general condition is in front of you. Day 6, day 7, unless she deteriorates dramatically, has a pulse rate of 140 and a blood pressure of 80 millimeters of mercury, or suddenly a saturation dropped. Don't expect a major change there. So what do you want to do? This is day 7. Do you want to start an antibiotic? Okay. What else do you want to do? You want to send up some investigations?
Blood culture as well as the drain, the chest fluid culture.
Okay. Anything else you want to do? So if you've done a CT, shall we look at the CT? Dr. Brar wanted a CT early on. So let's look at the CT.
So you want a blood culture?
Yeah, that's it.
So these are the only cuts that we have?
Yes, sir.
Okay. So based on these 2 cuts, without second guessing what else it could be, let's try and read this and see what it is.
Subdiaphragmatic collection. There is gross left subdiaphragmatic collection. Okay.
The drain in situ, and there is a drain in the collection, and it is air containing collection, so likely an anastomotic.
So if I have a drain in the collection, I get air from outside, I could get air from the leak. No? I fiddle around with the drain, I pull it, push it. Yeah, there's not enough coming there, so I try and compress it, twist it around, push in a bit of air just before I get the CT done. Okay, so what should we do now? Or do something or nothing. So again, like the last time, we've got 2 or 3 possibilities. So let's look at those possibilities and decide what we want to do. Algorithmic approach. What an algorithmic approach. So let's do an algorithmic approach.
I would want to start this patient on empirical antibiotics, and then based on the cultures that we have sent, step up to those. I would want to continue to hydrate the patient, ensure nutrition via the NG. And the drain is draining just 75 ml per day, and there is still a significant collection. So probably it is not adequate to drain this collection.
I give 1.5 liters of NJ. Now I see some milky stuff coming out into the drain.
Then it
happens. Don't tell me it isn't. You've never seen that happen. What do I do now? Stop the NJ. How do I feed now? Change the tube.
MCT based diet is what we would want to give in this case.
What is that?
this leak.
No. The leak, whitish leak he meant is the feed.
The feed is refluxing back.
Usually it's a milk-based feed and that is draining out. That is not correct.
Anastomotic leaks can be, the leak should be graded according to the extent of the leak, either it's less than 10% or 10 to 50% or more than 50%.
Practical. Do you do that? When you sit down at the bedside and you assess whether the disruption is X, Y, or Z amount?
What do you do?
So the feed is coming out and 1 liter. Sir, you mentioned how much?
I said I've given 1.5 liters of feed and there's feed coming out. I will not say milky white fluid. I'm saying feed is now coming out of the drain. What should I do?
There is an anastomotic disruption. So.
Okay, it could be an anastomotic. Anyway, what do you want to do? So yesterday, today, don't give us an explanation. Tell us what to do. What should I do? Stop the feed or continue the feed? Stop the feed. How do I manage the nutrition now? Basic TP. Huh? Parental nutrition. Okay, that is one possibility. What else can I do? What else should I do?
Be a little practical. Control. Use collection despite the drain. Would you not like to drain that? It's a significant amount of collection, undrained collection, despite the drain. So that takes priority over anything else now.
Yes.
Only having dealt with that, you would think of nutrition and other supportive measures. But first focus would be on that collection itself. So how do you manage that?
USG guided percutaneous trained for that collection.
Ultrasound guided. Do you think it will help? Because despite such a wide caliber drain, it's still,
Despite having put the drain, if there is still a collection on subsequent imaging, then the only option left with re-exploratory laparotomy, give a drain again, and drain the collection. Do a FJN
feeding is lost in it. Fine.
So I think your intervention has always got to be graded. Don't be trigger happy and don't intervene too early. Look at what happens to, so that's why I said algorithmic approach. You start antibiotics, you wait and watch, you see the patient stabilizing, you don't do anything. You don't see the patient stabilizing, you assess whether your collections got drained out by that time or not. You reposition the tube, that doesn't help. You could consider doing a percutaneous drain, but if your ultrasonologist tells you, oh, your CT, so this seems to have debris within it, may not be able to drain it properly except by doing a lavage. But if there is a collection which looks like pure fluid, there isn't much debris in it, you could upsize the catheter and see if that helps. Going in and doing another laparotomy is not necessarily the answer always. There will be times when you will have to do it, but don't be trigger happy.
Thank you, sir. Sir, now I request Rahul sir to announce put anything about the quiz program.
So yesterday we organized the first round of the quiz and the results are out. So we'll be displaying the results. There are 8 people who have been chosen for the final round. So it is rank 1 to 8. There was clash at the 8th rank, but the person who had push. So here is the list of the qualifier. So rank 1 was Dr. Anup Singh from DLK Max Delhi. He scored 91 marks. Dr. Yasnadat Sarangi from SGPGIMS scored 73. Dr. Lavina Balani from SGPGI scored 70. Dr. Ashirvad Panda from Apollo Hospital, Bhubaneswar scored 64. Dr. K. Prashant from SGPGI scored 61. Dr. SBJ Praveen Kumar from AIJ Hyderabad, who scored 56. Praveen Agarwal from Fortis Hospital, Delhi, probably, who scored 52. Are you all there? Can you please raise your hands? So, Anup Singh, yes. Yajnadat is here, Lavina is here, Ashirvad Panda, K. Prashant is here, SBJ Praveen Kumar, Praveen Agarwal, and Dr. Ruchir Bhavsar from Yashoda Hospital. Are you there? Yes, very good. So congratulations to the winner, but this is not the final round. The final round will be in the evening at 5 o'clock, and it will be an interesting round for everybody. So this is the team up. Rank 1 and rank 8 are together. This A, B, C, D will be decided later on. So that will be by chit system. So rank 1 and rank 8, Dr. Ruchir Bhavsar and Dr. Anup Singh. You will team up as one team. Dr. Praveen Agarwal is rank 2 and Dr. Yajnadat Sarangi and Dr. Praveen Agarwal, rank 2 and rank 7. Dr. Lavina and Dr. SBG Praveen, they are rank 3 and 6. And rank 4 and 5 have teamed up as team 4. So be ready for the sessions. There will be 4 rounds. We'll be telling you the rules as the round progresses. And so all the best. Try to prepare if you want to. You can team up, you can decide what to do. So please go ahead with the sessions. Thank you so much.
One important announcement. I request all respected faculties and all delegates to gather in the lunchroom in front of the auditorium only for group photograph before lunch. That means around 12:30. It is a sincere request. And all SGPGI faculties and residents to be gathered after lunch for SGPGI group photograph. Sincere request, please to be followed. Okay. Now I request for next session, Dr. Karthik, Dr. Ashlibad, Dr. Rahul, Dr. Tarun to the stage. And now I'll request Dr. Shivanshi Singh sir, Dr. K.D. Yadav sir, Dr. Mohammad Ibrahim sir, and Dr. Lavina Supeza to moderate the session, sir. Thank you, sir. And Dr. Lavina will present the case.
Actually, sir, to lead it.
Yes, who is going to present? Lavina.
Morning, everyone. So we have a patient of 34-year-old female, homemaker, resident of Bihar, presenting with chief complaint of pain abdomen on and off for 8 months, intermittent melena for 4 months, and abdominal distension since 4 days. History of presenting in this patient was apparently asymptomatic 8 months back when she developed pain abdomen, which was insidious in onset, intermittent, colicky in nature, diffuse in all over the abdomen, mild to moderate in intensity, lasting for 1 to 2 hours, and partially relieved with oral medication or passage of flatus or stool. It was associated with history of melena for past 4 months. It was 5 episodes lasting for 4 to 6 days, followed by normal colic stool passage. It was not associated with postal hypertension or not requiring any blood transfusion. Since 4 days, she was having abdominal distension, insidious onset, gradually increasing, diffuse, aggravated by food intake. It was associated with colicky abdominal pain, obstipation, and multiple episodes of small bowel bilious vomiting. There was the history of diet modification present to the liquid diet, history of Bourgogne present, history of loss of weight of 10 kg in 6 months present. There was no history of hematopoiesis or hematuria, no history of respiratory discomfort, hemoptysis, bony pain or backache, no history of jaundice, seizures or altered sensorium. Past history, there was no medical comorbidities. There was history of abdominal hysterectomy for fibroid uterus 4 years back. Family history not significant. Personal history, sleep was normal, consumes mixed diet, and there was no history of intake of alcohol or smoking. On general physical examination, she was averagely built with BMI of 19.5 kg per meter square with weight of 50 kg.
ECOG 0, breath holding time of 35 seconds, no pallor, lymphadenopathy.
Based on the history, what is coming to your mind?
The history. So based on the history, since patient is having some intermittent subacute intestinal obstruction over the period of 8 months, sir, and with multiple times patient is passed blood is malignant.
What is coming to your mind in terms of diagnosis?
Sir, it can be a small bowel cyst, sir, and having intermittent obstruction is for interstitial or luminal obstruction. Secondly, ileocecal TB, sir, or a due to malignancy, right-sided malignancy, sir.
Why you are seeing ileocecal tuberculosis?
Sir, it's a long history, sir, 8 months, sir. Young female, sir. That is why
Is bleeding common with tuberculosis?
no, sir, not common, sir.
Why is it not common? Why tuberculosis do not bleed?
So because mostly hypertrophic mucosal obstruction,
Not common is bleeding, or it is not common, why it is not common?
it's not proliferative, sir, it's all.
Why tuberculosis do not present with bleeding usually?
Because
Artery.
sir, there is melanoma, in short. So small bowel cyst can present with
Very common diagnosis you should make. It's the first time.
It is not common, sir, but there is a long history, 8 months.
It's when those common with this.
Sir, what the patient is having recurrent pain abdomen, so patient may not be unable to take proper nutrition.
Small tumor. Yes.
It's not a good way to start with the first diagnosis with a uncommon kind of condition. Maybe possibilities there, but I would not really appreciate anybody starting with that kind of a diagnosis.
So both components are there. There is a bleed, there is a subacute obstruction. So usually the gist is what?
It is mostly, sir, bleeding, small bowel cyst and mostly bleeding.
So usually it is not involving the mucosa. So how come it will narrow down the lumen and produce this type of obstruction?
Most likely, endophytic cyst can produce obstruction or interception due to endophytic.
Interception, for interception, size has to be very small, for any small bowel. Are you thinking intercepting where?
Small bowel intercepting into small bowel, sir, ileum, distal ileum. Yes.
Theoretically possible, but the first
Whether you call it benign or malignant, I mean, this is a big question. To make a first diagnosis of malignant also, because of a long history, you may say, I don't really think, but possibility is there, but that's where you keep yourself open, benign or malignant. But it's definitely a lesion which has bleeding and obstruction, both components are there. So gist is very unlikely, and tuberculosis also is not very common.
What?
Yes.
What did you say about second diagnosis?
Sir, inflammatory bowel disease can be the possibility in this patient because patient is young age with obstructive pattern and also there is a history of melanoma on and off. There's a long history of 8 months. So it can be the possibility of
this won't be a possibility. What is the common presentation of inflammatory bowel disease? Is it bleeding
So bloody diarrhea is a common presentation, but Crohn's disease can also present like yes. So it can be a diagnosis.
But obstructive pathology and
Sir, small bowel Crohn's disease can be the possibility. I am not taking up it the first diagnosis, but sir, it can be the possibility.
Small bowel Crohn's, what is the commonest involvement?
Ileocecal, sir.
So what are the structural lesion, ulcerative lesion, what is the common in those?
So ulcerative lesion.
Ulcerative
Lesion leading to strictures, it can be leading to stricture of fistulas, but initially it is an ulceration, then leading to stricture and fistula.
Initially there is a bleeding history.
So initially it can not, but yes, melena can happen.
You decided that I will say Crohn's and I will fit everything in that.
No, the young age.
You have seen any patient of Crohn's presenting with the bleed, especially small bowel Crohn's.
So melena can happen.
Melena is also a terminology, doctor. Can happen, anything can happen. But what is we talk about common things occur commonly. Rare things do occur though rarely.
Yes, the first thing is tuberculosis, then melena and right side malignancy. Sir. We cannot rule out the malignancy also.
To right side malignancy, what are the common presentation?
Sir, it's a bleeding in the form of melena or and
combination is occult bleed, anemia, or
anemia, sir. Anemia and in the form of melena, also where the patient can present early, and in the later stages, obstruction can. In advanced disease, advanced disease, yes.
Or other form of obstruction can occur in any other area. Small bowel, that is the right side colon malignancy.
So intussusception can also cause the lesion that causing the intussusception can also cause obstruction.
The huge lesion involving ileocecal junction also can produce obstruction.
Yes, sir, that can
also obstruction rather than intussusception is there.
Yes. Cecal carcinoma involving the ileocecal junction.
Can you show the examination finding? Yes.
She is averagely built with BMI of 19.5 kg per meter square, echo of 0, breath holding time of 35 seconds. There is no pallor, lymphadenopathy, pedal edema, cyanosis of clubbing, no enlarged left supraclavicular nodes. Patient is vitally stable and afebrile. On per abdomen examination inspection, abdomen is distended with umbilicus centrally placed in position and inverted. All quadrants move correspondingly with respiration. There is no visible peristalsis, sinus and gauze vein. There is a lower midline scar of previous surgery. Hernial orifice and external genitalia appears normal. On palpation, abdomen is distended and non-tender. There is no palpable lump or hepatosplenomegaly. There is no evidence of guarding rigidity or peritonism. Surgical scar healthy with no cuff impulse. On percussion, liver dullness, upper border palpable at 5th intercostal space with liver span of 13 centimeter in right mid-clavicular line, flanks are tympanic. On auscultation, bowel sounds was found to be exaggerated. On digital rectal examination, rectum was collapsed with normal sphincter tone, love stained with colic stools with no palpable growth of pelvic. All the systemic examination was found to be normal.
You get any lead from the examination?
Bowels are exaggerated. History of bowel is present, so I would like to admit this patient first and secure IV cannula, give IV fluids, sedate the patient, and then later think of the investigating the patient further. Right. Sir, for the past 4 days, that is vomiting also, 200, 400 ml, and the bowel sounds are also exaggerated. That's all.
Any clue in the history about the type of surgery which is done?
They have given that she has undergone hysterectomy for fibroids 4 years.
So if I say this is because of the adhesive obstruction.
Possible. Most common obstruction is adhesive obstruction. In colonic, it is less common, sir, because initially the downward distension occurs first, and once the obstruction is proximally up to the duodenum, then only probably patient will have bilious vomiting. So the first that's why. Sir, I said that the patient is in obstruction. I have not said that patient is in colonic obstruction. Given the history and examination, I am saying that patient is in obstruction. I will admit the patient, resuscitate the patient, and then do a blood investigations first before jumping on to the other things.
Then what is your diagnosis now? That if you are saying you are only admitting that she is obstructed, but you are not sure that whether it is because of colonic. So what are the reasons for obstruction?
So do you really think that you're thinking that the pathology of obstruction and bleeding is separate and adhesive obstruction is separate, or they are related to each other?
But I can think of right now, sir, since the vomiting is bilious and patient is in obstruction for the last 4 days and the history is long standing for the last 8 months, and she has undergone a surgery previously for 4 years ago. So the history is not per se fitting into a colonic obstruction per se, but so yes, since most common cause of obstruction is adhesive obstruction, I'll still say that it is adhesive obstruction. Given the history of abdominal distension, pain abdomen and bleeding,
First tell what is your thinking process, then explain.
Patient
Your explanation is too long to remember. So first give this is my thing, then explain why I am saying that.
The patient is in obstruction right now, and the most common cause of obstruction is adhesive obstruction. So I think in that terms, but the history is also points towards the second pathology. So I'll keep that also in my mind that the possibility, the obstruction can be because of that, given the history scenario, right colonic malignancy is also there. Right colonic malignancy. Given the history.
Adhesive obstruction is an incidental finding. You don't have to regularly. How common is adhesive obstruction of hysterectomy? And in this patient, there is a long-standing history of pain, anemia, morbidity, everything fits into a colonic obstruction rather than an adhesive
Right-sided malignancy. Do right-sided malignancy obstruct or left-sided?
Most commonly left-sided obstructs, but because they are constricting those, but right side can also present with obstruction.
So if I say that there is a colonic malignancy and what are the colon which are adjacent to the small bowel, which can be infiltrated or because of the tumor coming to the surface, the small bowel can come and interrupt. Any small bowel which is in very close proximity with the colon. The idea is different. What about proximal jejunum? If there is a tumor close to stomach pressure,
Sir, for proximal jejunal obstruction, the history does not fit into the upper GI obstruction. So because there is no recurrent obstruction, the patient is having on and off obstruction. There is a long history and the patient is not having a recurrent obstruction on every feeding.
Pain is for last 8 months and the vomiting is just for the
And there is distension of abdomen also.
Vomiting first and then distension.
Yes.
so the question is saying if you put a lens tube, proximal obstruction will disappear. So it has not gone. So proximal obstruction doesn't seem to be possible. So you have to think about this.
Next, what investigation for
Sir, patient has been previously investigated with the reports. I want to see those reports.
What investigation would you have advised?
Sir, at present, sir, I will advise an X-ray abdomen to be done, if possible, at bedside.
And blood investigation, sir. Blood hemogram, CBC, complete.
When you are asked about investigation, you have to talk about diagnostic investigation first. Rest of can happen as a part of the management.
So then I will go for a CCT, sir. CCT of whole abdomen, sir.
presenting with bleeding melena. So,
Patient is in obstruction, sir.
management. Initially, we're talking about diagnosis, right? Ask you like what you do to diagnose this patient. I mean,
Sir, patient is in obstructions. I thought we better will.
X-ray abdomen accepted. Fine. So I give you an impression about what is the level of obstruction. Maybe you might give you an
Might, sir, but confirmatory would be from CCT whole abdomen, sir. After that, I can go for, if obstruction relieves, I can go for the colonoscopy.
history of bleeding or melena.
Yes, sir, to evaluate.
Would you do a scopy rather than?
So colonoscopy can be done initially, but patient is in obstruction, so we will not do colonoscopy at this stage.
How is that colonoscopy going to work?
So there is a gaseous distension. Already patient has having gaseous distension.
Retrograde to the obstruction. Is it going to really matter?
So if the patient is having partial obstruction, then yes, sir, it can pass. Yes.
If it is partial obstruction, it will go and come out also. So where's the? You can
So then colonoscopy
have difficulty in preparing this bowel, but all the same, since this is obstructed, there may not be anything much residue distally. So you can still attempt colonoscopy. I mean, I think it would go for it. Yes, I mean, how will you forming is to go for it? Yes,
So non-invasive investigation is better to do first than an invasive investigation in the case of acute obstruction. If it is has been a non-obstructed cases, then I would like to do diagnostic. So then we will fall into a trap that if we come into the colonoscopy, then they say that, okay. See, for diagnosis,
Contraster, you will not give oral
will
contrast.
not give an. The point is, you should not do the CBC and see the yes, sir. Yes, blood investigations, then RFT also.
Come with the GI, upper GI, lower GI, and everything property will be hard, even then that I will first see the because there is a history of the
but this is the intermittent bleed over 8 months time. It's not so unstable that you need to stabilize the milk by giving blood and then 6.9
the patient is having low hemoglobin of 6.9 with a normal TLC count of 5,500 and normal platelet count, and raised platelet count of 7 lakh, and INR is normal. The patient is having anemia, severe anemia. The activity is within normal limits. LFT is total bilirubin is low. Total albumin level is 2.1 and that is low. And the other parameters, albumin is reversed, AG ratio is reversed, and is because of chronic inflammation and chronic.
What diagnostic investigation will be? Anything CT scan or colonoscopy?
So we have both. First, I'm showing the CT scan.
This is the non-contrast CT the axial scans showing the standard stomach and the standard duodenum also. The large colonic distension, right colon distension, and there is no fluid till now. I would love to see the fluid. Pelvis, there is a minimal fluid in the pelvis, sir. And I would like to see the vascular calcification or aortic calcification. Aortic calcification. No calcification. You are also seeing any point from the transition to. Sir, I would like to comment on it on. Still you can make it out, bro. Sir, there is a distended right colon, sir. So probably distal to the hepatic flexure or so hepatic flexure most likely is collapsed. Most likely, sir, hepatic flexure malignancy, but I would like to comment on contrast phase. What about the small bowel? Small bowel is standard. Stomach and duodenum is diabetic. So what does it mean? That means that there is hepatic flexure malignancy leading to backflow obstruction and complete.
The duodenum is distended, not.
Duodenum is distended and is not responsible for the
Duodenum is reverse order.
minus to the junction to the ureter. Is the infiltration of the duodenum or is it the complete backflow of the duodenum stage?
So let
Because up to duodenum, the stomach is distended, duodenum is distended. Stomach doesn't look like distended.
from IC to duodenum as the contrast shows from CCT axial scans and showing the arterial phase and photovenous phase, mixed phase is there. And
Why are you saying arterial?
sir, there is a mixed phase, sir. Because the portal vein and arterial phase, arteries are both are. Small bowel is. I would like to see the lesion on the hepatic flexure side. So there is a heterogeneously enhancing lesion in the hepatic flexure. Yes. Hepatic flexure side. There is a fat place with the duodenum are contained at this point. I will go to see. So the fat planes with the duodenum are maintained, and I would like to see the whole transverse. Transverse colon is collapsed.
You follow the stomach of the duodenum.
So fat planes are maintained at this point. Fat planes are maintained with the duodenum, and
D3 is fine, but D2, D3.
please go up. So this is the caudal lobe. I think that it's with the malignancy it's
You follow the stomach. Negative contrast is, yeah, go on following.
there is a collapse in the distal part of the D3, but not with the hepatic flexure. So there is a collapse in the part, but fat planes with the malignancy is maintained, sir. And there is a fat stranding also, sir, along the hepatic flexure side. I would like to see the aortocable lymph nodes also, and lymph nodes along the.
Why you want to see aortocable? Use the spellings and the aortocable.
The aortocable lymph nodes, A1 aorto and A2 aortocable lymph nodes are distant lymph nodes for the right malignancy. So if they are enlarged, then yes, sir, it is a distant metastasis there.
So first I think you should talk about lymph nodes which are.
Yes, sir, I will see that also.
Yes. Then you will talk about
Yes.
And what more information?
Sir, liver, I would like to see the liver also. And And there is a ascites are already, we have talked in the minimal ascites in the, so in the pelvis, sir, is the ascites fluid. Minimal fluid in the, yes, this.
Can you explain that?
Yes, sir, it can be because of obstruction and malnutrition also, and it can be because of malignancy also.
Likely.
I'd like to pull out that. Sir, hypoechoic irregular, hypertense irregular, and with peripheral margin enhanced. Sir, T3 disease with malignancy with N1 probably, and sir, I have not looked up the lymph node, sorry sir. So that I have to look also.
Did not do a colonoscopy or still not do?
No, sir, we will not do the colonoscopy.
Sir, after placing the tubes, stabilizing the patient, can go for a colonoscopy, and after that, have the look at the morphology of the mass, and we can, after that, we can go for a, at least for palliative resection for obstruction.
Management changed colonoscopy, no, so I know, but we can do that way to preoperative plus the specimen also because this patient is definitely developed right.
All the TTS. Sir, all the if we can
Yeah, it's very. I think why are you so against doing colonoscopy? I mean, two of you are.
You have admitted the patient, you imobilized, you are saying that his mother is and the colon is dilated towards the right side.
So cecum is distended almost 9 centimeters as per I can see is positively distended. Tissue biopsy.
To rule out any synchronous lesions and know the extent of the disease. Any underlying disease, sir, any underlying disease. Yes, definitely.
Unless we step forward to the patient to the management,
you are going for a life-saving surgery right now. In a patient like this.
So patient is
in fact,
I will like to answer this.
you are going retrograde. Yes.
Obstruction is at the level of the malignancy, right side is dilation. There is a constant overlap because there is a close to obstruction type thing. You started putting whereas distance from what the distance to the tumor, which is almost taken over the whole tumor. So how we are going and cutting both damage to the cecum? Very illogical answer you are giving and you are persisting with that. That is the most. Is that
I just add one more thing. I mean, in fact, I'll go one step forward. Others may not agree with me. In fact, I'll do an endoscopy also in this patient after putting a rice tube in the stomach. Because duodenum is very close to the tumor. I want to exclude it.
But there is also yes, because what you said there is a pain, but there may not be a pain. Why this is dilated after that there is
I will not do a colonoscopy because patient is clinically obstructed. significant obstruction. I will not do it. I will investigate the rest of the colon later on once the investigation is complete. That is our approach will not do this. Because again, it might be possible, but many times because of malformation, it not be possible to do. And also, chances of finding synchronous polyps is around 10%, and synchronous pregnancy is less than 5%. You will find. So for 5 to 10% and with inadequate malformation, I will be hesitant to do any colonoscopy. We'll plan for surgery after stabilization and improving, and then our
colonoscopy shows ultra-proliferative lesion at the hepatic pleasure, biopsy taken, and rest of the colon they might have gone beyond the malignancy.
Previously, patient is suspected now. See, problems before that he was not aware.
We don't know to see. We don't know the data.
There. Now waiting for the loss.
What is your
Sir,
The anti status also. The differentiation. The still prognosis, it will not change the management, but prognosis, it will be poor prognosis with poor. So I would like to counsel the patient pre-operatively with the different prognosis, if it is a well differentiated and with the poor differentiated.
You have a very different spectrum. So at one place you don't want to colonoscopy, and then at the other place you don't want differentiation in abstract.
If it is done, then sir, I would like it. If it is done. Sir, I would like to do upper GI endoscopy also. So because there is only dilatation of the duodenum, I would like to rule out any other synchronous malignancy over there also. If it is done.
So we don't have the report, but it was saying only the localized lesion was there at the hepatic pleasure.
Only action section is could not see. I think seeing a colon section will give a much better idea of which whether obstruction is there, which bowel leaves are dilated. I think we should always ask coronal section for these patients. Not all
Yeah.
Yes, sir, that and those cancer I was not able to find any infiltration, but yes, sir, coronal sagittal scans can help, sir.
The suspicion was definitely there.
Suspicion was there. I'd like to do upper GI endoscopy. Oh, so is there any ulceration over there? Is there a lesion? Mucosa is intact. I will suspect that even if the endoscopy is, CT scan does not show any infiltration, I will suspect that there might be some infiltration over there, and that causing the external compression and external compression. It will change that if there is infiltration that we might have to do for artery dissection, we might have to do extensive dissection. And if it is only compression and the fat planes are there, then intraoperatively we will be able to find it. Sir, at this stage, no. At this stage, we have to, because patient is obstructed.
IASG.
So I would like to remove the colon and investigate. Sir, no. If it is T4B, then yes. T4B and 3. Yes. And 3. Bulky tumor is there, sir. If it is infiltrating also, it is right now out of the body.
So Foxtrot plan.
The T4B and 3 disease and M1D. Yes, sir. No, sir, because it is different dynamic. It is acutely obstructed lesion. No, sir. It is a closed loop. Then also there is a chance that patient might have. It can, sir, gangrene.
What are the other evaluation, other urgent investigation we do before planning service?
Chest and chest. I would like to see the CT chest or HRCT chest.
In the beginning, we
no, sir. Actually, abdominal CT scan was opened up directly, but it did not say about that.
But you have to say when you are doing one CT scan.
Yes.
After you see the finding, you are not going back and doing another CT.
No, yes, sir.
CT chest abdomen and pelvis.
Yes.
And then CA level, how it is going to the
CA level, sir, it will decide that it is better for prognosis and then the follow-up of the patient and the recurrence. And patient is having high CA levels, then we might need PET-CT. If initially there is a high, then we can go for PET-CT directly in spite of CCT.
You are seeing the
It's raised, sir. So if it is because we have to do blood investigation first, then if I got the blood investigation first, then I would like to.
PET scan after
Yes,
this.
sir. Yes,
But
PET
patient is
CT.
obstructed. So you have to treat at that time for obstruction.
And still, sir, at this stage, I would like to know the staging properly. And then if CCT can be done, RFT is normal, I would like to do the PET-CT and then go for the dissection.
We have got your section.
Yes.
The patient has to wait another 2 months. Then before starting, then again you will need a staging. Why you want to based again PET scan at this point?
Sir, I would like I want to do a neoadjuvant therapy for this patient, right? Go for the dissection in spite of PET-CT. But if the patient is having high CA, I would like that. I'm suspecting that it might have metastatic disease. And so I would like to stage the disease at this point so that I can prognosticate and counsel the patient and the attendants. What is your stage at this point and how it gonna react in the further future? Yes.
Just importance of CA, just tell me 3 sentences.
Sir,
prognostic value, what in what instance it is increased, raised, and what is the importance of it? Has it got anything to do with the differentiation of the tumor?
Yes, sir. In non-smoker it is less than 3. In non-smokers it is less than 5. And sir, it is for the prognostication and then the follow-up. If it is
in what percentage you get elevated or it is not elevated?
20%, yes. The 20%, 15 to
Elevated or not elevated?
Elevated. Yes, sir. Poorly differentiation also it shows, and sir, it shows that in recurrence also in the follow after the surgery follow-up we can get the early recurrence. Yes. I would like to do the diagnostic lab. There is a ascites in this patient. I would like to do the cytology. Negative cytology.
Diagnostic lab in this patient. Obstructed patient. Why are you going diverting all this,
Sir, this patient physical status, patient physical status allows I'll go for a right extended hemicolectomy. I'll note the entry of findings, if any peritoneal metastasis or peritoneal seedling or liver improvement with a diverting ileostomy.
Sir, D3 CMV with serial. D3 CMV with serial. D3. Sir, says that in T3 cancer, more than T3 N1 disease, if or imaging, a patient have central group of lymph node, there are chances that 10% of the patient might have central group of lymph node that we can leave if we do D2 lymphadenectomy. With D3 lymphadenectomy, we can get with those. Sir, with overall survival and disease-free survival, there is no change with respect to D2, D3, but yes, with recurrence, there is a high chance of recurrence in 5 to 10% of the patients if we do D2 in T3 N1 diseases. Sir, yes, sir. Last. Yes. Survival is same. Yes. Yes. And
why do we extensively staging laparoscopy? What is the harm? Do laparoscopy, you find particular disease there.
Sir, because it is obstructed, so
you do a colonoscopy, you start chemotherapy. Why you want to do extensive surgery when the peritoneal mets are there, which is not curative surgery?
no, the peritoneal mets are not there.
Why not do laparoscopy? There is free fluid is there. On laparoscopy, you find peritoneal disease there. Then what you do?
Sir, then I would like to go for resection only, and then sir, chemotherapy followed by adjuvant.
Laparoscopy will have that transfers for your suspected duodenum involvement is there or not. You can assess if the duodenum is also respiratory involved or pupilling is there at the root of mesentery. You don't want to do extensive resection when the patient is obstructed with low hemoglobin and hemoglobin.
No, but
is it standard practice?
In obstructed cases, I would like to not do in diagnostic lab.
At least an exam stick to standard practice. Other than
so it depends. T3 and 1, stage 3. So low risk perhaps. It is high risk or stage 3 disease will give adjuvant for the 6 months perioperative.
Yes, sir. In case of
stage 2.
high.
In MSI, sir, if the patient is stage 2, then we may not. Thank you, sir.
Now I request Dr. Praveen Agrawal, Dr. Rahul Ashok Misra, Dr. Praveen Kumar Reddy, and Dr. Prashant Kumar to come up on the stage for post-op scenario. I'll request Professor Piyush Sahni sir, Dr. Ansuman Pandey sir, and Dr. Chetan Kankriya sir to moderate the session. And Dr. Lavina will present the post-op scenario.
We have a patient of 26-year-old female without any comorbidities with diagnosis of acute severe necrotizing pancreatitis with respiratory failure, acute kidney injury, and on inotropic support. with colonic perforation, status post PCD placement. She was operated on day 46 of onset of pancreatitis. Procedure done was open necrosectomy with loop ileostomy with feeding genostomy. She was shifted to critical care medicine department. From post-op day 1 to 3, inotrophily stopped, pH and lactates levels normalized, urine output was febrile, extubated on day 3, and from day 4, she had sanguineous output of around 600 ml in intraoperatively placed drain in peripancreatic region with difficulty in breathing. On examination, pulse rate was 140 beats per minute, BP, starting of inotropic support of NORAD, double strength at 10 ml per hour, respiratory rate was 28 per minute, and saturation was 95% on 10 liters of face masks. On respiratory system examination, auscultation bilateral lower zone air entry was reduced with crepitations present, and she was using accessory muscles for respiration. On abdominal examination, Bagota bag was present, and peripancreatic drain was draining sanguineous output with few clots were present in the main bone. Stoma was grossly normal. Input, she was tolerating 1000 ml of FJ feed. Other than that, IV fluids and drugs were given. Total input was 3700 ml. Urine output was 950 ml with 600 ml of sanguineous output from peripancreatic drain. Rest all drains were turbid of approximately 100 ml.
So here a young lady, acute severe necrotic pancreatitis, day 46 of admission. And she has sanguineous output in the drain.
And blood clots on the bones there. So what do you think?
Colonic perforation, ileostomy done already.
So first,
What day was that done? Colonic perforation? Day 46. And today is how many days? This is 6 days, 4th day after that.
surgery was performed on 46th day of acute pancreatitis, and this is post of day 4. So what do you think?
This could be post necrosectomy bleeding, post-op bleed.
Just because this case scenario is post-op bleed, that is why you
it's post-op day 4. I mean, it is not too early, not within 24 hours, but patient has history of patient underwent open necrosectomy, and second thing is patient suddenly till post 3 patient was fine and has suddenly deteriorated in terms of her status, in terms of tachycardia, in terms of 600 ml sanguineous drain output, respiratory distress.
No, so understood. All that is understood. All that is what.
Second.
what will cause this emergency?
Secondary hemorrhage.
Reactionary hemorrhage or secondary?
Secondary hemorrhage.
Everybody agrees to it? Or anybody has different views? All the 4 agree to it, secondary hemorrhage? Okay, then you answer next. What do you think is the likely cause of this hemorrhage?
Might be from either might be a venous bleed or arterial bleed from an arterial aneurysm.
Based on this scenario, do you think it is an arterial bleed?
Yes, it could be.
You think that it could be an arterial bleed, yes, but more likely to be venous bleed?
Most likely to be an arterial bleed, sir.
Most likely to be an arterial bleed. Okay, so what will you do next? Third person.
Sir, patient is on inotropic support, so I will take the patient in OR immediately.
You don't want to see what hemoglobin it is, what it is. You will straight away shift the patient to OR looking at this.
I will simultaneously I will send CBC, KFT, LFT, and I will see ABG also. And
without awaiting the reports, you will take up the patient, and without
I will
resuscitating the patient, you will take him up for shift to OR? And what is your intent in taking in OR? What do you plan to do taking up after taking in OR?
Sir, most likely I am suspecting arterial bleed, so I will see the bleed where is it from, and I will ligate the artery.
So you go in and you find nothing there. You just find lots of clots, you evacuate the clots and you can't see anything.
Have
Now-
you ever seen a patient of post-necrosectomy being taken up for bleeding? How friable it is? Is it easy to identify the vessel and underrun the vessel?
Or alternative is, sir,
So here we have a person who is day 46 in hospital. She's a young person, but she's day 46 in hospital with acute severe necrotizing pancreatitis. Already had one surgical procedure done. 4 days later, you want to go in and do something else. Must be clear in your mind as to what you wish to do. What are you tackling this? What is the problem you're going to tackle?
Stop the bleed is the main intention, sir. Now,
Agreed.
I may.
So what are the options of stopping the bleed?
Certainly, we have to find the source of the bleed. Because most probably, so I evacuate the clots, give a wall, and keep a pad.
What are the likely of you had a collection, there was a necrosectomy. What all vessels do you expect to actually have there?
Pericardial aneurysm and
Aneurysms.
aneurysm causing rupture and bleeding and common hepatic artery. So how do you want to do something preoperatively to know where it is bleeding from?
We'll send all the blood investigation. We'll see the hemoglobin to localize the bleeding source. Possible to as a do embolization, something we will plan for that, because in necrosectomy to go inside and to find the source, it will be very difficult for us. And even if we go in, we remove all clots, then to pack it up, then to resuscitate again, and then to evaluate the patient again. So postoperative date, which was the patient, chronic patient. What vessels again? And number two, would you like to post CT scan with an angio, or you take the patient directly for an AS? Sitting with postoperative date 4.
Sir, patient BP is 90/60 with NORAD 10 ml per hour. That is also double strength. So I will take for DSA directly without taking for CT angiography.
So it is a reiteration that it is going to be a re-exploration, 4th day post surgery, a very young patient. Yes. So what are the options?
So if I will find any vessel, then I will ligate. If I won't find any site of the bleeding, then I'll evacuate the hematoma, and then I'll give the wash, and I'll do packing. And already the bag is there, so I'll.
So you do that, and post-operatively, next day also the BP remains 90. There is still drain output of around 400-500 cc. The patient appears pale. What do you?
We'll continue the blood and blood product transfusion. We'll PRBC transfusion along with, we'll check the PTNR also. We'll support with FFP and if required,
You check the PTNR after the re-exploration. You don't check it before.
Before shifting for theatre also, we should know what is the coagulation profile of this patient.
Okay, so we want now a set of blood investigations before we want to take the patient to the theatre. Okay, are we okay with that? I agree. There are situations where you will take the patient to the theatre, and it's possible that a person is crashing, and therefore you decide that this is a better option rather than going ahead and getting some investigations done. In that scenario, too, you would at least send off these investigations and hope that you will get some answers while you're in the theatre. Okay, but to ignore everything and just go to the theatre is not something that's a great idea. There will be situations where you'll have to stop everything else and take the patient to the theatre. No questions asked on that score. But if we have a possibility of getting some investment, let's look at this.
The CBC of this patient shows that.
So let's look at the hemoglobin first.
Fine.
So do we want to look at the other two numbers that are there, 9.8.8 and 5? So if those numbers were 6 and 5 versus 8.8 and 5, it gives us some indication of what is happening. So you got three values there. There's a purpose behind giving you those three values.
Where hemoglobin drop is there.
So you got a significant drop in the hemoglobin, a drop of about 4. So our platelet counts are down to 92 and an INR is 2. So what do we want to do now?
Patient is also in consumption coagulopathy because platelet is low and INR is high, and
basically taking up the patient.
My problem remains what it was yesterday. We asked you, so what now? And you give us 5 different things, but don't tell us what you want to do.
So we'll trace the.
You want to transfuse, you don't want to transfuse. You want to give platelets, you don't want to give platelets. You want to give fresh frozen plasma, you don't want to give fresh frozen plasma. You want to take to the theater, you don't want to take to the theater. You want to take person down to the radiology suite, you don't want to take the person out. These are the options available to you. You got to take a call.
So we'll
Today you're doing your MCH DNB, is there somebody else taking this call? Tomorrow you will have to take this call. When we're sitting and asking you these questions, all that we want to know is, are we letting you get into the field with a reasonable judgment, or are we making an unreasonable judgment? Are you making unreasonable judgments, and therefore are we making unreasonable judgments? That's all, nothing else.
Okay. What answer?
So one more case.
What answer
After this?
This case is that you would resuscitate patient, send investigation. Based on this, the platelets are low, patient is in consumptive coagulopathy, so surgery is out. So what I would do is after adequately resuscitating the patient, shift to DSA, see if there is any invisible vessel. If it is there, we will embolize it. Because going in surgery in this particular scenario is not going to help you much. At the most,
So did this patient get to the OR? And did we get to the OR after an angio, or can we see the CT image? Okay.
Static image, there was hypertensity in the right side collection, and the right side drain was draining the sanguinous output.
Okay.
Other
So-
than that, there was no major vessel which showed actual blood.
What was
So decided to take the patient to the theater and explore and pack if necessary.
So the most pack.
Okay. Intra-op findings.
So did you take upfront for surgery or did you do DSA prior?
So we did DSA prior.
You did DSA.
That's
And didn't find anything on the DSI.
This was 14 note of open exit.
Okay, so this is what generally you would do, that if it doesn't help, then there is a diffuse ooze. Basically, this is due to erosion of vessels, small pancreatic when you will pack it and move for the breast. Pack, pray, pack pressure and pray. Second case.
So somebody asks you a question, don't seize up. Don't sort of become silent. It's no great shakes. What you've been asked is something that you've done. So all that you need to take a decision at that point is what is to be done. Nothing wrong in your wanting to go to the theater. Nothing wrong in him wanting to go to the to do a CT angio, and nothing wrong in a third person or one of you wanting to do an angio straight off or DSA straight off. Nothing wrong in either one of those approaches. It's just that you need to justify that approach. Why am I doing this? And why do I want to ignore everything else at this particular point in time? Okay.
So we have a patient of 59-year-old male with comorbidities of hypertension and diabetic mellitus on oral medication. He underwent open pylorus resecting pancreaticoduodenectomy with feeding geronostomy with indication of periambulary adenocarcinoma, clinical staging of T2N plus, status post ERCP and stenting for uncovered cells, with uncovered cells. Till post-op day 3, he was extubated on day 1, remained vitally stable and afebrile. FJ was started on post-op day 2 and he was tolerating FJ feed of 1500 ml per day. On day 2, RT was removed with output of 100 ml and oral liquid diet was started. He was passing flatus and stool. RT output was remained 100 ml and removed on day 2. Left drain, which was anterior to PJ, was draining 30 ml approximately serous output. And another drain on left side posterior to PJ was draining 200 to 150 ml serous output daily. And right side drain near the edge was draining around 10 ml serous, which was removed on day 3. On day 4, a patient started complaining of epigastric fullness and hiccups. On examination, temperature afebrile, vitals, pulse rate of 109 beats per minute, BP 102 by 60 mmHg, respiratory rate 22 per minute, saturation 99% on air. On chest auscultation, there was decreased basal air entry at bilateral basal zone with no added sounds. On abdominal examination, abdomen was soft, non-distended, non-tender. Bowel sounds were present. Succussion splash was present. He was passing flatus in stool and one managed with RT placement with drain start output of 1300 ml.
What do you think is happening in this patient?
So as the patient post-op day 2, they had removed the rice tube and the patient was started on liquids and again started development of fullness and sufficient splash was done. Rice tube was reinserted. He's developing a delayed gastric emptying. And 1300 ml rice tube output is there. The left tray is 150 post-op day, post-op day. That's patient. There can be some collection which is being undrained in that area.
What collection? Something marker of a leak, like small leak. That should come at your point. How do you manage? How do you classify DG?
Sir, it is according to ISGP. According to IASG classification, it is classified in grade 1, grade A, grade B, and grade C. In grade A, if patient required RT on POD3 or reinsertion of RT on POD3 and not tolerable oral diet beyond POD7. In grade B, if patient required RT and reinsertion of RT beyond POD7 and non-tolerating oral diet beyond POD14. And then grade C, if patient required RT insertion beyond POD14 and not tolerable oral diet beyond 20 days.
Do you want
to is not mentioned in this, and
so this is the dream product. So serum amylase is 16 to 108, so it is not 3 times grains.
Yes. So now I want to do an ultrasound abdomen to check for any collections,
okay,
which is causing secondary lesion.
The liver was normal. There was intraoperatively placed drain. Near tip, there was minimal collection. Bilateral mild to moderate pleural effusion was present and mild pelvic ascites.
Huh? The synovial electrolytes. Indian synovial electrolytes?
Yes. Sodium was 129.
So sodium is really low. Otherwise, creatinine is okay. Do you want to know anything now at this stage? Do you want to ask the operating surgeon more about the surgery? What type of surgery has been done? Does it have any bearing on it?
Yes, sir. Whether the anastomosis was anastomosis in terms of whether the pancreas was found under pancreatic duct was dilated, or what was the size of the pancreatic duct, and
So you want to know the fistula risk, you want to assess the FRS. What are the FRS factors? What do you take into consideration for FRS?
so whether it was a pancreatic duct carcinoma. Second duct size, sir. Respiratory, capture of bacteria from
intra breakdown. Pathology is setting type of test. What more details would you want to know from this surgeon apart from this? What type of gastrointestinal was there? What type of anastomosis was there? And is it an
whether it is anticolic or retrocolic, and yes, but in this is spinal sector.
So now how do you manage this patient? Back to first.
Will support the patients with continuous of FJ feed and IV fluids if required, because serum sodium is low, it is 129. We'll continue with the same finding, watch for the heart rate and BP, is it maintaining or no, or tachycardia is persistent. And we'll follow the drain output, we'll repeat the serum amylase on day 5, we'll see how much, we'll continue the spirometries for that the pleural efficiency. Yes. RT aspirated.
And this
so this what we follow in our institution, that initially after post-op day 3 to 5, there is no rule of the octreotide we give. It will we'll repeat the drain amylase and see on post-op day 5, because on post-op day 3 it is not very raised.
Okay, so what do we do now? We're 3 days post-op, further 3 days post-op, and we still have a 1300 ml or 1200 ml RTS.
Manage the conservatively and I'll start the prokinetic drug also.
Okay, prokinetic started, doesn't make any difference. 2 more days go by. Okay, apogea endoscopy, check for patency of anastomosis. Alright,
Better way to do it. Do you like to do an apogea endoscopy in the post-operative scenario? So
Edema, maybe. There can be edema.
Any
other
experiments that we post-op ideas, but for that
feed is the
we still FJ site obstruction of the lab going.
So how do you figure that out? Follow it up till the
yeah. Sometimes it takes us to
anything else that you can do? We don't want to give contrast. Creatinine was slightly high. She seemed a little dehydrated, so you don't want to do contrast. Can I do anything else? Plain X-ray of the abdomen, see a dilated loop proximal to the FJ site. You'll be able to see the tube of the FJ. Simple things sometimes work. Okay.
So CT was also done apparently.
At some point,
what does it mean? Usually, what is the time lapse whereby the DGE should resolve?
If it is 2 to 3 days, 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 2 to primary TG, then it should result. If there is no
When do you want to do a CT scan? You actually documented that there was no significant biochemical or clinical leak.
There was no obstruction. Patient is stable, sir. If no other parameters is problematic, then we can wait for to get a CT. But if we have strong concerns that all of them, then we can get a CCT. Sir, what is going to mostly the call?
We asked you when you got a DG.
DG is called when unable to see
Postoperative force.
any so ABC A would be any.
So then we'll grade that difference. If the rise tube is continued after post-op day 3 and patient is not able to tolerate. Sir, one question I have to ask, sir. If they ask when we should do planned endoscopy, so after post-op day 7 or any other? So let's see this.
We see not in this patient, when we saw it in the other patient.
RT was came out during shifting the patient, so you cannot see RT here.
Can somebody tell us what do we see over here?
The last person, yeah. Read the scan for us. Loudly and in the mic, please.
Stomach is not much dilated. And there is a collection air.
Speak in the mic loudly. Everybody should hear that.
There is some collection in the lesser sac area. And the stomach is decompressed.
Because he was on rise. What else?
Other than that, there any.
What do you want to see on the CT? You
FJ site.
Yeah. That is the FJ site?
FJ site, yes, sir. Looks like FJ site.
So are you ruling out that there is no leak?
Leak in terms of, sir?
Based on this CT, you can confidently say that there is no leak?
So, which site? FJ site leak or sir?
No, anestomotic leak.
PJ site. PJ looks, I mean,
there is no gross collection.
Yes,
there is no obvious.
Yes.
There are significant post-operative changes, and there is also a continuity in the sheath closed.
Yes, sir.
So would you still say that there is no leak, there is a significant amount of bowel edema? You would say that it is not secondary to the leak based on the CT scan?
Not sure, sir. Because minus lipids were also normal only. DFA levels were also between 5.
What is the CT report?
So there was fat standing near the surgical plane, the anastomotic side. Other than that, one liver cyst is there.
So this abdominal portion needs a revisit.
To answer your question, when you will do an endoscopy, basically you will be very patient enough. If you are blood investigations, there is normal. You will be very patient enough. Let the rise to remain for 3 weeks. Only then you will think of doing a CT scan or an upper GI endoscopy. Otherwise, you be patient. because patient has got an injury in place and it's like.
So, you can do an early endoscopy also, provided you can do it with a low amount of lymph ablation and the patient, you go in, if your colleague is doing it. And you should tell them the distortions in the anatomy. Why? Because sometimes it happens that you enter the afferent and the efferent limb very quickly and you may even do more harm rather than benefit. Number two, there was no significant oral contrast or as I said, an X-ray would be a better option. And then subsequently you can find it out. Most of your information you can get from the contrast enhancement scan. So endoscopy for us should be last. And unless you have a plan specifically that you want to reinsert a tube or which is already pulled out and you don't have an FJ, then you can either do it under contrast study to intervention radiology or.
Thank you, sir. And remind that sir, we'll have a photograph session before lunch, sir. So all now, sir. So all respected faculty and delegates, please gather near the photo. Outside the audience selfie point, please gather around there.
Change the program. Fine. Yeah. Even. Date करो, नहीं करो, इधर एक फोन लेके इधर मुड़ रहा है, इवनिंग ना एक्चुअली वो केस में लाया है, वो केस में लेट हो गया ना
Starting में
ये आप शादी को wow, right,
patient managed himself.
Hello.
Right.
Very good. हाँ पासवर्ड दो लैपटॉप दो पासवर्ड लैपटॉप दो शायद वो लॉगिन नहीं मैं कर देता हूँ उसमें यार इसमें ऑलरेडी ये सही उसको शूट हाँ पर ये करना नहीं जाएगा सॉरी That's a complex.
Good afternoon, everyone. Now we'll start our seventh session. I will request upon the stage Dr. Abhi, Dr. Shanita, and Dr. Gajendra. Dr. Gajendra, Dr. Sanita, and Dr. Advait. Dr. Advait is just coming, sir. 1 minute. 2 minutes. Now I'll call upon Dr. Piyush Sahni, sir, Dr. Sujay Pal, sir, and Dr. Pridhi Yadav, sir, to moderate the session. Dr. Lavina will present the case.
We have a patient of 18-year-old male, BSc student, resident of Lucknow, presented with complaints of hematemesis 12 years back and yellowish discoloration of eyes and urine for 5 months. Patient was apparently asymptomatic 12 years back when he developed spontaneous hematemesis. It was of 3 episodes over 6 months duration, approximately 100 ml per episode, associated with clots, associated with melena and postal symptoms, requiring 3 units of blood transfusion, and there was no history of GI bleed after that till now. Now for
So to find out the etiology, sir, whether the bleed was well tolerated or not, was it associated with any decompensation or
Associated melena, postural symptoms, associated with clots, requiring 3 units of transfusion. What does this relate to? It doesn't relate to.
So what do you think the basis of this? Please go on.
Now for 5 months, he is having yellowish discoloration of eyes and urine with insidious onset, progressive, associated with generalized itching and acolic stools. It is also associated with mild dull aching, upper abdominal pain, and intermittent high-grade fever with chills, not preceded by any prodromal symptoms. There is no history of nausea or vomiting, no history of abdominal distension or altered sensorium, no history of awareness of lump in abdomen, no history of recurrent fever, upper respiratory tract infection or urinary tract infection, no history of easy fatigability or generalized weakness, no history of recurrent epistaxis or spontaneous gum bleeding. Past history not significant. Birth history, he was delivered home delivery was there with full term, cried immediately after birth. There is no history of umbilical sepsis, no history of umbilical catheterization or intra-abdominal infection, no history of hospitalization soon after birth or prolonged jaundice in neonatal period. Developmental history, milestones were achieved on time with satisfactory academic performance. Immunization history in the childhood, we don't have the records. Personal history consumes mixed diet. Appetite was normal. Bowel and bladder habits regular, with no history of alcohol intake or smoking. Family history not contributory. Should I continue with treatment history?
Let's wait. So what do you think here? So they're taking all this history about birth, umbilical vein catheterization, umbilical vein sepsis. What is going on in their minds that they're asking all these things?
So they're thinking in the lines of non-cirrhotic portal hypertension if there was an umbilical cannulation.
How does that help? If there was umbilical vein catheterization or there was no catheterization, how does that help you?
It can tell the chances of EHPV cases may be having the history of all these.
What percentage of patients have a history of umbilical vein catheterization?
Around 5%, sir.
95% will not have it.
It can suggest it is there.
So 5% in which it is present, it may or may not be contributing to the occurrence of whatever the disease process is. So normally things in there 5% you usually don't ask. It become customary to ask, so we ask about this. Must be aware of the fact that the numbers in which you will find this is very, very small. Okay.
Which would indicate that there was probably
They have been exchanged for the knowledge of this so
otherwise there is any correlation with that correct probability.
Okay, so what do you think you have to?
Sir, is it case of non-cirrhotic portal hypertension with the recent onset of
So why do you say he has portal hypertension?
he have history of bleeding.
Bleeding, what are the causes of common causes of GI bleeding? Three common causes of GI bleeding.
But GI bleed common is peptic.
He has upper GI bleed. You agree? Or you think he has a lower GI bleed?
It's an upper GI bleed.
Upper GI bleed. He had hematomas. He had an upper GI bleed. So three common causes of upper GI bleed.
So malignancy, CS stomach, or peptic ulcer disease. Common is peptic ulcers.
You're dealing with the 18-year-old, right? How many years ago?
12 years.
At the age of
6. So you're taking the speed.
And also, CS stomach is not the best GI bleed. So even if you take all ages, then CS stomach doesn't come in the top three. Okay, so one possibility is a variceal bleed. Second, so it can't be that every patient who's 12 years old or 6 years old that has a GI bleed has only varices and nothing else.
So any bleeding disorders that will present.
So bleeding disorder, only hematomesis, no other site of bleeding.
Right.
So any other differentials? So what would be the other causes, forget the age for a minute. What would be the other causes of bleeding? Okay. Malignancy will never bleed so profusely, but you know, okay, differential. Anything else?
Esophageal injury, that common case, menorrhagic piece, tear,
Typical history for
angiodysplasia.
some kind of a vascular harassment, that's why they which can present in a young adult. So you think in these terms.
Cyst also are the important cause,
Some kind of a
rather than
So this man had a significant GI bleed when he was a child. So the history, we do not know what happened between the bleed and the sort of cholestatic symptoms that he had. So would that be important gap to that? What would you ask?
Any treatment he has received for in that episode of bleeding, what was done and how was he following up under some department or not? Was he under some medication or not?
Any endoscopic procedure was it done during this period?
the blood transfusion was done, it means he was admitted. So we expect that something more would have been done that time only.
Say endoscopy, whether it was done or not is not mentioned, sir. So whether
During the episode of hematemesis, 3 units PRBC was given and was managed with endoscopic examination followed by intervention thrice 4 monthly. Since then, he is on yearly endoscopic follow-up without any further intervention and on regular oral medication. For jaundice, he was managed with endoscopic biliary stenting and
Okay. HPV or portal biliopathy. That's simple. Anything else? Can people with HPV develop gallstones and CBD stones without portal biliopathy? No.
say hemolysis can cause.
Hemolysis. So why do people with HPV have hemolysis? Do they have hemolysis? Splenomegaly leads to what? A large spleen, a hyperactive spleen leads to what? Hemolysis. Does it cause an increased incidence of formation of pigment stones? No, it doesn't. So just like anybody can develop gallstones, anybody else with PHPV can develop gallstones. It's just that these young, so at that age, it's uncommon to see gallstones. Anything else that you can think of? He developed the first episode of hematemesis at the age of 6. So he was a child then. We don't know when he started having the portal hypertension. We don't know whether he has a congenital malformation. Could he have an associated congenital malformation, which could be causing the jaundice?
As per the history, sir, there's no growth, retardation, all the milestone achieved.
No, we're trying to figure out the jaundice. So he said HPVO, with portal biliopathy is a simple diagnosis. Is there a possibility of anything else? So one option is to say, I'm not going to consider any other condition, any other differential diagnosis at this stage. When you're at this stage in the history, it's a good idea to look at the possibilities. You get to the examination stage, you can probably do some examinations, say very unlikely. We have a history of endoscopy and interventions endoscopically, so it's very likely that he has varices which have been intervened with and on multiple occasions, and that's why he's on annual follow-ups. Okay, cortical cyst, coronary disease could be associated with congestion, but these patients can develop. There's nothing which bars them from developing these conditions. So you can find an occasional patient in which you find these conditions. Just don't close your mind to the fact that this is portal biliopathy and nothing else.
Thyroids will not respond to the treatment which has been given, endoscopic stenting. So if there is jaundice because of the stent, and treat the patient will not respond. So you have to differentiate, you should know how to any metabolic disorder can happen at that time, 8 years, 6 years. But again, all the components are not favoring because now is 18 and even Wilson, so we can think, but we can also simultaneously.
The pills seem to be but decompensated.
Yeah.
Like a ability because it's obstructed component and all this. And I have responded.
Okay, so presuming that this is extravagant cortical, and it's portal biliopathy associated with it, and that's your first diagnosis, how are you going to investigate this? Sorry, we haven't done examination yet. So when you want to examine this patient, tell us what is there. But what are you looking for? Specifically, what are you looking for?
Palate.
Okay.
Any splenomegaly.
Okay.
The BMI, sir.
Okay, yeah. So BMI is an easier way to look at growth retardation. If you're wanting to look at growth retardation now in a person who's 18 years old, started the disease process at the age of 6, BMI may not give you a maybe get better to ask for a history of how the siblings are. May give you a better indication of whether this person is growth retarded or not. So BMI alone may not give you an answer. Okay. What else? Anything else that you would? Pallor, jaundice, splenomegaly.
Signs of liver cell failure from the stigmata of CVD.
Okay, all right. Rule it out.
But do we expect in
So, but just to rule out the cirrhotic causes for liver.
so cirrhosis, which cirrhosis can develop at 18 years of age? Because of which
Possibility of the case.
So autoimmune hepatitis progressing to cirrhosis. Or hepatitis B or C, which is present congenitally, can progress to cirrhosis.
Hepatic fibrosis, congenital C hepatic fibrosis.
Is more common. Look at more common things, more likely to happen at that age. Congenital hepatic fibrosis, yes. Okay, so you got a anything positive on the general?
Other than that, Hackett grade 2 freedom again.
Beta blockers for maybe you got to keep it at the back of your mind. All right. It's useful to give beta blockers in patients with AHP. So we give it because no, that's not true. It's used for something else. Everywhere the base is same as using beta blockers.
Secondary, second prophylaxis. You can add history of endoscopy, therapy, endoscopy. And
he right now said that there is no evidence.
Prime recent prophylaxis studies not suggesting to give if it's no cases only high risk
In EHP view.
Yes, sir.
In EHP view, the data is in EHP view. The question is, do we have data in EHP view? But you said we don't have definite evidence. So what is the evidence, whatever little evidence that you have in EHP? We're not talking about the non-EHP view setting. Is there any evidence? Are there any studies? Are you aware of anything? Are you not aware of anything? Or are you extrapolating it from the evidence in cirrhosis?
That is asymptomatic.
So two small randomized trials, underpowered, done long back, which showed that may be useful to give beta blockers in patients with extrahepatic portal venous obstruction as secondary prophylaxis, not primary, as secondary prophylaxis. But they're small numbers, very small numbers, and very underpowered. After that, nobody has done that. I'm not aware. It's used, and people have found it useful. We use it. Okay, so we've got splenomegaly now on inspection, on palpation. Anything else we're looking for? If you're given this as a long case, would you like to do a rectal examination, or do you say, I don't want to do a rectal examination? So if you do a digital rectal examination, is that useful, or is it useful to do something else? If at all you want to do examine the rectum and the anal canal, is a digital rectal examination useful, or is something else useful in a patient with extrahepatic portal venous obstruction?
Proctoscopy.
So proctoscopy would be better. You could look at fine rectal varices, but don't necessarily need to do it in every patient. You could do it in patients who give you a particular history rather than do it in each and every patient. But it's a good idea to ask, if you're in an exam, to ask whether you should. If somebody says yes, please do go ahead, then please do examine. All right. So in this particular examination findings, no description of veins dilated and the flanks are posteriorly asking patient to left lateral position and try to see is it important? We should look at this in any portal hypertension, or we should not. Isn't valuable, but to complete. So Dr. Yadav's question is, should you look at dilated vessels over the abdomen, abdominal wall, or the back, or the flanks, or should you not? In patients who have evidence of portal hypertension.
Yes, sir, you have to.
You should. Okay, so it's the information is not here. Would you be interested in finding that information? Okay, so that's what he's asking you. Should you ask for? You'd say you should ask for. Why should you ask for this information? Why do you look for this information?
Sir, if there is a peri-umbilical dilated veins, it's suggestive of the recalculating umbilical vein.
In a patient with portal hypertension, why do I look for veins over the flank, back, over the abdomen? Why do I look for this? Why should I look for those veins? Okay, on the back, on the flanks.
Trying to check for any SVC or superior vena cava or inferior vena cava obstructions.
Superior vena cava or inferior vena cava obstruction in a patient with portal hypertension. So the answer is very specific. You see portal hypertension in patients with Budd-Chiari syndrome, the obstruction could be at different levels. If it's at the inferior vena cava level, then you are likely to find flanks and back veins distended with flow in a particular direction. So you should be, so you're focused, no? Your portal hypertension. You're not non-specifically looking for SVC obstruction on the back. Here's an 18-year-old with portal hypertension who's been bleeding for 12 years or has had a history of bleeding for 12 years. So if you are asked that question, the answer is very focused answer. You give me an unfocused answer, I know you're guessing. Okay? All right. So what should we do now? So anything else on this examination sheet? Quickly went past that slide. Are you interested in anything specific? No, abdominal examination is done. Splenomegaly. Anything specific you want to ask or look for the examination other than what she's told you? No, we can move on. So what should we do now? Considering that this is a child this is a young boy now, 18-year-old, and started with an upper GI bleed at the age of 6. What should we do?
First, we'll review the last endoscopic report to know the status of paralysis.
So you want to look at the last endoscopic report? Do you want to look at the first endoscopic report?
Yes, sir, first.
Or the last one only?
Last one that tells us
It's useful to look at the first status of all the endoscopy reports, but certainly you want to look at the first endoscopy report as well. You want to know, so the last endoscopy report may show you obliterated varices or normal esophagus. You want to look at the first endoscopy report and see what was the grade of varices at that time, if you want to look at it. Yes.
Endoscopy report at the time of bleeding showed grade 3 into 3 column and grade 2 into 1 column esophageal varices with with RCS, mild PHG present in fundus and body of stomach, duodenum normal, EVL was done.
So that's the index endoscopy. Comment? Happy, unhappy, goes with what you were looking for, does not go with what you're looking for, you're looking for something extra. There's more information that you want here.
Esophageal varices.
Follow-up endoscopy.
Yes, sir, follow-up endoscopy.
Don't want any more information. Okay, follow-up endoscopy.
The last endoscopy done in December 2024 showed grade 1 into 2 column esophageal varices with no RCS, post-EVL scar present.
Last EVL, when was it done?
Sorry.
Last EVL.
It was at the time of 12 years back.
So the history said no further interventions were done. Annual endoscopies were done, but no further intervention.
Grade 1 paralysis are there.
Grade 1 severe PNG.
What makes quick?
You said you want to do endoscopy?
Ultrasound we have.
Ultrasound is recent?
Yes.
This is now.
October 24 texture, by lower HBRD present, gallbladder normal, CBD dilated 12 mm, portal vein replaced by multiple collaterals, hepatic vein, IVC patent with normal waveform, spleen 21 centimeter and large.
Okay, next.
Splenic vein not mentioned and renal vein.
Yes, sir.
Anything else you want? Splenic vein, renal vein, that's all?
Superior mesenteric vein.
So you want the whole portal system delineated, and they've already said here, but a lot of ultrasound will not tell you what is the status of the hepatic veins and inferior vena cava. You're working up a patient with portal hypertension, you want that. Status also told. Investigation of a patient with portal hypertension, tell them, please look at the hepatic veins and inferior vena cava. So what do we do next? Upper GI endoscopy done, ultrasound abdomen, Doppler done.
CBC, CBC.
We don't want to do anything for the splenic vein. We're happy with what we see.
So we'll need a CT photography.
We'll need a CT photograph. Need it for everybody. Can't you go back to the person who did the ultrasound and ask him to look at the splenic vein and superior mesenteric vein for us?
We can do that, but again, he has jaundice. We need to evaluate the CBD as well. So better will be MRCP with.
Correct. So so why do a CT and an MR then?
MRCP with MR angio, MR photography basically.
Why not just do an MRCP? You see, however, the more complex you make your MRI investigation, the longer it takes to be done. And whether you like it or not, if you have to deal with a large number of patients who need an MR to be done, you need to look at how you can decrease the time in the machine for a person who's having an MR and get only what you need. Decrease the time. So if I want to do an MRCP and an MR angio, it will take me longer than if I want to do an MRCP alone. Yes, no. So if I can get the information from other cheaper, easier, quicker investigation, why not do it? Anyway, so what do we see on this? What are we looking for?
This is thrombocytopenia. And TLC is normal, hemoglobin is on the lower side. So he has bicytopenia on the hemogram.
So interpret.
Probably splenomegaly is leading to this picture in the hemogram.
So hypersplenism.
Hypersplenism, yes.
4 features of hypersplenism. This is an MBBS question. So in your MCH question, exam, if you are asked what is hypersplenism, define and you falter, then don't grip later.
Splenomegaly, either bicytopenia or pancytopenia in hemogram.
One or more formed elements.
And
so you could have 1, 2 or 3.
Hypercellular bone marrow. And
so do you do bone marrow for everybody? Should we do bone marrow for him?
Reticulocyte count can be done.
Not there here. Ask for it. Okay.
It reverts after splenectomy.
Okay. What else should we do? We are going very slow. Tuck, finish.
MRCP with
LFT.
LFT, LFT.
In October, it is before the biliary stenting was done, and now 2025 is the recent one.
So what do you think?
He had obstructive jaundice, direct hyperbilirubinemia. Total bilirubin 6.8, direct was 4.5. ALP was raised. OTPT was slightly deranged that time. This time also it is slightly deranged. Albumin is normal. So this picture we see in portal biliopathy as well. So this corroborates with
Do
findings
you
of
see in any patient who's got obstructive jaundice, which is now like
Positive.
Yes, sir.
So it not be who have plates.
Do we have that EMCP cholangiogram, please? There's no filling defect in the biliary ducts. CBD is dilated, yes. And there are indentation over the CBD.
What is but till the findings, but we can see. So narrowly seen in the distal CVD with the smooth tapering.
what do you want to do for this narrowing? US? Sort out this narrowing?
In this setting of EHPV, probably it is due to.
This is post lunch. Hyperglycemia, which is making people drowsy, listless. No? If it is so, we can do some physical activity. We can go out again and come back in again. No? So what should we do for that narrowing? That narrowing is significant, important for you. You want to do an EUS to sort that out. You want to do a CT to sort it out. You don't want to do anything. You want to ignore it.
So it was
Very
significant.
limited options. Our field is such that we've got 3 or 4 options at every stage. We need to weigh the options that we have and come to a decision. We can't, when you have a patient sitting in front of you, you can't sit there and keep watching the patient and saying, patient को कुछ चला जाएगा. It's not going to work. No? And you can't do it in front of an examiner. The more likely is that you are in difficulty. So some examiners will speak irrespective of whether you are in difficulty or not. But most examiners want to listen to what you know, not what they know. So what should we do next?
So he had already been stented.
So ERCP done, stent, you got a picture, nice picture. What do you want to do now?
Sir, the management further he will need a So we did the prior LFT.
Prior LFT they showed you. Pre-stenting they showed you. Post-stenting they showed you. So you know the pre-stenting LFT. So his question is, patient came to you, what would you do?
Got an MRCP done.
Okay, you got an MRCP done. Seen this picture, then what?
Followed by stenting, obviously, because he was in.
Followed by stenting. Okay.
So the status of the CBD, any filling defects, and IHPR, the
Any dominant stricture if there is. Implementation over
the length of the stricture.
These things you have to mention. Plus you may have. So in this case, now they have asked for a critical case. Are you okay with that?
TT sir with photogram board. Aim now to check that how the vascular anatomy, how the collaterals, and any. So when we see the how the.
So what specific things to decide on management of this patient? What are the options available to you? One is you continue with whatever therapy they have given up to now. That is, continue to do endoscopy on an annual basis. They put in a stent, his jaundice has come down, whatever little fever or something he had has settled down, and now you can keep him on that stent and keep him on stent exchanges. He's 18 years old, and doesn't need to come to me frequently. So that's another option available to you. You have other options available to you, and if those options you wish to consider, what are the other investigations that you want?
He needs a shunt surgery. So I need to know.
He needs a shunt surgery. Why do you think he needs a shunt surgery? He hasn't had GI bleed in the last 12 years. Why do you wish to do a shunt?
But upper GI shows there are still varices and
That's
also
what to do. He's not bled. 12 years he hasn't bled. God knows when he'll bleed again. Why
he has symptomatic portal venopathy as well.
So
we need to do shunt surgery so that anyway it will also help in further decreasing the bleeding risk, and also if the collaterals decompressed by the shunt.
going okay, then you suddenly, to my soul, you decided that you wanted to shift gears. So don't shift gears just because the examiner says so. Don't. You're going fine. Just go back to that same track. Where was the track? You wanted to do a shunt surgery for him. Okay, then.
So we need to know whether he has a shuntable anatomy or not.
Shuntable anatomy. So what are the options to get hold of a shuntable anatomy? I said we could go back to the ultrasonologist and ask for a Doppler. Instead, I've decided to do a CT. A lot of people are now moving towards doing CT. Why?
There is objective evidence of.
So a Doppler ultrasound or an ultrasound, you can get reports like this in a patient with portal hypertension. Work in a specialized center like ours, so where I used to work previously, you don't need a CT in most instances. But if you are working alone or you don't have a regular ultrasonologist, or you just get a report from somewhere more useful for you and gives you more confidence if you've got a CT in front of you to be able to look at the vascular anatomy. Now, what vessels are you interested in? And which are those shuntable vessels that you're looking for?
So first of all, we'll look at the portal vein, whether it's replaced by collaterals.
So that we know on the ultrasound is already replaced.
I would like to look at the splenic vein and the superior mesenteric vein.
So for shuntable anatomy, we're looking at splenic vein, superior mesenteric vein, any other vein?
And the left renal vein, and left atrial if needed.
Okay, what else? left adrenal, left renal, those are the systemic veins that we're looking at. Portal venous, splenic vein, superior mesenteric vein. Any others that you want to look at?
IUV also suggest in case.
Okay. Any others?
IVC, sir.
IVC systemic side. Any others? Some people like to look at the coronary vein. There are coronary cable shunts that have been described. Very few people do them now. I don't know if anybody does them, but they've been described, they've been used. The large series. Some people like to look at the coronary vein as well. So if you are going to look at these, if you are going to do a CT, you might as well look at all these. Okay.
Yes.
Yeah, so if you are going to do a shunt first, you're going to decompress, leave the stent in situ, which would be an option in this patient because he's already got a stent in situ, and give him a stent-free trial at a later date. Assessing the vascular structure in the porta at a later date may be more useful if and when you need to do a hepatic angiostomy. You can see it, but if you are going to decompress, it may change. Can. So in a group which is going up for an exam, I won't advocate that they say this in the exam that this will be a first choice. They'll get into difficulty. So there will be situations where you will do it, but yeah.
Stent-free.
So we do a shunt in this person. Do we have a patent splenic vein? Have we looked at PCD? They haven't shown us CT. Yeah, so if the person is continuing to bleed, then it's better to do a shunt because obviously whatever shunt is available is not decompressing. Sorry. So if a person has symptomatic, and there is a shunt, I would still go ahead and do a formal shunt because it's very likely that that shunt is not decompressing adequately.
But to be non-vaccine having problems.
So shuntable, non-shuntable anatomy.
Shuntable. Splenic vein is patent. Left renal vein is patent.
So I think very important to look at whether both kidneys are present. Not so important to look at the renal vein. I don't think we've ever come across. We've seen variations on the renal vein. 2 renal veins, 1 renal vein. But more important to look for things like a horseshoe kidney, an absent kidney. Because you don't want to go in on the left side and then see that the kidney is not there, congenitally absent, and you don't have a vein to anastomose to.
Retroaortic.
Multiple collaterals and branches.
Joining from
So I see here actually yeah.
Day 5, what do we do?
So I'll explain him regarding the further management plan.
So what is the further management plan?
So we'll follow up the LFTs and also symptoms, whether there is recurrence of jaundice. If not, after 3 months or 6 months, so we can.
When do you want to do the LFT? When do you want them to come back? When do you want them to reassess?
See if he has any stenocholecystectomy in between.
So that's separate. One is routine follow-up. Second is we have to tell him if you get this, this or this, you come back to us sooner. I want to see you after 1 week, 2 weeks, 3 weeks, 5 weeks, 6 weeks, 12 weeks. Never again in my lifetime. Possible, no? I don't want to see you again. Go to some other surgeon. I don't want to do the hepatic angiostomy if I have to. Send him to somebody else.
So we will follow him up for at least 6 months. After 6 months also, if he is asymptomatic, there's no jaundice, we can start removing the stents, that is in situ. And even after removing the stents, he remains symptom free. We can do away with the hepatic angiostomy. Repeat MRCP.
Endoscopies and leukoviruses.
Small size, grade 1.
MRCP.
So Doppler to look for the latency of the shunt. So Doppler to look for.
Can I on endoscopy make out whether a shunt is petered or not?
See if there were large grade varices which have decreased. No, earlier there were red color signs, now there are no signs. So if there is evidence that the varices are decreasing, we can say that the shunt is working.
Is there data to suggest that you see A, B, C, and therefore it means X, Y, and Z? If you know, say. If you don't know, say I don't know. Let me tell you. So if you see a fall in varicose grade by 2, it indicates from a pre-shunt status to a post-shunt status. It indicates a patent shunt. However, if there is no decrease in varicose grade, the shunt could still be patent. And therefore, you need to do a Doppler to be sure that the shunt is patent. If you're going to intervene further. If you're not going to intervene further, it doesn't matter to me. If I have a blocked shunt, what is the likelihood I will rebleed?
So around half.
Half matlab?
If the shunt block rates are of the range of 20%, then around 10% will.
Yeah, so everybody with a blocked shunt will not rebleed. So if I'm not re-intervening, then whether the shunt is patent or not is not very useful information for me to follow up the patient. Because everybody with a blocked shunt is not likely to rebleed. If everybody who had a blocked shunt was likely to rebleed, it may make sense to investigate everybody and see whether the shunt is patent or blocked. But if I am going to re-intervene, so just do, there is a likelihood that I am going to re-intervene, then doing a shunt patency is useful.
Sir, after in this patient being proximal spinal shunt, on follow we found patient again had upper GI bleed. Then if we want to do the shunt again, then what option we have to prefer?
So if the presented vein is available, you can do a mesocaval shunt. That would be the next best shunt to do these patients. Patients who already had a spleen removed because they had a large spleen. It happens in our country. People don't make a diagnosis of portal hypertension. They make a diagnosis of tropical splenomegaly syndrome and take out the spleen because the spleen is enlarged. And you're left with no splenic pain to anastomosis. Then the next best shunt to do is mesocaval shunt. Okay. Any questions?
This patient at the index episode at 6 to 7 years, if it was not controlled endoscopically, then what would be the shunt of choice for that?
Lining shunt still. So as long as splenic vein is about 7 millimeters in size, good easy anastomosis to do. If the shunt, if the splenic vein is smaller than that, the smallest size that we've done is 3 millimeters, but there's a large series of Bismuth et al. 4 millimeter shunt. But the only thing they used to do was they used to do an intraoperative angiogram to ensure that the shunt was properly placed and was wide enough for a good flow. If not, they revised the anastomosis. And they had over 90% shunt patency over a period of 2-3 years when they reevaluated. So if you have a patent left portal vein, then and then only can you do a Rex bypass. So in children, if there is a patent left portal vein and you are comfortable doing a Rex, then you should go ahead and do a Rex because it's more physiological. We've never been able to do it because most of our patients have been older patients. And in about 20-25 odd patients who we tried to look for a left portal vein, we couldn't find them. So in the adults, you don't find the left portal vein very frequently. In children, you probably find it more frequently. But even then, in all children with extrahepatic portal venous obstruction, there's only a proportion of patients who will have a left portal vein. I don't remember the exact numbers, but I think it's somewhere in the range of 60%. So if you have a left portal vein patient, then you can do it. I'm not sure it will work very well in the emergency setting. So if you believe in doing emergency shunts, then probably a shunt like a lateral shunt may be better.
So in a case of USPVO with asymptomatic portal biliopathy, should you go ahead with a shunt or not?
So asymptomatic portal biliopathy, GI bleed, portal extrahepatic portal venous obstruction. No question. Secondary prophylaxis, please go ahead and operate and do a lateral shunt. Primary prophylaxis. We advocate primary prophylaxis. It works well for us. So we think it should be done. If you have a patient who has grade 3-4 varices, large varices, even if the person hasn't bled, it's a good idea to go ahead and do a shunt. So asymptomatic portal biliopathy, no GI bleed, still a good option. Published data. This is published data from us.
So one more question. After PSRS, if patient still has asymptomatic biliopathy only, or just inhibited ALPs, but bilirubin everything is normal, and patient is not symptomatic, no problems.
Don't do anything. Please keep these patients far away from people who have endoscopes. They very quickly want to put in a stent.
Sir, in this case, after shunt surgery, how much time we should wait to assess portal biliopathy?
At least 3 months. 6 months is not a bad idea either, but 3 months definitely. So let the portal venous system decompress, and whatever changes can revert, change. Let them revert.
Sir, if
the same setting is not possible. Even if you do it with the left side, modified when then possibly not good for you. The same thing. So best that stabilize is ready. Hysterectomy is already done. Then ensure that the hemostasis is maintained. And subsequently take forward.
So your experience, you're comfortable doing a mesocaval, your situation is totally under control, your anesthetists are happy, you haven't spent 4 hours doing whatever you've done, you don't need another 4 hours to do it, please go ahead and do it. But not at the beginning of your career and certainly not in an exam. Don't say this is the first that I'm going to go ahead and do a mesocaval now. If the examiner asks you this. Okay, good.
Sir, yeah, there is no timetable when during the second surgery. First we did the programming experience. Can we large collateral can be used for something?
So makeshift shunts have been used. Makeshift shunts work for a short duration of time. The literature suggests, and our experience is that makeshift shunts usually don't work for very long. So if you have a situation of a patient with symptomatic portal biliopathy and who's stented and you may need to do a hepatic vaginostomy, it's a good idea to do a makeshift shunt. And at 3 months, don't wait for 6 months because they might be blocked by that time. At 3 months, evaluate and go ahead, and if the patient needs, do a hepatic vaginostomy at that stage while the shunt is still working. But on a long-term, makeshift shunts don't work very well. So out of choice in a patient who has multiple episodes of GI bleed, doing a makeshift shunt as a first choice is not a good idea. As a last choice, if I have no other choice and I need a shunt, yes.
Then all systematic production, that means it is freedom.
Asymptomatic portal biliopathy, no.
How does this formation give the LFT all normally is no but it's closed as very multiple intents. But some patient are very mind similar time mind accidental as very, but there is no cross intestinal structure. So how which should be.
So I think the group of patients, so there's very little data on this, or hardly any data on it. This is more experience rather than anything else. If you have a patient who has gross IHPR, but the liver function tests are absolutely normal, this is a patient in whom you need to do something, because if you don't decompress the biliary system, sooner or later they will need a transplant because they will develop chronic liver disease. Patient has mild dilatation, is asymptomatic, keep them on follow-up. If they continue to dilate further, then you may need to intervene. If they have a rapidly increasing or even a slowly increasing alkaline phosphatase and nothing else, then you may need to look at these patients a little more carefully. And at some point in time, maybe think in terms of intervening in that. But every patient who has asymptomatic portal biliopathy, doing an MRCP will not show you gross biliary dilatation. These are exceptions to the rule. So in most patients, there will be minimal changes in the biliary tree on imaging. These patients don't need to do anything prophylactic. Okay.
No, is she at the moment jaundiced? The jaundice LSM 2. She is still stented. Can take do a biopsy. Confirm the
serum albumin.
So do a biopsy. Confirm whether there is cirrhosis or not. If there is no cirrhosis, you can still go ahead with the shunt. But if there is cirrhosis, then it's better not to contemplate it.
So synthetic function is preserved and reasonably okay to go ahead and do a shunt. You'll see some reversal of this fibrosis, even if complete reversal doesn't happen. But in a patient who's got definite cirrhosis, signs of decompensation, jaundice is because of the cirrhosis, then obviously you've got no choice but in these small number of patients to actually offer them liver replacement. Okay.
Good, thank you.
Thank you all the participants.
Thank you, sir. Now, call up on stage, Dr. Hema, Dr. Rajiv, Dr. Rahul, and Dr. Tarun for their posters in the review. And I request Jaswant sir, Dr. Sujay Pal sir, Dr. Sandeep Salvija sir, and Dr. Abhinav Prasad to moderate the session. And Dr. Prashant will place the present the posters in the review.
Ending. Start.
KTRBL, the smoking instead of therapy here. The unbundled procedure of exploratory laparoscopy is precision of a guidelines bowel segment, small bowel segment, end instrument, D1. Indication of the surgery was the acute mesenteric ischemia with small bowel gangrene, perforation secondary to SLN problems. On POD 1 to 3, patient was extubated and shifted to recovery room. Therapeutic use of anticoagulants was started and he was kept on leukemia. Stoma was pink and healthy. Police catheter was removed on POD 1. Stoma started functioning and started oral liquids on POD 2. After that, there was removed on POD 3, which was draining around 51 6. Today, postoperative 4, patient is conscious oriented. He was ambulated and he was evacuated. Pulse rate is around 90 to 100 beats per minute. Blood pressure around 110 plus 77 maybe. With respiratory rate of around 20 beats per minute. Saturation around 98% of movement. Just there was no added zones and his parameter was around 3.5 liters. Parabdomen soft, non-bending and suturing is healthy and there was no issue. Stoma is healthy and function and output of the stoma was 2.5 liters per day. And it was kept on enteral nutrition semi-solid. And these are the parameters from day 1 to day 4. On day 1, patient received IV fluids around 2 liters and TPN of around 800 ml. The urine output of around 1200 ml and stoma was nil. On day 3, he was input was around IV fluids of 1500 ml, TPN around 1 liter, and orals around 800 ml. And the urine was around 1200 ml, stoma was 2500 ml liquid.
Post of day 4, post laparotomy having high stoma output. So this is a case of high stoma output. So likely short bowel syndrome, sir, because of short bowel syndrome.
So that's okay, but what is happening to the patient now?
Dehydration, sir. Since
So,
the urine output has
what are the parameters you will look post-operatively in a patient like this, and how will you calculate to correct this dehydration, and what you will give orally, what you will not give orally, what IV fluids you will give? This is where we have to now start working.
Yes. Uh, 2.5 liters, sir. 100 ml per hour. So if it is high stoma output with decreased urine, I would increase. So first I need to
like to know how much of the bowel was resected, whether the colon is still present or not.
Now we details there.
Operative findings. 200 ml of additive content was sufficient. There was a patchy gangrenous small bowel from 100 centimeters distal to DJ flexor till 40 centimeters proximal to ICG. Multiple perforations were noted over the gangrenous segment. The rest of the small bowel was sedimentous and congested. 240 centimeters of gangrenous bowel was detected. And ostomy was made 100 centimeters from DJ flexor and DMF of 40 centimeters from proximal to ICG.
What should be done now?
Sir, the length of a small bowel post DJing is from the DJ to end jejunostomy is 100 centimeter. So it is less than 200 centimeters. So it comes under criteria of short bowel, sir. At present, patient needs to be managed conservatively. Look for the electrolytes, calculate input output, and start TPN and give anti-motility medications and the diet modifications, sir. Sir, with TPN, we can start enteral feeding also, sir.
Can he have water, tea, coffee?
Yes,
His
yes,
relative is asking. Is it okay if we give him, or do we have to give something else? What is the difference between hypotonic, isoosmolar? What is our hypoosmolar? What kind of fluids he would like to give him?
So I would like to give hypoosmolar because if we go for hyperosmolar, it might again pull the fluid from the systemic blood vessels and might increase the stomach.
Exactly the reverse. If you give hypotonic fluids like water, tea, and coffee, most of the time that is the cause in the initial phase of this first few days. He will have excessive stoma output. So normally they ask you to give isoosmolar fluid, not hypo or hyper. That's the first thing. As you rightly said, first you need to calculate what is the deficit here. Now, if you really see in last 4 days, there's a good amount of deficits, and that's the reason he is going into dehydration and tachycardia. So correct it first. Continue and stabilize it on TPN, and then start simultaneously on enteral fluids, which are isoosmolar. And then, of course, you said you would like to give Lomotil and all that kind of things.
I would like to correct electrolyte abnormalities also, sir, if they are. I would like to check the.
How do you correct magnesium in this case?
Sir, IV magnesium sulfate, sir. So 1 to 2 grams, sir. Yes.
What is the role of any elemental diet in this patient when it starts entering?
Yes, sir, definitely we need to go for elemental diet also. Simple.
What was
like such isoosmolar rates or replace with Vectral. Your initial focus is just to replace the fluid and maintain the homeostasis of electrolytes. After achieving that, you have reached a stage when you know what is the daily output of the stoma. Accordingly, you will plan out the next phase of it. Okay. Do you anticipate that this guy will ever leave the hospital?
Sir, length is 100 centimeters. So if jejunum length is less than 100 centimeters, the patients are usually dependent on TPN. So he will need a long hospital stay. And we need to secure a central catheter as well. Central.
Is there anything else that we need to do while we are doing all these things?
LFT, sir. Monitor.
Show us everything. Why do you need to monitor the
Patient can develop intestinal failure associated liver disease. Cholestasis. Yes.
We are in the early postoperative period. Why is that stopped?
Cholesterol.
How long does that take to happen? Does it happen in 1 day use, 2 day use? Again, that is also not of immediate concern, but yes, I agree that you do frequent electric do all the electrolyte charting almost on a daily basis, like twice a day. We'll also look at calcium and phosphate levels. Treat him like a case of short bowel syndrome. And what the other thing that you have to look at is mesenteric vascular disease, SMA thrombus. Is there something that you can do for that?
She will require something else. Require the imaging findings, then also you look at the albumin level of the patient. The albumin levels are increasing, what does this indicate? Patient is getting better now. Yes. Is it not the indicator of dehydration?
Indicates dehydration.
So if the albumin levels are increasing, that means this patient is actually asleep. This collaborating with the dreams. After that, anything else was done?
So we need to evaluate systemic disease also, sir. The cause that had what had caused the AMIs, acute mesenteric ischemia. Was there any proximal atherosclerosis? Was there any clots in the heart? And if if he is a case of a CAD, manage the CAD also.
But we didn't put a prelims, but there was an eccentric thrombus in the SLM.
This is more like a thrombotic, sir, because embolism might lead to segmental blockage, and if it is a massive resection of the bowel, then it is likely major vessel thrombosis that has
When you think now when you think it's at the phase 1, now how would you really proceed to say will you able to restore his whole integrity of his intestine, and how would you go about it as a surgeon?
For the adaptive phase to.
How do you know the adaptive phase has come?
Sufficient diet. 1 to 2 years.
All is there. 100 centimeter of jejunum is there.
40 centimeter to be very frank. It's a good size ileocecal wall and your stoma is pink. So I think these are the patients where you would like to maintain them for a few days and take them early. Don't wait for 2 years. But not for, I mean, most of the people will wait for 4 to 6 weeks. 6 to 8 weeks, you wait, look at the thing, in the patients, everything is controlled. You take the risk. Of course, you would take the risk. How would you assess the integrity of the bowel vascularity before you do this surgery? This is the last question, then we'll go to the next case. That's what you said, no? Time is up, no?
Yeah.
So contrast enhanced CT scan, sir. We need to look for the bowel vascular. If it is enhancing or not, sir. If it is sir, even is.
Many things on table also they do. ICGs are being used. There's a lot of work being done, but no real data to say that it works, you know. So many times it's you look on the previously CT enhanced Doppler, you take the table, you look at the vascularity, and ICG may help, but otherwise you would do that. And the another thing is whether to do thrombectomies and all, these are the questions, but I think if the patient has settled down, then usually these are not needed.
Okay. 45 years female with no comorbidity. She underwent open right hemoglobin with area transfer diagnosis for adenocarcinoma of ascending colon with presentation of lower GFA for 6 months, and she received 3 blood transfusions preoperatively. Patient has an uneven postoperative post-stage POD2, and her indolence nasopharyngeal tube and Foley's were removed. Today on POD3, patient has a complaint of pain in right lower abdomen with one episode of fever with chills, which was around 100 degree Fahrenheit, and she was passing in loose stools. On general examination, her current temperature is around 100 degree Fahrenheit. With pulse rate around 114 beats per minute, and her blood pressure was around 90/15. Respiratory rate is 18 breaths per minute, and her saturation of 98% of fluid. On local examination, for abdomen is distended with tenderness in the right fossa. Bowel sounds were absent. Food is healthy. Train output is around 500 ml per day. Chest, there was a decreased air entry in the right lower chest region, but no adhesions. Her urine output was around 1600 ml in past 24 hours.
What is your
Could be anastomotic leak, sir. First, we need to stabilize the patient. Patient has a fever, tachycardia, so we'll upgrade the antibiotics.
it's a technical leak or is a vascular or healing leak?
Technical. So even it could be other viscous perforation, or it could be even a ureteric injury owing to ventricular accumulation. So patient is having patient is having post-op day 3 signs of sepsis with likely intra-abdominal collection. This collection could be because of either anastomotic leak or previous or simultaneous in the surgery there was a viscous perforation, bowel injury, or it could be some intra-op ureteric injury, or it could be even collection, hematoma collection.
It's good that you're keeping all that in mind. It's definitely fine.
But most common is leak.
So what was the thing? It was an open operation.
Intraoperative findings, there was no evidence of any dissemination. Mass was present in cecum and ascending colon, and mass was added to the gerota fascia and the second part of urine, but there was no infiltration. Right ureter identified and results. Proximal transection was done 10 centimeters proximal ICG, and distal transection was proximal 1/3 of transverse, both using tri-ligament stable purple. And reconstruction was side to side Hansen aerotransverse anastomosis, 2 layer, outer pulling 3O and inner vital 3O, both continuous. And on specimen cut section, there was a circumferential ulcer-proliferative growth at cecum and ascending colon of size of 5 centimeters with lumen copper. Rest of all
right branch of the middle colic or no? Would you like to ask these questions to them? Okay, so they have done now side-to-side anastomosis of iliotransverse. Right? 2 layers, outer proline, inner vicryl, both continuous. So in fact, chances of inner side-to-side anastomosis are much less leak compared to the end-to-end anastomosis. So now how do you go about this? This is your information. Now what will you do further?
Send blood investigation simultaneously, hemogram. TLC will be
going down. Hemoglobin has gone down. Platelets have gone down. And TLC also has gone down.
Patient is in sepsis.
So, next.
We'll get to KFT and followed by imaging by contrast and CT scan.
That period is making.
Yes, the creatinine is normal, so we can give IV contrast. Yes.
Right, yeah.
Yes.
You have a CT scan?
Yeah, a snap of one.
That's
So
it.
there is a gross intraperitoneal collections with air fluid, with air extraluminal. So likely it is anastomotic leak, sir. Post-operative for yes, sir. There could be a pneumoperitoneum.
Basically, there is a collection which
Collection.
is showing up. What else you would like to see here?
So is it a localized collection or elsewhere also in the pelvis and subdiaphragmatic lesions?
Collection.
So you look at the number of collection projects.
And vascularity, sir.
Vascularity of what?
Whether the status of middle colic artery, whether it is preserved, right branch of middle colic artery is preserved or not.
So even if it's not there?
So it is prone for anastomotic leak, sir. It is ischemic, the site of anastomosis is in the ischemic segment and it is prone for anastomotic leak. So since there is a cross contamination and it is likely a major leak, we should re-explore the patient after resuscitation and look for the site of leak. And if it is a very minor leak, and if it is
Big area, no? You're saying ischemia, you're suspecting a major leak. Do you really think you'll be able to just take few stitches and come out?
Get a stoma, sir.
Why not do re-anastomosis? Extend your resection, remove the more sections and then do anastomosis.
Patient is in sepsis, sir. Likely the anastomotic might again fail, sir.
Fine, sure. So you will do both.
Section, will you take out the same full anastomosis or will you do a proximal stoma?
Sir, it exactly depends on the type of leak, sir. If it is a massive disruption, dismantle the anastomosis and get it out as a stoma. And if it is a very minor leak, then we can take a chance to repair the site of anastomotic leak and get a proximal stoma.
His question was very clear. He says, will you take out same as a stoma or you'll do a proximal stoma?
We'll check for the viability of the bowel, sir.
Yeah, you're likely to get ischemia now. It's not a healthy bowel if it is not healed. So there's no point in trying to remove the center. You'll again find stoma on the third day again becoming black or ischemic. It's better to do a proximal stoma at this stage.
Moreover, that if your segment, which is itself ischemic, that is one scenario. The other scenario is, even if it is a little larger leak, it is the mesentery at this side, this time is very edematous. So you can just, if it is possible to take some approximation suture and you control this situation by diverting the stoma, which might just prevent the septic complication and then follow whether the healing is.
So the anastomosis is not being disrupted. Is there anything else that can cause this?
From the stable line, sir.
Also look at the steps.
It is common to have stable line giving away because 500 and this suddenly on day.
See, this is a typical ischemic leak. And I asked you this question of right branch of the middle colic now. This is what exactly happens. The patient has been done on the right side. You probably have blocked the right branch of middle colic has been really taken, then that segment becomes ischemic. And that's where is the anastomosis. Therefore, it has leaked. So it's very important to preserve these, you have to that clarity. If I'm going to preserve some portion of the transverse colon on the right side, I must see that the right branch of the middle colic is present because they're all thyroid artery. It's a end kind of an anastomosis, end of a supply. No? So this is where the vascularity understanding becomes very important. And this is a very classical kind of an issue which comes. This is a typical ischemic leak on coming on the third day. This is not a septic leak. This is not probably also technical leak. This is probably an ischemic leak. That's the way you would analyze. Therefore, when you are doing it, you should do proximal stoma rather than the same level stoma. Okay.
For duodenum, sir. Chances of a duodenal injury is high in right hemiparesis.
You look for anastomosis, look for staple lines, duodenal kind of an adherence which was there. If somebody has done with cautery, you could get, but of course that would get little later on the 6th or 7th day. But you could get these ischemic injuries because of the cautery also. And ureter, I think you said it was preserved, but you don't know how it was, whether the cautery was used along with or not. Any other questions anybody has?
So in right hemicolectomies, we usually don't go for diverting stoma, sir. And if the bowel is grossly dilated, then in obstruction, in such patients, we can think of in emergency situation. Sir. So even in emergency settings, when the patient albumin is very less, then instead of going for anastomosis, we can prefer stoma.
Or there may be another situation where you would like to do a stoma. May I respond? Given that you're dealing with
So unresectable case, if it is
maybe resectable, so there may be peritoneal 3 legs, maybe segments. Situation you might have to go with stoma.
So my doubt is about short bowel syndrome of giving hypotonic or isotonic fluids. So I had a discussion with the critical care person in our hospital. They said that we usually give ORS in patients with short bowel syndrome. So because we're thinking that it is a isotonic fluid, but then he said that in ORS it is slightly hypotonic fluid. Basically, it is having a osmolarity of 360 to 370, and our blood has 393 something, 394. So he explained me that because it is hypotonic, then only the water will absorb into the body. Initially, I was of the opinion that it must be isotonic, so I got confused, and I just want to clarify that our answer should be like it is slightly hypotonic because ORS is slightly hypotonic, or it should be isotonic because isotonic it will neither absorb neither.
That's very important, I mean,
Osmolar,
not the tonic.
Yes, sir.
Osmolars, you get absorbed, and everybody prefers isoosmolar. If you give too much of hypotonic fluid, then it will rapidly get emptied out. No, if you really see the gastric emptying time, you have double timing. No, is of early. I mean, for fluids, it is much faster because if you drink a lot of water, it will go because of it's hypotonicity. If you want that fluid to be retained there and get absorbed, then some amount of isosmolarity is needed.
We said ORS and hypoosmolar. It is also that confusion starts from there because these is ORS.
The concept should not be giving free water to absorbent. That is what it means.
Thing like that pre-anesthesia fluid they give nowadays. They give that 50 gram of glucose and give that, and they say that it is much more than the routine our ORS or our sports drink. And then you all talk about osmolality because that really prevents the catabolism. So what we also want to do is to prevent catabolism in these patients. This patient which was there of that was already in catabolism. So we wanted to prevent catabolism in an early phase. Therefore, you want to give an isosmolar fluid. So that's the whole point. Think about this anesthesia.
Sorry, sir, I didn't understand. Okay.
Thank you, sir. Now I call upon Dr. Tarun Yadav, Dr. Biresh Kumar, Dr. Vikas Nehra, and Dr. Sanjam Singh onto the stage. I'll request Dr. Piyush Sahni sir, Dr. TD Yadav sir, and General KG Singh sir to moderate the session. It is a 57-year-old female housewife, mother of one, resident of Kushinagar, UP, and she was presented to us with an incidentally detected HBS surface antigen positive status, and on ultrasound found to have liver as well. During preoperative evaluation for right femur fracture in August 2024. Patient was in a usual state of health till 4 months back when she met with an road traffic accident and had fracture of right femur and accidentally detected as hepatitis B surface antigen positive on preoperative workup. Later, she was referred to SGPGI for her hepatitis B antigen positive status and on workup on ultrasound found to have liver as well. No history of any prodromal symptoms, no history of any jaundice, no history of any fever, abdominal pain or vomiting, no history of any hematopoiesis, melena, postal dizziness, syncope, fatigue, or need for any blood transfusion. No history of any distension of the abdomen or sensorium or reduced urine output. No history of any alcohol consumption, recurring jaundice, previous blood transfusion, high risk sexual behavior or IV drug abuse. No history of any loss of weight or loss of appetite. No history of any respiratory discomfort, hemoptysis, bony pain, back pain or seizure. Past history, no medical comorbidities, no history of any previous surgery. Apart from that right femur fracture, family history not significant, personal history sleep is normal, appetite is normal, she consumes vegetarian diet, bladder and bowel habits are normal and regular, she is non-smoker, does not consume alcohol. Treatment history, she was incidentally found to have hepatitis surface antigen positive status and further evaluated by hepatitis B DNA and was started on tenofovir. On she was found to have liver as well and SGPGI for further time.
Yeah.
Patient is
Possibilities.
The patient is HBS positive with liver as well.
So at least, what do you want to think about? You also know she has liver instrument, she's HBS. She's also 56 years old. She also has a fracture.
We might be dealing with some benign liver disease. Second possibility is primary malignant liver disease, or the third is secondary to liver. Secondary to liver.
So this she has been diagnosed as BSAG positive. So many things has been given. What are the other things which you can think about when patient is incidentally detected as BSAG positive? Is it possible that never had been had any type of jaundice, no history earlier, and suddenly incidentally diagnosed as BSAG positive?
There is no decompensation. Patient can present like this without any decompensation.
So we are not talking about decompensation.
Yes. There is no history of
Jaundice alone is not a suggestion of decompensation of the liver.
HBsAg positive patient can present without jaundice with liver as well. Jaundice is not required or cirrhosis is not required in HBsAg positive patients to have HCC.
So what do you think about the route of infection? He has said there is no blood transfusion, there is no other this thing.
Blood fracture femur was deep.
Fracture femur is now. A child, she's been detected as to have HBsAg positive.
So we should take history about if she has undergone any other previous surgical intervention like childbirth.
He said there is no history of previous surgery.
Has been ruled out. Most of the common causes of transmission have been ruled out in the history. what should be the first thing which should come to your mind? Sir has also said 56-year-old, she is HbA1c positive, there is a fracture femur, there is a lesion in the liver. But the first thing should it be a benign thing, or should you think of something more sinister and then rule out the other things?
Highly probably, sir, it is a
And a very pertinent question, is it for the first time that a patient can present with an HCC with the background of HbA1c without having had episodes of jaundice or something like that?
Yes, sir. 90% of the times presentation is like asymptomatic HbS positive, incidentally detected liver lesion.
90%. Which data suggests 90%? You have to have some sort of. So in what I am thinking, I was also thinking there has to be a route. So we are from UP. So there were so many even in my childhood there were so many people getting repeated injections by the rural practitioners, and they will use the same needle for everybody and just clean the not even clean the needle, not even boil, just clean with the spirit and go on applying the injection. So that maybe I was thinking about that maybe the one of the causes, because it is not possible. Or the husband. So we should know about the husband. Husband may be the partner who is responsible for the spread. What is the average time to be taken for the patient with suppose some exposure to the HbSAg? We have some this virus and then be positive, and then is developing malignancy. So that's why it's a long history, no? So we have to think about all those things which can happen, because it's not possible. There has to be some route by which this come. And there is, as you said, there is no decompensation. So how is it possible that what is the sequence in
Integrated the closed of the cells genome, and then it can cause. Actually, there are two mechanisms of HbA infection and causing HCC. One is by integration into human genome and causing subsequent DNA changes in HCC. Second one is causing chronic inflammation leading to cirrhosis and HCC.
So that is important that in HbSAg positive patient. So why did you say that first possibility may be benign as well? We must be having something in mind.
In this scenario, I feel in an exam, the first thing should be a HbSAg related malignancy with a fracture femur, maybe metastatic. That should be the first thing with an age also. And then obviously you keep benign conditions also in your mind. Perforce, you should not, hemangioma being the commonest, I don't think that should be brought here as a possibility given the historical background. Can the patient be non-cirrhotic and have the HCC, HbSAg non-cirrhotic, HCC and met to the femur with fracture?
Yes, sir, it can also happen.
So what percentage is that?
Because of integration into the genome, that can also happen.
Yes. So I'm also not sure of the percentage, but a small percentage can be non-cirrhotic HbSAg with HCC and met.
So mostly we are not talking about metastatic SCC, but SCC in HbSAg positive, mostly it is without preceding cirrhosis. So commoner is without preceding, less commoner is following the same sequence as integration of the genomes and then following the same sequence and presenting as a SCC. Sir?
What is the importance of tenofovir? Is it protective? Does it reduce the incidence of malignancy? And what are the other implications subsequently in the management of this patient?
In the postoperative period, we can start the tenofovir to decrease the chance. There are studies that shows that it can decrease the chances of recurrence.
Is there any relation with the viral DNA load? When should you be operating on the patient? Is it protective to the surgeon, knowing the load? Will it affect your management of the case?
The viral load is, if there is a negative viral load, then risk of transmission is increased. So it is protected. We should do the HBV DNA viral load in every patient pre-operative.
At what level usually antiviral is started? Do you want to do core also, or you are happy with the only surface?
The core and incision also usually.
When you are going for surgical thing, then all these things are important. And we have to know the HBV DNA level, because every patient who is positive, asymptomatic patient might not require antiviral. So once you start antiviral, then how many months or weeks you wait for the surgical intervention if required?
So 3 to 6 months, we consider that it can come, viral load become very low.
But 6 months is very long period for malignancy.
3 months.
So how will you proceed in this patient?
Examination.
Look for specific things.
Look for any signs of CLD failure and BMI of the patient. So parallel jaundice.
BMI.
The general condition complete.
So if it is
BMI is
show
then
if the patient is obese along with the HbA1c positive, it leads to the increased risk of HCC as compared to
hepatosplenomegaly and
I think you should go sequentially. General examination is very important. Start off with parallel interest.
lymphadenopathy. Specifically, I want to look at hepatosplenomegaly. Otherwise, I will look for all the general examination.
BMI is very important.
So here's the examination in front of you.
She is conscious, cooperative, oriented to time, place, in person. Her BMI is 17.3 with weight of 40 and height of 1.53 meter. ECOG status is 0. Breath holding time is 30 seconds. No pallor, no interest, no cyanosis, clubbing, lymphadenopathy or edema. No peripheral signs of CLD. Vitals are BP 110/70, pulse rate is 76 per minute, respiratory rate 16. She is safe to drive. On per abdominal examination, on inspection of abdominal flat, umbilicus is central position and inverted. All products are moving corresponding with respiration. No visible scar mark. Any visible peristaltic sinuses or unblocked veins. Hernial appear normal. Bilateral inner appear normal. On palpation, abdomen is soft, not tender. No palpable lump or organopathy. Hernial orifices are no palpable in pulse. On percussion, liver dullness can be appreciated in the 6th intercostal space in the right midclavicular line. Liver span is 12 centimeter. 12 centimeter. Planks are tympanic. On auscultation, normal pulse sounds are heard. On declavicular exam, normal symptoms plus student colic stool. No palpable growth or palpable. Systemic examination is essentially normal.
So has the examination helped you in any way?
The liver span is slightly in the lower range. It's 12 centimeter. So that there is some shrinkage on the liver. Suspecting that there is some cirrhotic component is there. Otherwise, it's
overall the examination is very normal.
So BMI is 17. So what does it mean?
low loss of
Is it favorable or not?
the thing is favorable in the sense that patient is not having obesity with respect to the liver for non-cholestatic, but because she is low having
So for this BMI, the size of the liver might be normal because if the liver is not cholestatic, because the BMI is less, so the liver will not be fatty. So the size of the liver for this BMI may be normal.
So for the nutrition assessment in this patient, is it are there other general physical examination factors which can be seen when there is a BMI of 17?
Yes. So, back thickness, triceps, mid-arm circumference, and shoulder contouring.
Any bedside
Prominent bony.
So bedside, sir, there are various tests. Subjective global assessment can be done. 6-minute walk test can be done.
What we see in 6-minute walk test?
Sir, we will ask the patient to walk for 6 minutes and we will calculate the amount of distance he has traveled in 6 minutes, which should be essentially between 500 to 700 meters for a normal person.
Without any difficulty and taking a run.
So if all these things are normal, so that 17 BMI, is it a happy thing? Suppose you do a 6-minute test.
Still, we have to for the nutrition score 2000 do that. We have to, though patient is not having any weight loss and critical condition, any history, but still BMI is a one factor that is nutritionally maybe patient is having low insulin levels in the investigation.
Intake, any relation of
Yes, sir. Food intake, if it is patient is having less 75%, 50%, accordingly we have to grade the nutrition score. And sir, but in history there is no loss of appetite, so it may be the normal.
So build a mind with that. So in a Eastern UP, there may be people built like that in the small build since childhood. So BMI, that's why sir was asking in an earlier case, BMI alone is not a very good clinical parameter to suggest anybody's nutritional status. So that's why all these things parameters are important. So let's proceed. What are the things you want to say?
This was associated with weight loss.
Can be somebody who hasn't spoken.
So we'll get a complete hemogram and the liver function test.
Why do you want a hemogram?
So look for the nutritional status. We'll know the hemoglobin.
Hemogram gives nutrition status.
The hemoglobin, CBC.
CBC.
The complete blood count
Does
will
total leukocyte count or differential count give you the nutritional status?
You are listening.
Difficult.
Yes, you are listening. Your colleagues talking to so many things.
Get into
Yeah.
Getting into difficulty. Status can't be assessed on a hemogram. I can look for anemia on hemogram. I can look for a hemoglobin value and look for a platelet. So nutritional status assessment on a hemogram is difficult. It's a challenge.
On the liver function test.
So why do you want to do a hemogram? You want to look at the hemoglobin to look for anemia?
Yes.
And
what else?
Then sir, platelet count is very important in hemogram.
Why is platelet count important in hemogram?
If it is associated with liver cirrhosis, then there might be hypersplenism and there might be decrease in platelet count. That might be indirect evidence.
So you can frame your statement by saying that there is a suggestion of portal hypertension rather than this.
What is the reason for low platelets in CLD?
Portal hypertension leading to splenomegaly, leading to the congestion platelets in the spleen, and then it can be because of liver.
What is that called?
Sequestration of platelets.
Hypersplenism. What are the criteria for hypersplenism?
Just at the case was
done. And what are the other reasons?
Liver pathology also lead to low platelet count.
Why is that?
Cirrhosis lead to low platelet.
Why does CLD cause not because of portal hypertension and why does the
I don't forget the pathogenesis, but cirrhosis also lead to low platelet.
So just check on that. Why is the platelet fall? Because platelets are not manufactured by the liver.
So indirectly there is some pathogenesis that leads to.
Generally CLD will have a low platelet count. Just check the reason.
Second here, we are going to look at the coagulation profiles, PT, INR, and APDT. SICs with the normal rhythms. And liver function test, RFT and PFP and QCAR. LFTs and KFTs are most of the values are in normal limits. Albumin levels are also normal in the previous slide. So there is no evidence of this.
Why KFT?
For and for renal function test, because we have to do any imaging, so we need a creatinine. Also, with creatinine level also, that if it is very low, then BMI will correlate less muscle mass.
Any other reason for deranged renal function tests? In this,
hepatorenal syndrome also can be, but there is no decompensation, so we are not suspecting.
what about
AFPs within normal limits, we also like to look for PIVCA. CA19 is also known.
So they haven't done a PIVCA.
What is PIVCA?
PIVCA is what? Why you have to say the PIVCA level?
Also, tumor markers for SCC cell and the prognostic marker. If it is high PIVCA level, then it is a bad prognostic marker.
What is that PIVCA?
Induced by vitamin K deficiency.
So that is indirect marker, but many times what percent of the people have normal AFP and still they can have SCC?
Percentage. Sensitivity of AFP is 50 to 60%, and specificity of AFP is 60 to 70%, and PIVCA specificity is 80 to 90%.
Yes. So that's why both should be done, and even if you are suspecting, because basically we are depending upon radiology and these markers to reach to the diagnosis, rather than doing any little test or something like that.
so which of these markers?
Yeah.
AFP is for tumor growth, size of the tumor. The larger the size of the tumor and metastasis, the more is the AFP. But PIVCA, sir, is mainly it's related to cirrhosis, also associated with the lesion.
In diagnostic, in
Which of these tumor markers form a part of the diagnosis?
alpha fetoprotein forms the part of diagnosis of radiological with raised alpha fetoprotein more than 200 on single modality imaging with characteristic enhancement and early washout on arterial and venous phase forms the diagnostic criteria for HCC.
So as per the definition, they do not form a part of the diagnosis.
If it is more than 500, then sir, it is a very bad prognostic marker, and with the high recurrence rate even after the good surgical procedure. But sir, for diagnosis, it has shown that in European and American guidelines, both have include AFP levels, one more than 200 and other more than 400 for the diagnosis, along with one imaging which has shown the specific features of HCC.
Having said that, it's not essential. Characteristic imaging findings are enough to label a patient as HCC.
HPV DNA is 27.
So is it before starting tenofovir or it is before? So that is also very important. So we should know that it has been. Okay. So what other things you want?
I also like to do a USG abdomen, sir, because the USG abdomen which was provided before did not have the complete information about the size of the liver, the contour of the liver, whether ascites was present or not, any other lesions were present or not, the size of the lesion which was present or any other sites of.
Why not portal and splenic vein? All those things associated. Ultrasound can even show you collaterals in that area. A good ultrasonologist can show you polypary collateral in the hepatoduodenal ligament and toward the hilum. Then when you are telling all these things, even whether there is a thrombus in the portal vein or not, this is also can be seen on ultrasound. No, that we have to do. But ultrasound, if suppose ultrasound suggests something very gross, which is suggestive that this patient is not going to benefit from anything, then why would do CT scan? So good ultrasound is always required. And this patient had a fracture, as Dr. was saying. We don't know whether it's a pathological fracture also. So we have to see, and PIVCA has not been done. So we don't know whether this particular SCC has gone beyond the liver or it is because of some incidentally detected thing.
Somebody wanted an ultrasound, you got the ultrasound. Ultrasound shows liver is normal size, lobulated outline with heterogeneous and coarse echo texture. Relatively well-defined hypertrophic lesion is seen in the left lobe, measuring 16 into 25 millimeter. no IHBR, mean proton is 12.8 mm, spleen is 13.6 centimeter. On orbital layers blood with microneal cystine, wall thickness is normal, CVD is normal, no site is rest within.
So please tell the inference of the.
Is it still possible that the patient is not cirrhotic?
There are features of cirrhosis in the appearance is there is a ghost echo texture, so which may point to like cirrhosis.
So how frequently can that be a false positive finding on ultrasound? Coarse echo texture and relation to cirrhosis.
Exactly don't know, but 80 to 90% is very sensitive for determining the technical texture of the liver on ultrasound.
So I'm sorry to disagree with you on that. I asked my head of radiology in my previous institution, what is this significance of your writing in ecotexture, coarse ecotexture on ultrasound? So he said, in a particular clinical context, it may mean something, but otherwise it means nothing.
Absolutely.
So that's the head of radiology at the Institute of Medical Sciences, and not very far away.
And the other thing.
So 80-90% is something that I'm sorry I disagree with.
The other thing you were mentioning is the clinical assessment of the size. So here, this is a very sensitive parameter on ultrasound. It reports it as normal. The span, 11.85 centimeters. What is the implication of finding stones with, say, cirrhosis? Gallstones with cirrhosis.
Incidental.
Is the incidence more, less, same? And does it alter? Suppose there was no lesion and you did it for suspicion of HBsAg, so you would advise an ultrasound. There was no lesion, you found stones in the gallbladder. What is the implication?
It's an incidental diagnosis more direct relationship with HBsAg.
Two questions. Is the incidence more or less or same? And would your management for the gallstones change? There is no HCC or any other lesion as well. What would you advise the patient? Vis-a-vis another patient with gallstones or sludge and no cirrhosis.
In cirrhotic patients, if the patient is symptomatic, we will see for the child status of the patient, and based on that, if the surgical morbidity is less for the patient, if he or she is child A, and if he or he is symptomatic, then we will go for the lap polycystectomy in this case. But if it is B or C, then based on the if the severity of the disease, we will change our decision. But mostly for C, we will not be operating the patient, and for B, we will discuss.
Early can be
Early after discussing with the family pros and the.
I thought what he was asking you was, you picked up a stone and you have cirrhosis versus you have no cirrhosis. That means asymptomatic. So is your approach going to be different?
For asymptomatic cases, approach will not change, but with respect to the CTP score, it will change.
Okay, so we got this ultrasound. What do we do next? This is prior to the fracture. Is that right? At the time of the fracture. Okay. At the time when she was detected to have HBsAg positive. Okay, so now what do we do?
CT scan. Triple phase CEC, whole abdomen, chest, and thymus.
With what in mind?
So upper GI endoscopy for any varices or any ectopic varices, portal hypertension, gastropathy, or CECT to stage the disease and diagnose the disease.
So what's the chance that with a normal ultrasound, no evidence of varices around the GE junction, no splenomegaly, no ascites, that you find varices?
The portal vein was dilated, it is more than 1 centimeter.
Okay.
And also there is a, though it is written as normal, but less than 12 centimeter I will consider as
small size liver. Also, so I would like to do, sir.
What is the prerequisite for varices to form?
Sir, more than 10 mmHg of total weight.
Of portal pressure.
HVPG, hepatic venous pressure gradient, when it is more than 10 mmHg, the portosystemic collaterals will open up. It will lead to the formation of the varices around the junction.
So let's look at the apogee endoscopy and then we'll go to the CT. So unexpected lines. Okay. Shall we look at the CT?
CT.
So saying stage, I'm not sure if I'm still not sure looking at an HCC. Are you sure?
No, sir, I diagnostic and then
So if it is, so before you start saying stage, I have to say stage at least twice, if not 3 times. Before you start saying you want to stage the disease, first want to make a diagnosis.
Do you want an NCCT?
Yes, sir. So to look for any
Calcifications.
and artifacts, if it is there.
What in mind? What diagnosis in mind?
Sorry?
With what diagnosis in mind? What pathological diagnosis in mind? Calcification in HCC?
No, sir.
NCCT.
Elsewhere in the aorta there can be calcification 64-year female. There can be calcification in aorta.
64, 56.
You are looking at an NCCT in this patient to look for calcification in the aorta.
In this particular patient, we are looking for any collection ascites to rule out and this
Collection. So many years ago, let me tell you this to just emphasize it. Many years ago at meetings such as this, Dr. Puneet Dhar said it's not important what you say as long as everybody understands. I disagree with you. If you use the right words, they will sound familiar to the examiner and the examiner will keep sleeping. It's the truth. If you say odd things like collection, now where the hell did this collection come from? I am wide awake. So I was sleeping, I wasn't saying anything to you, I wasn't bothering you. No, why do you wake me up? Please don't do it. Not in an exam. Do it anywhere else. They want to pass the exam, they don't want to pass the exam. They don't want to pass the exam, keep waking me up, no problem. Not wake me up, wake all the other examiners up also.
Some lesions.
So I think it's extremely important to use words, use phrases that you're familiar with, that fit into the clinical scenario. Anything that you say which doesn't fit into the clinical scenario, I'm joking when I'm saying examiners are asleep. The examiners are listening to familiar things. This is what I wish to listen to, and this is what I think should be happening. So if you say ascites, it looks familiar to me. It sounds okay in this scenario. You say collection, it doesn't. Okay. So calcification. We sorted the calcification. Sorry, I digressed from the calcification. So we still need to sort out the calcification.
Some lesions can still present with calcification, though in not case, but biliary cystadenoma, if we are suspecting that it can show calcifications in the lesion, but not for this case.
Classically, which lesion is present with calcification? Hydrated. It can be one, and you still have benign conditions on your mind. So that is there. Any other? Cystadenomas can be there. Anything with a scar, central scar?
Yes, sir.
FNH can be there.
When you this can produce lot of calcifications. Much more than intrahepatic cholangio sometimes might be having. But is it possible that intrahepatic cholangio can be present in a setting of hepatitis?
So it can mixed form of intrahepatic with HCC mixed, Palm can present like. Please read. This is a non-contrast enhanced axial scan showing non-contrast axial scans showing lung and abdominal fields. On lung field, there is no pleural effusion, no calcification, no nodule. In abdominal field, liver margins appears regular. There is hypotensive lesion in this left lobe, but I will like to confirm that on.
It's again what's the if you plane a scan, you cannot have hypotension or so same thing comes again.
Like to comment.
Say that I would like to see the
Contrast. There is no ascites, no calcification.
Should have seen the femur also.
I was hoping to see the femur.
It was showing in the lower cuts. I wish you had said that also, given the history.
So is that something with the fracture femur done? No, nothing done. It was fixed. So why are you so keen on looking at the fracture femur?
So to rule out whether it was a pathological fracture or
yeah, so it's a good idea to look at the femur because you might find some large lytic lesion there. I couldn't see anything there.
So this is the arterial phase of the CT scan and axial sections. The chest appears grossly normal. The liver shows, the left lobe of liver shows a hyperintense lesion.
Here you are using long term
Enhancing. There is no ascites.
But you have to put the vessels when you are taking arterial picture. To go so this artery looks to be normal, this artery looks to be normal. You have to say that otherwise that's why you are using arterial key.
Yes.
Approximate size, location, which segment, what vessel.
Okay.
Phases have been discussed earlier. Arterial phase, how early yesterday.
I'd like to see the arterial anatomy of the liver, the branches of the common hepatic and cerebral.
Could you see in this?
Arterial branches are away from the lesion.
left hepatic artery is transversing close to the lesion below scleral.
So what are you interested in specifically here?
So any anomaly or arterial anomaly?
A, anomaly, B, location or relationship to the tumor size or whatever lesion it is. So I'm interested in what?
So both
Right and left?
Yes, sir. So, because in this case we will be preserving the right hepatic artery. So we will
right I'm going to preserve, so that's I'm interested in. What else am I going to preserve?
right portal.
If I end up resecting, I'm not saying I'm ending up resecting, but if I end up resecting.
Right portal veins are right hepatic artery. Then
So in the arterial phase,
middle hepatic vein relation the
in the arterial phase, medial phase. We're looking at the arterial phase. We're going to look at the right hepatic artery. What else do we want to look at?
So the region of the left hepatic artery, whether it is accessory or replaced left hepatic artery.
Is it? All right. No, then.
Any right hepatic branch from the left hepatic artery.
Segment 4 branch, from where the segment 4 branch is coming, whether it is coming from a left hepatic artery or a right hepatic artery.
Okay, all right. What else?
3 right hepatic artery from SMA.
Okay, what else? I'm not interested in the hepatic artery itself.
From the left gastric. In a scenario of cirrhosis with this lesion, and it turns out to be an HCC, a transplant center might offer a liver. This level looks good now. Yeah. In which case you need to understand the entire anatomy very well.
Type of anatomy and
Spleen is okay. Are we okay with the spleen? Shall we move it to the venous phase? Size, okay. Should move on to the venous phase? Yes, no.
Splenomegaly is present, sir, because it can be seen in the cuts of the kidney also, the left kidney, because it is going.
Yeah, so mildly enlarged splenomegaly is present. Anything else? Move on to the other phase.
This is the portal venous phase. The axial scans are there, and the main portal venous. So in the portal venous phase, there is washout of the mild washout the lesion in the left lobe, and
Where is this lesion, in the left lobe or where is this?
sir, in the segment 2, 3, and if there is low down, please go low down. I'd like to see the 4 segments. So not in the 4, mainly in the set 2 and 3.
So you have to say, but since you are saying this, there is the principal, we are saying the left portal vein in entering the dividing, and the lesion is the left to the side area. See in this area.
So there is no portal vein thrombosis I can see, and also the anatomy, there is no left portal vein thrombosis, not in main portal vein, and sir, mild
Implication, left portal vein thrombosis are the same findings.
so portal vein thrombosis is a upgradation of the grading and leading to ruling out the transplant and the resection. If at present, but with the downstaging we can do, but right now for if there is portal vein thrombosis, then
okay. So,
but if main portal vein is free of thrombus, then still the transplant can be done, but not for the segment of the portal vein which is involved to rule out the transplant, whether the portal vein can be reconstructed or not.
Affect the prognosis.
So delayed venous phase. Is the delayed venous phase axial scans, and there is a complete, not complete, but there is more washout of the lesion, and suggestive of HCC, because it is in hyperenhancing in the arterial phase and washout in the delayed and the portal venous phase, suggestive of better cerebral carcinoma. And there is no portal vein thrombosis, and there is no decompensation of the liver.
You have seen two in
looking like it doesn't seem to be. It is not. So you have to look at the quadrant lobe is also seems to be. Then first yes, sir, but classical picture, even if in non-cirrhotic with the background of HB-SG, it can be said that if it is. Otherwise, it is. Yes, sir. Then we can consider other fibrolamellar type and other types of.
What is the reason for this? These features which you said, why has this happened?
So because of arterial branching, because of arterial supply of the lesion, there is a hyperenhancement in the early arterial phase and not in arterial, but arterial phase, and because there is no portal venous branch supplied to the tumor, then it washes out.
Arterioportal shunting, neovascularization of the new arteries. That is these are the common reasons for early pickup by the tumor and washout in the portal venous and the venous phase.
Stiffness is
slightly on the higher side, 9.3. Generally, the cutoff for 6.
So why did you do a fibroscan?
We didn't ask for fibroscan.
So ignore it then. Don't look at it. So what do you want to do?
We have to characterize the stage of the SCC. It is going in, there is no portal vein thrombosis. There is a
So what do you want to do? PET CT?
no,
Resection.
no.
In that case, resection of the tumors, the liver, the
No, you wanted to stage the disease, no?
That we have staged the disease.
You now said that I want to stage the disease.
We will look at the CT thorax and CT pelvis also.
So you want to do an HRCT of chest and we ignored that. We wanted to ignore that, so we ignored it.
Why do you not want a PET CT? Vehemently against.
That AFP is normal. PIVCA, we don't know the PIVCA. AFP is normal. There is no decompensation. So
cystic lesion. Cystic lesion.
Yeah. Please tell me. Yeah. Yes.
Yeah, there's something there as well.
We have to see on the arterial face if it is enhancing or not by desynthesis.
Okay, so if you had done a
That's a clear cut CA. So still because of the primary lesion is very good enhancement is there in the arterial phase. If it is similar enhancement, then we can characterize it.
We can go to arterial phase.
Segment 6.
That looks cystic.
One more. Yes, cystic. Just. So there is branching of that the arterial branch that is.
Too small to characterize on a CT. Doing an MR may be a reasonable option.
but should be mentioned, not missed out. If the background was erotic, then it can be a regenerative. Then at least two imaging modalities, especially if it is
Okay, presuming that the MR doesn't suggest the person, the second lesion, what do you do?
So we will go for the resection of the disease. The patient is compensated, the LFTs are normal. We will go for the formal left hepatectomy with the MHP preservation.
Anything you want to do before that?
Why left segment? Why
Lateral
lateral
segmental section. Left lateral section taken with done, yes. But first I like to see for the port. Yes.
Why left hepatectomy?
Left lateral section, sir. Segment 2, sorry. Sorry.
Difference in the bone. You want to do any functional assessment? You are doing left lateral.
For left lateral, there is no need for volumetry.
That's why it's very important to say like that because it is away from the segment protection. The bifurcation is the hepatic vein. It's not involving the segment corridor. It is away from them.
Sir, I would like to discuss this in MDT. There are two options because the size is the more than 2 centimeter. So if the guideline says if it is less than 2 centimeter and there is no decompensation, then we can easily resect the lesion. But if it is the size of more than 2 centimeter and within Milan's criteria, then there is a guideline that it can be transplant can be the better option for these lesions to decrease the chance of recurrence. So I'd like to keep it in a multidisciplinary team meeting and discuss with the patient both the options and then take the decision according to the patient.
So here in this patient, liver is absolutely there is no worries, there is nothing.
Yes.
So should this patient go for transplant?
Service.
Yes, sir, because
integration The strictures because of ischemia mature over a period of 6 months. So
how does this matter? You are not concerned about this stricture now. You have decided to bypass it.
Extent, sometimes it may look normal, it can be stricture can
Let's increase that. If it is a healthy mucosa that you have seen during dilatation, do you expect this to again further stricture? If it is a raw mucosa, then obviously, it healing and all those things would come. But 4 months is a long enough time.
This is a acid in the
Picture starting at 22 centimeter. Will you classify what kind of picture is there? Other words, is it a high type of picture or low type?
low type. It's a low corrosive structure.
Type structure, if the proximal mucosa is healthy, then probably even 4 months, if the patient is okay, you can take up that stuff philosophy behind. Conventional teaching is yes, you wait for 6 months. It is not take those act of 6 months. You have to further qualify whether what kind of stricture are you dealing with. If the stricture was at what is high stricture?
Within 2 centimeters of the critical balance.
Then centimeters from the critical balance. How do you further classify high stricture?
Another question is 5 types are there, sir. Type 1 is the scope is still possible beyond. Type 2 is scope not possible beyond. Type 3 has a SGE. Type 4 is a stricture, but there is 5 centimeters of cervical esophagus distal to it. And the cervical esophagus is patent, it's a point stricture. Type 4.
What are the implications of it?
Type 4, we can reconstruct that structure's part, then we may be able to do the coloplasty to the cervical esophagus so that we can avoid aspiration. If it's not possible, then we may have to do a pharyngopolic anastomosis with the intracheal spleen. Quality of life may not be good for the patients.
How will you manage that structure? Like what kind of structural plasty are you talking about? Or nowadays, is there something else which can be done in such patients?
Balloon dilatation can be attempted, sir.
Yeah. So earlier it was like the short picture, they said that you can do a flapiture or something, but however, if you can pass a guide wire, you can use the balloon dilatation. Before that, high strictures, what is the conventional classification? Some strictures may think that it is not to be attempted at all. So how do you classify high strictures? Based upon the glottic, is there any classification?
Yes, sir. Subglottic, supraglottic, and hypopharynx. At the pyriform.
Yeah, if the pyriform or whether the pyriform is available, whether it is going, and what is important in high strictures, in addition to the level of the strictures, what else is there in high strictures?
If there is associated injury with the epiglottis also we have to see. And
Signing. Basically, in such strictures, high strictures, you need to have a ENT evaluation, and the posterior signing case should be live first to reassess the level of the stricture. Probably because of that, you might not be able to reach the upper esophageal sphincter.
So in this case, I agree with you that you might have to wait for 6 months, not for the reasons of the disease progressing, but for nutritional consequences. And what will you plan now in this situation?
Sir, colonic pull through, esophagocoloplasty.
What will you do?
Native esophagus, sir, it will be left in situ. Because if it is left in situ, there is a chance of formation of mucosal and also malignancy after 20, 40 years malignancy. And if you dissect, there is increased risk of injuries to the adjacent structures, thoracic duct. Now, difficult.
Usually the mucosa gets damaged, sir. Chances planning no if you know side to side esophageal anastomosis, chance of
no chance.
There's no chance of
No chance.
If the stomach is already intact, in that form, that you will know by the waiting in the thorax itself. Chances of mucosal occurs higher if the native esophagus is left behind and you are taking a gastric pull-up. When you are planning a non-pull-up and the stomach is in situ and in continuity, then chances of mucosal are less.
Yes.
The problem is the other way around, that if you leave behind, there is chances, but that is also very less of malignancy.
So in this, will you leave the stomach behind?
Intraoperatively, we will assess, sir. Intraoperatively, if stomach looks healthy, then we may retain the stomach. I'll retain the stomach. CCT only we can assess with the CCT. That was remote.
That validation was done,
but no,
that time you can inquire with the endoscopy. You are planning for that, you should inquire that endoscopy.
Secondly, can contrast gastric who's image the stomach. And I like that.
if possible, if the stomach is also available and the colon is also available, which one would you prefer?
The mobility.
Please not an issue. Stomach is available. Not in this case, I'm just talking about it.
Since it is a low stricture, I would prefer stomach, sir. Stomach. If it is a high stricture, then I may go with the colon. If it's a low stricture, then stomach, I'll do with the stomach.
That reason. How can you length of stomach tube, gastric tube, but in the then you take intraoperatively
Cauterization of the tube.
Anything you do by preparing the tube.
tubularizing the.
Go along the greater convention and take a smaller size stipple and I am looking below.
So you tubularize the stomach. And at times, the even the area of the stomach near the fundus, they around 2/3 of the greater curvature can be transected and tube taken up as another tube, the reverse gastric part of the thing to increase the length of axis.
Stomach is single anastomosis.
Advantage is it is a single anastomosis. Single anastomosis. Vascular supply is good. Technically simpler. Then redundancy is less. That is more with the colon. Disadvantage is reflux. Not get the question.
Bile reflux.
Bile reflux.
Goal of fibro. What goals and cons of fibrometry?
The pyroplasty can result in
Dilatation or pyroplasty, but there's so many things. It says that it is really confusing.
pyroplasty can be done, or pyroplasty can be done, or intraoperatively you can just dilate the pylorus with the Foley's also can be done.
How will you dilate?
Um,
How will we pass the dilator?
We generally do not correlate with the pyroplastic artery in CS areas versus in corrosive. In corrosive, if you have this pylorus, you have to assess whether there is a associated pyloric stricture is there or not. Then what will you do?
if pyloric structure is having, then we will not use stomach.
Even if you have used stomach, then what will you do?
Gastric. I think then gastric.
We have to add a drainage procedure.
Gastric.
What is asking is that in a normal gastric, because we have a debate of doing or not doing gastric. Yeah. But if I do that for throat structure, definitely add a asking of some sort of that position. Is that right? Same way, people lives in the body. Uncommon that we will be scars are very it starts somewhere in the beginning of the plants. And we can be having a lot of related of it, not having a problem of that.
Yeah, I was talking about the hypothetical situation and stuff. I suppose in this case, I don't think it would be.
Colon is advantageous. If you take the left colon, it will be the lumen will be matching, sir, and increased length even up to length can be increased in colon, and vascularity is also robust in colon. And
Which vessel plays
with vessel-based nutrient?
sir, for the left colon, we can use the ascending branch of left colon and use it like a isoperistaltic. If that length is not adequate, you can take middle colic and you can use it like an antiperistaltic. See, commonly the ascending branch of left colic is used. Right colon also can be used, but the lumen, the cecum is bulky and mismatch is there.
High chances of redundancy. Very much vascular.
Suppose you have taken up this thing. Full discoloration of the blood, what will you? There is not adequate, there is ischemia there. I'm also suggesting of ischemia there. So,
then we have to look for any as the pathway we have to see sir, if there is twist in the pathway we are taking through the retrosternal routes, and we have to see we may have to take up the sternum on the left side of the sternocleidomastoid head. Sometimes that can also cause compression.
you have seen, you might have witnessed the cervical vein. What was that? Usually you ask executives to oxygen here. You can
increase 100% oxygen, reassess the colon for how the pulsations are there or not. And if pulsations are there, then maybe it's a twist as we brought it up the when we pull up the colon, and then
What else can cause? Yeah.
Narrowing at
narrowing at the
manubrium.
inlet, thoracic inlet. You can remove the manubrium. The
Sternal mastoid, claviculitis, clavicular.
So even doing that, it's not okay. You check the weight. So
The thing is fine now.
ICG we can.
ICG confirms that it is ischemia.
Then we may have to change plans.
Use it right side, we can
If you have left side.
We take another full.
No, can there be any other technique which can be used to salvage this segment?
Supercharge. Supercharge.
Can use the some critical pain for the venous thing, and you can use one of the trees. So that can be tried if you have other trees. Otherwise, you'll have to take it down. Any other questions you want to ask?
Sir, for isolated gastric injury and isolated esophageal corrosive injury, how long wait ideally? Like if there is isolated gastric injury, how long we should wait for further reconstruction? Both 3 months or
Depends on the lesion. At least I think 6 weeks you will wait and you will take the help of PPN and all, and earlier you can take question.
Basically, sir, that you were teaching here that in stomach, if you have a gastric stomach injury isolated, if your patient comes, when you wait for stomach, it is standardly earlier said that for 3 months, and for esophagus, anything is 6 months. What's to wait before you plan the definitive treatment in these patients? It's like a question to find the result.
But it's not too late because we don't know whether the scarring will extend. Gastric outlet obstruction, by and large, had a surgical treatment only. Now we have some bit of endoscopy, but by and large, that is out of the window. Most scenarios, we have surgical treatment only. We are waiting for the structure to stabilize before saying I do a GJ now. Right? That is, I think the Jipper means 6 months. That period is very short. We don't know where the number came from. Some people say 3 months. So that is the broad figure, 3 to 6 months to stabilize. For esophagus, we will try the endoscopic treatment first. And that might take from anywhere from 3 months to 2 years, depending on what bottom line you say for saying that this is the endoscopic failure. So there is no timeline. The endoscopy is based on several criteria, whether you say multiple dilatation is required, whether quality of life, whether poor nutrition status, whether multiple length of stricture, whether tight stricture. All those criteria will take their own timeline to decide whether this is the endoscopic failure. In esophagus, endoscopic failure is the indication of surgery. What is failure is something to define. There are broad guidelines, but there is not very specifically what is long length stricture, what is multiple stricture, what is multiple dilatation. There are some criteria, but there are very cast in stone. Last guidelines with guidelines.
Don't hand over patient very easily.
Yeah.
Combine the ability to go for gastric flow. But some disability is evident that the protein production of the omelet be 80 years, 20 years, 25 years. So, taking a gastric flow will be a quality from gastric exam of the pyrite. So, is it correct with your patient who will go back for the gastric?
No, there's not studies that have been done. We always felt that the stomach was the most worst thing whenever it is available. It is our philosophy to offer the stomach whenever it is healthy and available. without any obstructive symptoms. These patients do well. Subsequently, also for a long time, they don't have any significant problem or distress as such. So I wouldn't be too sure of secondary hepatic gout. And in our own experience, we have seen that all the deaths that have happened after elective surgery for corrosives have been restricted to the group which were colonized. That's because there has been a leak somewhere in the abdomen or at the cologastric site or at the higher level. So you must always keep this in the back of your mind when you are deciding the kind of surgery that you want. Rajneesh?
Well, let's rotation. People say that in lockdown because your stomach is down there, don't go to the stomach. We have some particular better because there are some volume there, so maybe your food is better. Couple colon redundancy in the long term, 10 years down the line, 20 years down the line, and hence symptoms of post-pain. Problem with stomach, as you said, you do the full capacity, so your dietary problem, your request problem start. What we want to say like that, usually is that I'm not the colon, this stomach, they are bad magnet, they are not a bad magnet, it's bad magnet, there is no data. We have only our own experience, and same for university, we all belong to the same, but there are within your serious relative to come as an examiner who say who says stomach is better, and you get very bad. So what I want to tell you is that be aware of positive and negative of both, and be sensitive mood of the person because in any medical center, for example, people who will say, okay, what is a product and I will swear by it. And go to and this issue has not been settled very clearly. Hence, please be pragmatic in assessing what is going on, but be aware of the advantages and disadvantages of both the cases.
Just to add to that, pediatric population, colon is the choice. It's not debating there. Adult population, you can have any stomach.
Yeah, but Richard used to advocate stomach problem all the time. So I'm not too sure that.
True, I agree.
Two questions. So one is in this patient, as I can see that there is a long stricture involving the gastroesophageal junction almost. So stomach might not be available. If there is any stricture in this pylorus part in this patient, and we are planning for colonic pull-up, so should we also plan for decompression of the stomach? That would be not me. Colonic cologastric anastomosis, then gastric. The second is by investigation. The second is, sir, for investigations, because, sir, CT angio we should do for Lupor vessels, or TCT we should say that it is separate, because it comes that so there is confusion in CT angio for vascularity of the colon, but vessels are.
Is actually young. For telling about the young, it is the Western world where the patients are much older, where they propagate CT scan. However, this CT scan is not being propagated in this part of the world. It's only told that you do a colonoscopy or a CT scan. You are planning in case you have a history of any colonic surgery or if there is any diverticulosis history. So all these are the theoretical conditions where mainly you don't recommend CT scan.
Colonoscope. Yes. Yes, sir. Let me. Yes, sir. That's all.
Vision like this, for example,
Yes.
not a laparoscopy.
Okay.
After time, you know, documents what was done.
Yes.
So you would want to know
Vascular. Yes, sir.
and go then my think of assessing the small after before you go for the meters.
Thank you, sir.
Most routinely we don't.
Yeah, routinely
we don't.
That is where the length of the strictures come into play. It is where rarely if you are pushed to do. There those scenarios you don't discuss right now, otherwise you will get more confused. There,
So because now with the it's a rare condition, as rare as malignancy in the structure is already. So I'm saying these are all theoretical purposes. It's fine. Like, practically, you don't really consider that as a.
When you do the CT, that also can give you a clue to what is the status of the obliterated esophagus, what you saw on the variant solver and that. That will also tell you that there's no.
It's likely that it's because I mean, looking at because. Thank you.
Thank you, sir. Now I'll invite Rahul sir and Yash sir to conduct the quiz program. Quiz sir, please. अभी quiz है sir.
So thank you, Sarangi. So I request all the finalists to please come up on the stage and be with the partners, team A, B, C, and D, team 1, 2, and 3, and 4.
So please don't prompt from. I expect कि कोई कुछ नहीं बोलेगा बीच में. Just keep pin drop silence. And so we'll be starting with the quiz. There will be 4 rounds for each team, and we'll announce the rules as per the round progresses. So firstly, for the first round, there will be a visual round. We'll get to see a picture. You'll have to answer the questions. There will be 2 questions, and each question will be carrying 10 marks. So if you answer the first, you'll be allowed to answer the second. And if you fail to answer the first, then the question will be passed to the second team. So for the direct question, you'll get 10 marks for the team who is asked the question first time. And if it is passed on, then it will get half marks. So there is no negative marking. And if the second team also fails to answer, then it will be passed to the third team. So we'll start with team A. So the question, please. So this is a radiopedia round. Oh, sorry. Oh, sorry. So please identify the sign given in the radiology image. This is for team A. Please identify the sign.
Duct is going behind the CPD.
Okay. Duct crossing sign, I'll give you marks for that. The second question, please.
If asymptomatic, no need to do anything. If symptomatic, minor papillotomy.
Very good. So team A gets 20 marks. So it is a most common congenital pancreatic anomaly, and it is duct crossing sign on MRCP. The answer is minor duct sphincterotomy if the patient is symptomatic. Very good. So the next question goes to team B. What is this sign called on ultrasound? And please identify the components as well. Yeah. Identify the components, please. Okay, ABC, it will go. Just let us know. ABC. So it is the other way around. A is artery, B is bile duct, C is portal vein. Okay, I'll give you marks for that. Second question, please. Another location in the body where this sign is seen. Yeah, it can be anywhere in the body. Now what is called femoral triangle mechanism. So be specific about it.
Be specific.
Yeah, be specific. That is what.
Fixing. Like what we pointed out.
So what is this called?
Complete your answer.
Okay. What? Into what? Okay, it is saphenofemoral junction. So I give marks to that. 20 marks to team B as well. So this is the Mickey Mouse sign, the portal vein, the hepatic artery, and the common bile duct or bile duct. So it forms a Mickey Mouse sign on ultrasonography in the liver, and same is seen in the femoral area. That is, the great saphenous vein enters the common femoral vein with superficial femoral artery on the left side. So please, the third question, please give the complete diagnosis. Team C.
Sir, IPM, sir. Main duct IPM.
Main duct IPM. Okay, correct. Next question.
It's not official side being endoscopy.
Okay, fine. So I just wanted the diagnosis. So what is the diagnostic triad and what are its components?
Main duct should be more than 5 mm. And there should be lucinar distal on the papilla in the side being endoscopy. And third, no instead pancreatitis.
What is the triad called? The triad is not completed. 2 points are fine, but third is not correct. Please name the triad. If you name the triad, I'll give you the marks and let you know the third point.
Patulous papilla. There's no communication made by side duct.
No, patulous papilla is fine, but until you name the triad, I'll not give you marks. So 10 marks to team C and the question passes on to team D. Please name the triad. Team A, team B, anybody from the audience? Oh, very good. He gets a chocolate. We'll mark it. He'll definitely give you a chocolate. So, ORC triad. So 10 marks to team C for this round. Very good. So he pointed out the 2 points correctly. It is dilated main pancreatic duct and presence of mucin secretion. The third point is bulging ampulla veter, which is fish mouth sign as well, which we could see easily. So next question, please, to team D. What is this sign called? You have 30 seconds to answer.
Seconds more.
The scorer is Dr. Yashwardhan. So he's keeping track of time. Okay. Team A, can you tell us what is this sign called? Very good. Necklace pearl sign. And then the next question goes to team C or team D only. Please show us this next question. What is the spot diagnosis and what is the ultrasound sign for this disease? Very good, very good. So they get 5 plus 5, that is 10 points. 10 points to team A for this question. Now we'll reverse the flow. So we'll start the next question from team D. This is the operative session. So here's the first question for team D. Identify the instrument.
Pass.
Okay. Team C.
Bone cutter, sir, chisel, bone cutter, bone cutter.
Wrong, please. Team B. Very good. Next question, please, to teams.
Next component to team B, sir.
Name 2 alternative non-crushing metal instruments that can be used for this instead. It is non-crushing, please. Please, team A. Team A. Name 2 alternative non-crushing metal instruments that can be used for this instead. That is for bowel clamping. This D-Martens is used for bowel clamping. So name other 2 non-crushing metal instruments that can be used for bowel clamping. Okay, I think this question started with team D. So 5 marks to team B for this question. 5 marks to please show us the answer. So this is D-Martens Wolfson clamp used for clamping bowels and used in anastomosis when we used to do end-to-end anastomosis. Now staplers are used for this purposes, and it is a very good instrument and it approximates as good as a stapler. Now the 2 other clamps, you see. So the Doyens and pairs, they are actually but D-Martens side it asked for D-Martens. I asked what are the 2 other clamps? Pairs. Yeah, it is for thick structures, but actually what we coccus is definitely a crushing clamp we used on the part which is not anastomose, but pairs can be used on the side which is being anastomose. Okay. If there is a discrepancy, then also we'll give team B 5 points. Dr. Rajnish. So identify the complete procedure. Use to team C. The procedure including both the diagrams. You see both the diagrams and then tell us. Don't say half the procedure, please.
First image in situ perfusion, sir, peripectomy, in situ perfusion. In situ because IBC is intact. And secondly, ex vivo.
It's part of the same procedure.
Components of the same procedure.
Ex vivo, sir. Ex vivo perfusion. Ex vivo dissection.
Oh, wrong, please. Do you want to say something else?
Hypothermic perfusion first is.
Partially.
Can you add to that?
Hypothermic ex vivo.
Nothing is ex vivo. No negative mark. Please repeat.
Just disconnect the IBC. But medically is there.
So please don't restrict the procedure, name the procedure.
Incorrect. Next, venous bypass.
Yes. Along with that,
Venous reconstruction.
what reconstruction? Why venous reconstruction? Team, you want to attempt? I'll not give you marks for half the procedure, please. Team B.
In hypothermic total vascular exclusion into venous bypass.
Correct. So I'll give you mark that. Please the next.
In complex liver lesion involving the hepatic vein.
Taken out the liver, back here, the liver is better here. Put ice pack so that it is hypothermic. And then
So in stage 1, you clamp the IVC, you take the patient on venous bypass and then clamp the IVC. After that, you divide the portal vein and then that is also circulated through the venous bypass. Once that is completely, after that you perfume it with hypothermic solution. Then you comfortably perform the rejection of the malignancy which is involving the hepatic venous complex and the IVC. After that you can reconstruct the vessel and then the liver is removed. So it is in. So there is a minor difference. Plus 5, 10. One. Correct. Complete name of the procedure. Complete name. Distal line related to incident. One last time, you can get one last chance to answer the complete procedure.
Distal weaker
So concentration body being stated is above, but this procedure can be modified Appleby procedure. Modified Appleby.
And yeah, I be carefully and answer. Team C.
Total pancreatomy celiac abscess reconstruction.
Look at the something which has been used over there. Please look at the figure carefully.
Total pancreatomy with joint graft between celiac abscess and
Right. It's not total pancreatomy, but what that posterior words. Team B. That's your final answer. Well, not accept that. Anybody would give an audience. Taking other than see instruction. Defining the procedure, name of the procedure. So, what does because you have because with the common hepatic beyond the TA, you have to leave that.
Modified FLP was the same term.
Actually, modified heartbeat was used when you preserve the stomach. In conventional Appleby, stomach was sacrificed. In modified Appleby, we preserve the stomach and the left gastric axis. In supercharged, when the GD axis is also sacrificed, you supercharge it with the graft. And so this is one wrong. So first question targeted to team it. If you answer correct without the hint, you get 20 points. If you answer by using the hint, you get 10 points. Incorrect answer, no negative points. And maximum number of attempts to answer the question is 1. I am strict about it. Identify this living area. Contributions to neoplasm of the pancreas. Okay. But chief gets for HPBA and the guidelines are also going to be revised. Yeah.
Point. Incorrect. Important. And
Dr. Davis.
correct answer. Indeed.
American surgeon and current activities are created and keep our cancer and cancer.
William R. Janagan. Correct. 10 marks after that.
We start with EP now.
Right. We'll ask her. Okay. Hint. Hint.
Finally, and was that this one possibly employed? EP and partner. But then, it's not there, given. Team that way. Team G. The team G though. Team G. I go with the
Sir, Professor Anand Narayan. Anand Narayan. Anand Krishna Narayan.
Yes. Professor American, you are to be a country, and even to IBS as the duty of institutes of agency. And we in the history of an individual to picture setting.
What do you Oh, you.
One pending question we'll ask later.
So, you know, Dr. Thomas E. Starr. What does E stand for?
So we try to ask the question by the end of the third round of fourth round. Ask your question. Same from your. Okay. At the end of the fourth, we will ask your question.
Anybody from the audience?
Thomas Earl Stazel. So I was audible otherwise as well. Thomas Earl Stazel, E-A-R-L, Earl Stazel. So what are the scores?
At the end of round 2, Team A is at 30, Team B is at 45, Team C is at 30, and Team D is at 20 marks.
Is closing. Now we go to the GI general knowledge round, that is round 3. So again we start with the rules. Please show us the rules. So correct answer without clues, 20 points. Correct answer after the first clue, it will be 10 points. Correct answer after the second clue, it will be 5 points. And each time you will get just one attempt. And if you don't answer, no passing. If you answer wrong, no negative marks. यहाँ का डिस्प्ले चला गया प्लीज. Is visible there? यहाँ देख लीजिए. So you can just have a look on that side, please. So the question to Team A. This famous Bollywood actor died in the recent past due to which GI disease? So you get just one chance to answer it correctly. Please, I don't accept that question. You didn't want the clue. So anybody from the audience?
NED? NED?
सर आपको चॉकलेट सही नहीं है. Okay, ठीक है, that's the right answer. Are on the line. ठीक है. So Team B, this famous Bollywood actor underwent a surgery for which GI disease in 2005?
Think an answer, no incorrect answer, you can use clues.
No, 2005 is not previously. 2005 is 10 years back, 20 years back. I am not asking for the history, please.
Yeah.
You have 10 more seconds probably. You can use the clue. Clue 1, please.
Portrait of the images.
So you can correlate the images and find out the answer. See, there is a tire punctured. There is incorrect. So there is no passing. Anybody from the
Articular perforation. Nerves.
articular perforation?
Complete the dots. Option 2. And it's a small bowel barium series. So it's a small bowel diverticulum, which is the question.
In a small bowel barium series, there is sawtooth appearance and there is a puncture there, so that shows perforation. So the next question to Team C. Carefully.
And fun fact, there's flagellant description of that, which is that small bowel dilatation consists of the gastric pain, abdominal discomfort, and lateral time as a postprandial.
So, Team C, this famous Marvel superhero died in 2020 due to which GI disease?
Clue, sir.
Clue 1. Correlate the images. There are one is the sign which is up, which appears in that disease.
Complete diagnosis.
Specific and be answer it at once.
There's one more clue which you can use, but don't be hasty.
Second clue. So this disease is commonly seen in this syndrome.
Both the clues.
Sir, cowden disease related malignancy or colonic malignancy due to cowden disease.
Syndrome is not, but you diagnosed it right at CA colon.
It is CA colon.
And it's Gardner syndrome. Osteoma.
And it was paper napkin effect, which can be seen on barium in those diseases. So they get 5 marks, 5. They have used both the clues. Team C5. So Team D, this French emperor died after an exacerbation of ingestion of large dose of
Clue.
Linitis plastica. Linitis plastica.
Diagnosis, please.
Gastric.
It's fine. Listen, it is leather bottle. The scores after team third round.
Second clue.
Top gear.
Top gear trial is for CS stomach. Top gear trial is for CS stomach.
End of round 3, team A is at 30 marks, team B is at 45, team
So we can start with the, please help us out, Yash. Please. So team A, CA pancreas in body, CA pancreas in body and tail is more malignant and aggressive than that in head. True or false? Wrong. Recipient IVC is replaced by donor IVC in piggyback technique of dead donor liver transplantation. Recipient IVC is replaced by donor IVC in piggyback technique of DDLT. Correct. So anastomotic leak is less common following thoracic. Correct. Cowden's disease is a hereditary hematomatous polyp. Correct. Half-life of carcinoembryonic antigen. Wrong. It is 7 to 14 days. Recurrent painless PI. So we had 7 questions. 2 wrong, 1 wrong and right. Always pass the question. I'll come to that question again. Don't waste time on the question. Operation is for short bowel syndrome. Caudate lobe mainly drains into left hepatic vein. Incorrect. Hepatorenal syndrome type 1 is more aggressive than type 2. How many months prior to clinical examination radiology? Wrong, it is 6 to 9 months. KEHR sign is for KEHR sign, KEHR. Incorrect. In past classification for fistula in ano, type 2 is correct. In living donor liver transplantation, the last anastomosis is correct. What is ETA trial? So time up. I think they attempted 9 questions and 6 were correct, 3 were incorrect. So 30 points to team B. No, 6 were correct. There were 3 wrongs and 6 correct. Okay, the 9th question they didn't answer. So points for team B. Team C, most common gastric lymphoma is B cell type. Pathogenic liver abscess is acute appendicitis or anatomical angiogen. Correct. According to Chandra's classification for portal biliopathy, what type is involvement of intrahepatic bile ducts alone?
Type 3.
Wrong. Sunburst sign in CT scan is a classical feature of which type of pancreatic cyst?
SCL.
Correct. Please, full form.
Serocystic neoplasm.
According to Borman classification of CS stomach, linitis plastica is which type of tumor? Correct. When should antibiotic prophylaxis be administered for a clean contaminated surgery?
Within 2 hours without surgery.
Incorrect. It is 30 to 60 minutes. 2 hours pull up next. So there were 8 questions which were asked. 2 were incorrect and 6 were correct. Don't waste time on your questions, please. So cutting ceton is the treatment of choice for perianal Crohn's disease. Correct. Zenker's diverticulum is a traction diverticulum. Correct. Catalonic trypsin antigen PRSS1 of associated with chronic pancreatitis is autosomal dominant. Incorrect. Alpha angle in TEG, thromboelastography, denotes fibrin cross-linking. TEG, thromboelastogram में alpha angle denotes fibrin cross-linking. Incorrect. Familial adenomatous polyposis is related to which chromosome? Correct. Pancreatic siphon is a problem following which shunt surgery? Correct. Goliger classification is described for what? Goliger classification. Wrong. According to Hassler column modification of Duke's classification for colorectal carcinoma, what is B1 as per TNM? What is B1 as per TNM in modified Duke's classification? Various needle used for. There were 8 questions asked and 4 were correct. Okay. So they get 20 points. Yes, sir.
But one last question is pending.
One question is pending for team A. In coach. Oh, very good. So they get 20 points. 20 points for team A. Huh? नहीं एक्स्ट्रा सिंपल टीके चट्टोपाध्याय सर भी थे है ना पी जगन्नाथ सर भी थे एवरीबॉडी वाज एक्स्ट्रा सिंपल ऐसे अगर कोई टीके चट्टोपाध्याय सर को नहीं पहचानता है तो बहुत गलत बात है बिकॉज ही यूज्ड टू कम इन ऑल द कॉन्फ्रेंसेस व्हिच वाज IASG and you have read that book day in and day out. Every day you read that book, and for all the recent advances, you definitely refer to that book in GI surgery. And if you don't recognize T.K. Chattopadhyay sir, then how can you say that these questions are wrong or not? This is very bad. So please don't question the quiz master. So we have come up with the scores, and it was a tough round, tough fight. So the 4th prize goes to team D, that is with 50 points. The 3rd position is with team C with 65 points. Team B scores 70 points and scores the 2nd position. And team A scores 75 points and they have won the quiz. Very good. Then 5 points. So congratulations. It is all luck. It was Kush का हाथ गलत चल गया इसलिए उनको lucky point मिल गया. But I don't know whether they might have recognized Dr. P. Jagannath as well. So we have, so I request Dr. Anu to please come up on the stage and present a cash prize for team A. Team A, please. Naam dena please. So first prize goes to SPG Praveen Kumar from IIT Hyderabad. Ma'am, please come up. Thank you. The first prize goes to Dr. Lavina and Dr. Praveen. This is a cash prize of 5,000 to each winner. A big round of applause for the winners, please. Second prize to team B. I invite Dr. Rajneesh on the stage to please give away the second prize. What's his name? So second prize goes to Dr. Ashirvad Panda from Bhubaneswar and Dr. K. Prashant from SGPGIMS. And this includes a cash prize of 3,000 rupees to each of them. A big round of applause. They fought well, but they were unfortunate in the end. Yeah. No. We have a consolation prize for the team, third team and the fourth team. So I request Dr. KJ Singh to please come up for the consolation prize. And we have chocolates for them. So, so team who scored the third highest points, please come up, please. So it is Dr. Yajnadar Sarangi from SGPGI, and your name please? Dr. Praveen. So congratulations. And this team who scored the fourth position, please come up. Dr. Anup and Dr. Ruchir. Correct. So, and chocolates for the audience who could answer the question correctly. No, I know who has answered the question. Thank you, sir. Very. I have one for Payal. So if we have time, I can ask few more questions. If we have time. Open house for anybody. Last chance to win chocolates. So you know all about Edmonton criteria for islet cell transplantation. Can you let me know where Edmonton is? In which country? So you will not get the. You already got the chocolate. You already got the chocolate. So somebody else also answered from behind. Okay, Anirudh. Anirudh, please come up. Please, please. Come on the stage. Jaldi आओ jaldi. तो chocolates खत्म हो गया time खत्म हो गया. So Dr. Eric Muhe, a German surgeon, performed the first laparoscopic cholecystectomy in which year?
1987. 87.
85. 85 for the second.
Who said 85?
85.
85. You already got the chocolate. 85. So hey, जिसको chocolate मिला है उसको chance नहीं मिलेगा. So no, Viris needle was first used for. I have not finished the question yet. For pleural tapping, it was not pneumothorax, it was pleural tapping. But can you let me know what was Dr. Viris himself? Wrong. Wrong. Wrong.
Physician.
So nobody. He was an intensivist. Anesthetist. Okay. Hello. I didn't hear. I'm sorry. Okay, please come up. Please come up. Please come up. Please come up. Please. I'm sorry, I couldn't hear. What's your name? So he's also Rahul. So the last question. Where was Viris from? Where did he hail from? Viris. Viris कहाँ के थे? Wrong. Na? You don't hear that country's name in GI surgery, but it is in Europe. Toronto is not in Europe yet. Please, I'll take your chocolate back. Anybody? Huh? Who said that? Huh? Okay. No, cheating is not allowed. Cheating is not allowed. Please. So I'll not give you marks. He was from Hungary, but he published his paper in Germany, and then people came to know about varus natal. He used to treat tuberculosis patients, and to prevent injury to the thorax while tapping, he started using varus natal. It was not for pneumothorax, it was actually for pleural effusion. So I asked about Thomas E. Starzl. He is a person who started with organ transplantation, and because of whom it is so flourishing. And can anybody tell me to which university does he belong to? Oh, very good, please. Upar aaye. That's great. What's it? So the last chocolate goes to Dr. Prasoon. Thank you very much. I hand over the further proceedings to Dr. Sarangi. Please carry on.
Thank you, sir, for the interesting round. Now the next round is next session is about surgical specimen and operative procedure. I'll call upon the stage Dr. T.D. Yadav, sir, Professor Piyush Sahni, sir, and Dr. Mohammad Ibrahim, sir, to moderate the session. I'll request Honorable Bihari ma'am and Supriya Sharma ma'am to moderate the session, please. Now I request Dr. Yes sir to present the specimens.
Good evening, everyone, esteemed faculty and dear delegates. I hope the quiz was a fun learning experience. For this last session for the CME, we have 20 spotters which include operative specimens and intraoperative photos. So for each spotter, we have added 4 questions just to start the discussion.
This round, if you can all come a little closer, because all of you can participate in this. So if you are spread out, it is a bit difficult. They can all come closer and sit. Half of you can be this side and half of you, and we'll keep alternating between the two sides.
I'll start, ma. Yeah.
Some of the SGPG residents come this side, please. Some of the SGPG residents come this side. All of you on that side. And if सारे बता दो भाई, it's not has to be distributed. Okay.
35-year-old lady presents with recurrent episodes of diarrhea with blood and stools. We performed this surgery and took out the specimen. So first is identify the specimen.
So who wants to answer?
Total correctness.
So what would be the 2 most likely indications for the surgery?
Bleeding, toxic megacolon. Oh, sorry.
Identify the specimens.
So is it proctocolectomy or colectomy? Colectomy. Total colectomy. Not proctocolectomy. Not proctocolectomy. Why? Rectum is not distal. Sure.
Would you see the mesorectum if it was at this configuration?
You won't be able to figure out the result. It's an organ stress. It will be very difficult to bleed. So that's the reason why you think, but you should be able to identify the specimen. If I gave you the specimen, you should be able to tell me whether it's a proctocolectomy or a tonocolectomy. This is tonocolectomy. Most likely diagnosis.
You see
Ulcerative
acute,
colitis.
acute severe, ASUC.
Acute severe. Could this be, so the indication could be for what? Acute severe ulcerative
ASUC.
Yeah.
Toxic colon bleeding.
Toxic colon, you expect the colon to be a little more distended. It could be any other indication. So a massive lower GI bleed could be another possible indication. What surgical procedure is likely to follow?
Completion productomy with ileal and pouch anastomosis.
Ileal pouch anastomosis.
Ileal.
With a diabetic anastomy. Why? You can do one without a diabetic anastomy. Why with the stage procedure? People have described two-stage procedure. What is the difference between outcome between two-stage procedure? Three stages. Two-stage procedure has high risk of leak and high risk. Then why do people report large series with two-stage procedures? So most people would do a three-stage procedure, and the reason for a three-stage procedure would be you don't want any pelvic sepsis. Why don't you want pelvic sepsis? Pouch failure is a higher incidence of pouch failure, and a higher incidence of pouch failure means your outcomes are not good. But there are reports of good risk patients who've had two-stage procedures with equally good outcomes. So it's not possible, it's not a no. It is an alternative procedure that you can. Okay, shall we go to the next slide?
Yes, sir. Identify the specimen, name the operative procedure.
Abdominoperineal resection.
Why do you say the specimen is that of?
So we don't go that side now. You had a lot of answers from this side, so we don't go that side.
Abdominoperineal resection specimen.
Describe what you're saying.
There's an ulceroproliferative growth in the lower rectum. Mostly involve extending around 2 to 3 centimeter above the anal walls.
This is a tubular structure with the growth at the lower rectum, lower part of the specimen with anal skin present. It's most likely it's a abdominoperineal resection with lower rectal tumor.
Second question. Let's answer the second question. How do you assess adequacy?
So there is a scoring for mesorectal mesorectum and the defect in the bowel. If there is a less than 5 mm depth of tear in the mesorectum, more than 5 mm or more than 1 centimeter, or there is perforated specimen. So this is how we grade the histopathological specimen.
Essentially, your assessment of completeness is by assessing the mesorectum. Whether the mesorectum has been removed completely and intact.
Intact.
So complications
won't go.
In wound dehiscence, when you're shown a specimen, then I think it is better to say what are the specific complications related to the procedure. Wound infection,
Perineal hernia. So perineal hernia, autonomic nerve.
Okay. One chemotherapeutic regime commonly in this disease for folks. Okay. Shall we for folks?
Identify the specimen.
The distal pancreatectomy with splenectomy.
So why do you do this procedure? Sorry. Okay, so tumor in the distal end of the pancreas. Any other reason? Okay, so location is important. What is the location? It's in the tail of the pancreas. That's why you need distal or maybe in the at the body tail junction. Okay. What are the different surgical approaches that you use? Okay. What does RAMS stand for? So modified and modular. Modular. Why is it modular? What is modular about it?
One by one.
So what do you understand by the word module? The modular comes from a module. Yeah, so you can take it out as an entity. That's like a module, you know. So I teach you a module in a curriculum, and it's one whole part that gets taught. So something similar is what is meant by the module, and it's not definitely not modified. Okay. Okay. Two complications. Fistula and hemorrhage. Okay. Postoperative. How many have seen NOPSI? How many of you have seen NOPSI? How many of you have seen NOPSI? One OPSI seen, one more OPSI seen. And these are all people with 10, 12, 15 years of experience, nobody with 3 years of experience. So I've seen two OPSI. Two in what, 35 years. So it's not something that's seen commonly. You read about it a lot in books, but it's not seen very commonly. What is specific about OPSI? What is full form?
Overwhelming post-splenectomy.
Overwhelming post-splenectomy?
Infection.
Infection. Okay, so what's peculiar about it? So you can get overwhelming infection because anything.
Very small penetration. Within 24 hours, patient will.
So something else. Capsulated organs. Okay.
Describe the specimen.
So that clock timer doesn't seem to be moving to my mind. So look at the giveaway hint at serial number 4. So nobody wants to describe this person.
Specimen where we can see longitudinal aspect, and there is a ridge-like circumferential thing, likely the G junction, and some of the proximal gastric. That can be seen.
It is so kind of picture.
Mid-esophageal stricture is the description of the specimen.
With the most likely neoadjuvant during today's at the distal part, most likely proximal part of the stomach, and two specific indicators with
Okay. Most likely diagnosed. Lower esophagus, mid-esophagus. Do you take out a specimen of the esophagus? Have you ever opened it and examined it? No? Have. What happens to it? Shrinks. Becomes very difficult sometimes on a photograph like this to say it's definitely lower or definitely middle. Looks more middle to me than lower, but maybe lower. So why does it shrink? Longitudinal muscles. What happens to longitudinal muscles after you take them out? No blood supply. Yeah, it tends to shrink because of longitudinal muscles. Okay. So what possible reconstructions? Just discuss those. The previous session. So what are the possible reconstructions? Possible reconstructions after this procedure.
The sign is very quiet.
So you can take up the stomach, you can take up the colon, take up the jejunum. So if you want to take up the jejunum, can you take it up to the neck? So jejunum you usually can't take up as a composite loop up. You will have to take it like a flap, like a graft, revascularize the graft. Okay. The giveaway, the answer to the giveaway.
By doing the 3-pill appendectomy and cervical
Usually while removing the lymph nodes around the planet. Okay, that's one place. Any other place? Okay. Thermal injury, if you don't identify where you are, if you're very close to the nerve, you could do that. Neck. All right, shall we move to the next?
Describe the specimen.
Is extended cholecystectomy not radical?
difficult to say on specimen. You have to.
No, I'm not saying about the specimen. I'm saying is extended cholecystectomy not radical?
And we are more than 2 centimeters, not an anatomical infection. If it is anatomical infection,
Is that the correct answer?
But simple cholecystectomy
Yeah. What are the components of a radical resection? But anything, man. One mass together with that may or may not have. So you look at the question, what are the important components or steps of this procedure? Now you're looking at the specimen. So once you do the extended cholecystectomy, so staging lab you're done. So the operative procedure, what are the main components? Does it have to be a wedge or it can be it can be an anatomical? What else can be a part of the procedure? You don't have to do it always, but when would CBD excision be required? Name to complication by the from next.
Describe the specimen.
This part is very quiet. Somebody from there. Variations can be these are only two variations. Someone said pilot setting or pilot specific. What is the classical? The classical. So how much of the gastrectomy is there? This gastrectomy for classical? Yes, how much of the stomach is moved as a part of classical bleeding? Essentially, gastrectomy part of it, which is one of the gastric, is the gastrectomy part of the classical bleeding. How much of the jejunum has to be removed? 10 centimeters. Why 10 centimeters? And 10 centimeters from where? 10 centimeters. Why 10 centimeters? Besides, why someone said 15 centimeters? Why 15 centimeters? There is no place. No. Just the condition. Yes. Without condition. So what is the original classical description? In that, how much jejunum was going to be? The original description of value. Then over a period of time, everyone has added their own things to it. Original description. Original description was 10 to 15 centimeters of the proximal jejunum has to be removed. That time, things were not so streamlined. The section was not so fine-tuned as it is now. But now we understand that if you can preserve the first jejunal vein without damaging it during the process of magnetic protection, you don't have to go beyond the degeneration. You can go to the convenience level. The convenience steps from whether you're doing the jejunal transection on the right side or on the left side. So variations, we have covered that. Indications for the procedure. Same that we have so same. So when you ask for indications, that's just one question. It would be nice to give it as benign malignant. Right? So malignant would encompass all malignancies. Including PD can be done. So benign conditions, so which you would like to do, or you can consider it's doing fine.
Chronic pancreatitis.
You are not sure whether there's a malignancy or it is. Caustic injuries or
Corrugate. Okay, anything else?
Pancreatic trauma.
I'm not sure. Yes. Pancreatitis. Okay. Then
Pancreatic trauma.
The other benign condition was when someone was saying for pancreatic duodenal trauma. Grade by pancreatic duodenal, but goes to a pancreatic duodenectomy in that situation. Postoperative complication. Another discussion I use it, that's just
The next one. Identify the specimen.
the umbilical vein. Okay. So that's a falciform ligament. So the falciform ligament comes out with the hepatectomy specimen. What else comes out of the hepatectomy specimen? Segment 4 comes out with the hepatectomy specimen if your falciform ligament comes out with the hepatectomy specimen. In small cases, probably with left lateral segmentectomy, if you're trying to get a tumor negative area, you might just include the falciform ligament with the hepatectomy specimen. Look at the distance, the amount of liver chunk which is left. One more thing, it is segment 4 more. So one more thing, it is segment 4 plus left lateral segment. So a left hepatectomy specimen. Corded flow, part corded. Which one is corded flow? The protruded part. The protruded part. I also know. So I will accept if you say it is corded, or I would say it is part of the either the lesion things over there. Okay. Most likely indication? One malignancy. Second. Okay. Recurrent pyogenic cholangitis. Any other? Malignancies. So, Palak said complex type 5 stricture. Why will you do a left hepatectomy for a complex type 5 stricture? Complex type 5 stricture, why will you do a left hepatectomy for Parash?
मैंने दो कर ली तो एक नहीं करी मैंने दो. So I think what is important is to remember the common ones first and then look at the rare ones. If you finish with the common ones and you're still asked for some more, then you look for the rare ones. It's unfair to remember only the rare ones. I can understand under pressure you remember only the rare ones. नहीं इम्प्रेस नहीं उस वक्त दिमाग से निकल जाता है रेयर वाली जो किताब में पढ़ी होती है वो याद रहती है जो रोज सवेरे शाम देखते हो वो नहीं है.
Okay, so the last part of this important components of preoperative preparation. When you're doing the left hepatectomy, let's assume for malignant condition. CD. Which group is answering? Who's that on that side? Okay.
Anyone, doesn't matter.
Volumetry. On the right, for left hepatectomy volumetry, then we leave this thing. Okay, volumetry then. Okay. Okay. So please understand, I mean, patient has already undergone a left hepatectomy because the specimen is in front of you. It would have been operated, the vascular anatomy would have been fine or reconstructed. So starting with that does not convey, convey confidence that you know what you're doing. If you ask me, I would like to say that patients' preoperative bilirubin levels, patients' cholecystitis, because all those things are things which you will correct when you take the patient out of the surgery. That's what the patient has ended up with. So, at what level of bilirubin will you be prepared to do a left hepatectomy? Fine. Is there a difference of opinion between doing a right hepatectomy and a left hepatectomy of preoperative bilirubin levels? Yes, please. Yes, please. Why is it different? I'm not debating the levels that we can limit for some other time, but why is conceptually why is it different? Right. But is there anything else you will consider? Suppose you're doing a left hepatectomy for a high bilirubin, assuming that your right lobe will anyway give you sufficient volume. Is there any condition where you think that you will still want to do a preoperative biliary drainage for a left hepatectomy? Why do you do preoperative biliary drainage anyway then for a left hepatectomy? Let's assume this is not cirrhotic. You will not do a left hepatectomy for a cirrhotic. Yes, please. Fine. One. If the liver is compromised for any reason, you take the patient out of surgery. Fine. Then, anatomically, will that positively consider your plan for doing a hepatectomy without preoperative biliary drainage? Volume is okay. Yes. The drainage of the right straight septal duct. If you are going to do a complicated reconstruction after a left hepatectomy, then you would like to correct as many parameters preoperatively as you possibly can. But if you have a single ostium of the right hepatic duct, you might just choose to do a left hepatectomy for a malignancy, even in the presence of a high level. Okay. Next.
Describe the specimen. Describe the specimen.
Entire will and transmission in the whole it's particular areas. And then the transmission so the diagnosis. And PAP. So it's like PAP. I must use the correct. The correct also.
Adenomatous polyposis.
You thought there was a tumor also, I thought. So you've taken out the specimen for tumor, for the polyposis, for both. Both. So part of the description or part of the diagnosis should include the fact that there is a tumor. So I can take the colon out for just polyposis, or I can take the colon out for the polyposis and the tumor. Would there be a difference in the kind of specimen that I will remove?
If you're doing take have to take out entire difficult item or take out lymph nodes.
So usually, yeah, so it's usually a more radical procedure. You take out more of the mesentery, you usually take out most of the omentum, and you won't take out lymph nodes along with it. Well, if you do it for a fat where you don't suspect a malignancy or there's no obvious malignancy, you don't need to do as much. Okay, few differential diagnosis. Okay, how are we going to restore? Okay. If you do an endoileostomy, there's no restoration. Question is techniques available for restoration. What is the next? Oh, we have more. I thought we were done.
So identify and describe the specimen and collaterals, so likely diagnosis. Indications for surgery. Name a few short-term and long-term complications for same.
So you're all mumbling to each other. I can't hear what you're saying. So what are you going to do if you get thrombocytosis? So what is thrombocytosis? Which is
If it is more than 10 lakh of platelets, then we should start on antiplatelet drugs to prevent 10 lakhs of platelets. So to prevent the thrombotic incidence of thrombosis.
Okay.
Sir.
So my hematologist told me 10 lakhs is fine, only if it crosses 11, then it's good.
Sir, I said 10 to 12 lakhs.
So should I do something when it's 7 lakhs, 8 lakhs?
No, sir. Less than 10 lakhs is no indication for starting any antiplatelets. But more than 10 lakhs, there is a chance of thrombosis can be there on long term. So we should start antiplatelets and for long term.
Where do the thrombosis usually occur, if and when they occur? Very rare. But if they occur, where do they occur?
Sir. Deep. DVT. So deep vein thrombosis.
Okay, so deep vein, one place.
Venous thrombosis are mainly
End of the splenomegaly. So seems with most indications. So the only indication I heard of taking out this organ was EHPVO. I couldn't hear of anything else. I think there are lots of other indications where you take it out.
So
With lots of collaterals. So the paper published which says that in patients with hepatitis C virus infection who have evidence of hypersplenism, taking out the spleen improves their overall outcome. From this country. वो याद रह जाएगा इनको और कुछ नहीं याद रहेगा. Short-term complications, you remove the spleen today, you go on around day after. Pancreatic fistula, okay, any other fistula? So acute gastric dilatation, what else?
Pleural effusion,
Okay,
bleeding,
any other fistula? Gastroduodenal, duodenum में कहाँ पहुँच गए यार? ये कौन सी स्प्लीन निकाली duodenum में जाके? Gastric fistula I can understand, yes. Gastric fistula I can understand. Any other fistula? Colonic fistula. So gastric, stomach, colon, pancreas. All three are possible. Okay. Do you have more pictures?
Identify the procedure being performed.
What you're seeing on the left is the head end, and what you're seeing on the right is. Can you identify a few structures that you're seeing and why? So when I say identify a few structures, don't say LPG. What structures are you seeing?
So opened up bowel, which bowel? Stomach, duodenum? Jejunum. It's jejunum, it's not the ileum. It's very obviously the jejunum, not the ileum. Okay. If you see the ileum there, you'd be worried now.
And what is it? Proximal structure. So this is the jejunum and the almost equally wide structure next to it. Is it just the pancreatic head cord? What is that long thing along the jejunum? So the most apparent thing. Omentum, where is the omentum?
So a patient who has stones, with chronic pancreatitis, a stone in the head and in the body and tail, what would you do? Just core? So open up the rest of the duct also, and then. So I can't identify the pancreatic duct intraoperatively.
And then.
Okay, so I'm doing a blind head coring, that means. Anything else, anything simpler? Anything which will make my heart beat a little slower? Palpate, no stone felt, can't be sure where it is. Put in a needle, what you get is not clear fluid, what you get is drops of blood. What next? Intra ultrasound, you put in a needle, they say put in a needle here, you will get fluid. You put in a needle again, you get blood. Where should I split the pancreas? At the neck? Bang at the neck so that posteriorly I open it up and make it open like that? No. So the initial description of a lateral pancreatic jejunostomy, was mobilize the tail of the pancreas, chop off the tail of the guillotine it off, open the duct from there and then completely open.
Alright, this modification called initially it used to be called fuse, where we must have cutting solution.
Next, this you can see this on top. This is the bed after resection, and you see some arteries. Okay, I'll move on to the next picture. Basically, this was supposed to be a segment 4B5 resection, but how do you identify the lines of transaction during surgery? So you have to identify two lines, a vertical line and a horizontal line. So how do you identify those two lines? So how do you identify that line? So that is a blind. So that is a blind. How do you mark the liver? You have an ultrasound. You can see the MHV. You mark it. If you don't have an ultrasound, so for this procedure, why do you want to go back to the IVC and dissect everything there? This is a segment 4B5 resection. So you're identifying two lines, a vertical and a horizontal line. So how do you identify those lines during transaction? It's not.
Looks more like more than a 4B5.
But I think photo का okay, so identify this step performed during a Whipple's procedure. This is a pancreatic vaginostomy. You can just name a few variations. So you see the pancreas here and the lobe jejunum attached.
So the long-term complications. It's explaining insufficiency, consequence of the pancreatic appendectomy. It's consequence of the disease process first. Combination of the what silver it's explained insufficiency of consequence of pancreatic appendectomy. Then it's the long-term complication that occurs. So stenosis of the pancreatic vaginostomy, which means that it makes a bad insufficiency. Depending on whether the thing is actually disease related or it was not disease related. Any other long-term complication of pancreatic vaginostomy? Huh? Long-term? External pancreatic. I don't know. Okay, to the exhibit endocrine pain. Anything else? Panic with prostate strictures.
Identify this maneuver. Hanging maneuver. How do you check for intra-bile leak? So you have echolangiogram.
Okay. What else can you do? Air, propofol, what else?
Okay. Under cholangiograms. All your diet has come under cholangiograms. Besides that, that is one form of prevention. Besides that, yes. So when you do ICT, how will you do it?
Big clamp first, and inject first.
Exactly, he's asking the questions. Open में कैसे करेंगे?
Handheld camera.
Huh?
We have a handheld camera.
You have a hand. Do you have a handheld camera?
We have a
Yes. So that answer this question. Open में कैसे करेंगे? And I, right? So the question is, how do you identify intraoperative bile leaks?
So we close the session? Or do you want to continue?
So this is the last. So
we're getting no responses from you. There's no enthusiasm. Yeah, so that's why I said. Show the previous picture if you want to show them this picture so that we can actually make out where all the arrows are. Now you want to look at the labeled picture?
Show the label picture.
Yeah. A line joining the loop of Henle and the origin of middle colic. And like one side to the right of SMB and the left border of SMA.
Okay, good. Thank you.
Thank you. Thank you.
Anybody has questions? Radical or extended, madam? Radical or extended?
And so an extension policy. Say you asked this question for me. T1A simple cholecystectomy. Remember, extended cholecystectomy for a fundal tumor on the even backside with no infiltration of the liver, a 2 centimeter wedge with lymphadenectomy. Is it radical? It's radical. Why is it not radical? I've said lymphadenectomy. So extend. So that is why. So I'm saying don't get caught up in these words. Okay. So extended cholecystectomy, when you say so, en masse resection of the gallbladder with either a 2 centimeter wedge or a 4B5 with standard lymphadenectomy, that we can have a discussion about with or without a DST. That is the, so don't get caught up in this. Yeah. Yeah.
I feel that might be slightly different from a screen, but what do for beyond the all us know about the you can create then also beyond that, it means either right interest being or But most of the one, in the rotating arm is more random than it's going to be required a rate. I don't know the same level, but trust me, there is no single place in the direction is the way to find it.
And that does not make extended cholecystectomy non-radical. Is the point that I would want you to. You can have more extended resections, and you can have an extended right hepatectomy. That is also radical, but an extended cholecystectomy is also a radical thing.
Okay, good.
I also have the opinion that radical cholecystectomy should not be, simple cholecystectomy should not be considered as a radical surgery for CAGB, whether it be TIAS or T1, because radical word started way back when it included all the organs involved along with the lymph nodes. It was the type of majority of the tumors. So, but after that, modifications came in radical surgeries, like modified neck dissection, that is modified radical neck dissection, modified mastectomy. The radical cholecystectomy came much later. Somehow the concept has crept in that even simple cholecystectomy is radical for CAGB. I don't think it is correct. Yes.
Extended cholecystectomy is not radical.
No, definitely extended cholecystectomy is radical. As Dr. Atish said, extended cholecystectomy is when you go beyond the gallbladder, because for many years, cholecystectomy was the only surgery for CAGB. You'll see old papers, there will be 80% of them will be just cholecystectomy for CAGB. It was all in after 2005, 2006 that we started doing hepatic resections and transplantations started to happen, that we were comfortable in doing 4A, 4B, comfortable in taking a larger weight of the liver. And otherwise, it was all nihilistic approach for CAGB. It used to.
You ask, if you actually look at the literature, the word extended radical very, very confusing. If you want to start analyzing literature and looking at what is extended and what is radical and are the outcomes different, you really can't make out.
Yes.
If you look at the German literature of the 80s and the 90s, you will look at them using the word radical. If you look at the Japanese literature, they tend to use, in those days, they tended to use the word extended. And then when they started doing even further larger resections, they started calling it radical. While the Europeans, Germans, essentially, if you look at their literature, they use the word radical very early on. So to my mind, radicality or extended, essentially, you should understand what you've done. So it's much better to describe the procedure. Say you've done a 2-centimeter wedge, along with an excision of the bile duct, along with a hepatoduodenal lymphadenectomy, or you've not done a lymphadenectomy, or you've not done a bile duct excision. So without sort of, trying too hard to understand what is radical and what is extended, if we do that, it'll become easier to analyze our results across centers. At the moment, it's very difficult.
I agree with you, sir.
No, this is the concept. This is not the name. This is the concept. Because extension, any extent of the cholecystectomy, you're adding removing the cystic plate 1 centimeter, 0.5 centimeter, plus addition of the taking care of the lymph node is the radical. Extended plus taking care of the lymph node. You're not taking care of the lymph node, it could be the extended cholecystectomy, may not be the radical.
So I would much rather describe what we've done so that we can understand what everybody has done, and then we can analyze those results. At the moment, everybody does and writes whatever they wish to write, and then it becomes very difficult to try and get all the literature together to understand what's happening.
I agree with you, sir.
So that is a big problem.
Me will be radical.
And I agree with Rajesh, there'll be lots of people who will say, this is what I mean by extended and this is what I mean by radical. So if you, so what I would prefer to do is not use the word extended and radical, describe the procedure. You're much, much safer. Somebody may push you at that time and say, no, so what is this? Is this an extended cholecystectomy that you're describing to me? Or is this a radical cholecystectomy you're describing to me? And then it's going to be a little difficult to try and say whatever. You'll have to just judge what to do at that particular point.
That will be better to describe.
So I've heard a description where an extended has been described as a 2 centimeter wedge, while a radical has been described as a formal segment 4B5. I've heard that description as well. So I'd much rather you just describe what you're doing. Good. Any other questions? None? Okay, good.
Few words from
that will be radical therapy for
So, the aim of ultimately the entire exercise is to smoothly sail through the exam, however appreciate that may sound. And we request Dr. My Guru and teacher, and I think for all of us, he's been through many exams that you and I have done. Advice, practical approach.
So always try and keep things simple. Ask the question, reply specifically to it. Don't know the answer, say I don't know. It's much better than trying to beat around the bush, confuse the examiner who doesn't get confused but gets irritated. That's not the way to get through. So I was taught by somebody from whom I learned a lot of things, that to pass an exam, you don't need to know. Knowledge and skills are not important. The technique of passing an exam is important. Unfortunately, he didn't teach us the technique of passing the exam. So therefore, I flunked the exam the first time around. And so don't fight with the examiner. I fought with the examiner. I don't know how many of you were there at the IHPBS certificate course at Amrita in Faridabad. I said the same thing there. I was asked to talk on tips and tricks for passing an exam. So I'm probably not the right person to do that. But I flunked my exam because I decided to fight with the examiner. The same thing that somebody was trying to do here, BCLC. And incidentally, I went back and looked at the BCLC and you were wrong. Okay. So you do need something more than just the size to consider transplant as an option. And the reason I went back and checked was otherwise it was stuck in my mind what you'd said. And therefore I decided I needed to correct myself. So I did the same thing after my exam. I fought with the exam. I didn't fight with the examiner. The examiner asked me something. I replied. And the examiner said, no, that's not right. And I said, no, I read it yesterday. I said it in a slightly softer voice. But anyway, we went on, we finished the case. I was sent back to my, to go and have lunch and come back. And I decided to quickly have lunch, but go back to my room and actually read up the book. And then when I came back for my short cases, I told the examiner that I had gone back and read and I was right. So don't do those kind of things. Doesn't pay in the long run or even in the short run. So try and keep things simple, answer what you can. If you can't answer, say I don't know, but too many I don't knows don't work well. So if you ask 10 questions and 8 of them are I don't knows, then that's not a great thing. Always try and, so you're under a bit of stress. Most examiners don't want to fail you. Most examiners are there trying to understand if you have a baseline knowledge, you'll not kill a patient if you're out on your own. And that's the kind of standard they're looking at. And if you can convince them that you're okay, you're not going to make any stupid mistakes and no blunders, they probably won't keep anything against you. Difficulty starts, and I say this again and again, the difficulty starts when you start forgetting some of your basics. You first lead the examiner towards a basic point for which you're unsure. And that's what I say is you start digging your grave. Then you deliberately go and lie down in the grave in front of the examiner. And then you tell the examiner, you request the examiner that please bury me. So then the examiner tries very hard to not bury you, but you insist that you have to bury me. After you do that, and you come out of the exam, you say, I did pretty well. I buried myself. So don't do those kind of things. Never say something that you've never seen being done. Never say something that you've never done yourself. So if you're asked about a particular procedure, which you've never seen being done, and you're asked to describe the procedure, you can start out by saying that I've never done this, I've never seen it being done. I've read it in a textbook and I'll try and explain it as best as I can. That's an honest admission. That's perfectly fine. The examiner might even turn around and say, okay, let this procedure be, let's go on to another procedure. So there's some exam where you're given a slip of paper or multiple slips of paper and asked to choose an operative procedure to describe. You pick up the paper, you read the paper, and you're a little unsure of that procedure. The examiner looks at you and says, are you comfortable? And you don't say, I'm not comfortable. If you say you're comfortable, he or she presumes you're comfortable. Now you start describing and you start making errors. Now the choice was given to you to change. And you could make that choice. Don't hesitate at that point in time. Make the choice, choose a second one. And more often than not, the examiner look at your face and say, okay, you want to describe the first one, you're better off with the first one, go ahead and do it. So, as I said, we're not there to try and, sort of pull you down. We're there to try and understand what you know, what you understand, what you've done, what is your exposure. And if you're okay with that, that's fine. So to my mind, somebody who's worked sincerely on the wards for 3 years, has looked at clinical material carefully, has seen patients and thought about them. So I can see a patient, I can mechanically write down the history, do the examination, make a diagnosis because that's what's written on the OPD card or an investigation sheet or on the CT report or on the MRI. And that's not being honest to yourself. So once in a while you're pressed for time and you do that, but if most of the times you actually looked at whatever you've done a little carefully, and if you haven't understood something, gone back and read about it, preferably the same day, even if it's late at night, 5 minutes. Nowadays, it doesn't take much time. My time, you had to go to a library, you had to open up a book. Now you don't need to, it's all on your mobile phones. You have access to everything. So if you keep doing that on a regular basis, then exam shouldn't be too much of a problem. So those are my pieces of advice. I haven't done too well as far as exams are concerned. I almost failed my first professional. I failed my MS General Surgery first attempt. But that's okay. Life took me wherever it needed to take me. So it doesn't matter. 6 months here and there, don't get too upset.
Thank you very much, sir. And I do not know whether they really, what you said about 6 months here and there is gone, right? That comes after a very, very long time. So, but thank you very much. I hope for you, this whole session and all the work that was put in was useful. We would be happy to get feedback.
from you, and you can give us honest feedback, like what you liked about it, what you didn't like about it. We are happy to hear, because I think we are going to hold this activity on a regular basis, and basically the end users are you. So if you tell us, we will change accordingly. So email to us, send an email. You have an email, the same email can be used. So we'll be happy to have feedback from you, honest feedback about what you felt could be different, we could add, and what you felt was unnecessary. So we'll be happy to hear the feedback from you. And thank you very much for your active participation. I will request Dr. Rajneesh, the organizing secretary for the PG clinics, to say a few words.
Good like this, okay. So I know it's been a long travel for you guys, even though we take pride in the fact we tried our best to host you. But I still appreciate the fact that you come from all corners of the country, and I know it's not easy. But you are young guys, you can manage it. Just a few tips to additions to what Dr. Piyush said. It's good to be prepared for a few things in the exam, apart from, in addition to what Sir already said, which will probably most likely always happen. One, the question about operative procedure to be described. You will have a couple of procedures you'll be very comfortable with. You would have seen them, you would have been very good at them. Be ready with at least 2 or 3. Because you might have an examiner who might say, "Acha, ye bhi tum batao kya karna hai." At that time, don't fumble. Be ready with 2. Sir, ye to main kar sakta. So at that point, don't start fumbling and deciding ki main kya bolunga. Because then you are in trouble. So grab opportunity. That's what he was also pointing to. Grab the opportunity to have that leeway. Yeah, he's offering it to me. Let me take it. Second discussion, because we also examiners, Sir has been my examiner, so I know your papers, or at least your research work, or if not research work, your thesis, your dissertation, whatever you call it, be very, very conversant with it, because it will crop up somewhere in your viva. It should not happen that you've done a study on some kind of a randomized trial, and the examiner asks you, "Acha, batao do arms ke bare mein," and you're fumbling, "Bhai, yaad to karo, kaun se arms the?" That is a very sorry, and it happens, trust me, even despite me saying it, still a few will go, and the examiner says, "Acha, mujhe study ke bare mein batao," yaad kar rahe ho ki study kaun si thi. It happens to you, it happens to consultants going for APS, it happens to us when we are asked for an R1 paper ki usme paper mein tha kya, aapko yaad nahi. And for you guys, I'm very sorry, us samay bada mushkil ho raha hai. Research from literature, that also crops up. Acha, recently kya padha? I mean, this is, honestly, this happens in the exam. Some of this will invariably crop up. Keep a couple of papers ready in your hand, in your mind, that is. Ye maine padhe the. So agar wo puchenge, to mere ko ye bole. Couple of them across the spectrum, a good idea, not that ki sir never ke tayar karke chala gaya, ye chalegi. 3-4 from various ends ki इसके लिए ये बोल सकते हैं, ये मैंने पढ़ा हुआ अच्छे से, इसके बारे में मुझे पता है. So this is just kind of practical, pragmatic advice. It happens all the time, and I still see people fumbling so badly. And the last bit is about your logbook. You may not be asked to submit a logbook, but ये question आते हैं. अच्छा बताओ क्या क्या किया? So either be honest, or you then pick with confidence. ये नहीं कि वहाँ पर आप बोल दो कि मैंने 50 ripples किया हुआ है, then examiner knows कि ये तो गया. So it happens. This is a practical worldly advice. Ultimately, you have to pass. So these few things. So thank you so much, and my esteemed faculty, apart from my own guru, is not here, but I would really was very thankful that they also came all the way. I mean, one must appreciate that they are older than me, and so it takes it's quite a lot of trouble to travel from Hyderabad, Cochin, Vellore, and come all the way here just to teach somebody, which COVID taught us could be done simply online as well. So feedback is useful, and I'm really glad you guys came. Thank you so much. We'll appreciate some candid words of advice for us. You may not call it feedback, because we intend that we would want to carry this on year after year. I think IASG has also told us today that if you are willing, you can carry it on every year for a set of students. We kept it small because we wanted to have one-to-one. That's why we kept it at 40 initially. How many people come here? So what's the point of sitting there? Okay. Is that all? Do we, anything else? My colleagues from my department, Dr. Ashok, Rahul, Ashish, any words of advice, anything you want to speak? Tell them these guys, ultimately it's all body advice. Yes, that's a good idea. That's a very good thing. अगर नहीं भी आता था थ्योरी में, उसको पढ़ के तो चले जाओ यार. वो भी होता है कि एग्जाम थ्योरी में भी नहीं आता था, उसको पढ़ा भी नहीं, एग्जाम में पूछा क्या था, तुम वो तो सिर्फ डीसी पूछा था, मुझे तो आता नहीं. So that becomes funny. Anything, that's a good thing to say. How many of you plan to leave tonight? This is just for us as organizing team, because we want to organize breakfast for you tomorrow morning. So we'll have breakfast in the guest house and then you can leave there after. Or not to you winning guys who are interested. Okay. Please, this is the spot. There's no issue. Please get up and you can speak anything you want. Or if you are shy, you can email it to us. Yes, so the participation certificates and the certificates for the quiz winners will be e-certificates, and we'll email it to you. Give us a little time, so a week's time maybe, and we'll email it to your individual emails which you give to us. Thank you so much. Dinner is served just outside the hall there, so please have dinner and then we can disperse. Thank you so much.
Yes. Yes.
मेरा अच्छा phone anyone left his or her phone here, mobile phone, please check.